All right, welcome back. Chairman Baldwin has passed me the baton. I'll try not to drop it. Let's see, we are continuing on. 22 LSO 147 draft 5 on pharmacy benefit managers. And we will continue with public testimony. Let's start with agencies. Have we got any agencies? Just kind of come up and take up as many seats as you feel comfortable with and.
Bring them back when you're done. So take them, but bring them back when you're done.
Yeah, that's right. Welcome, Commissioner. If you'll just introduce yourself for the populace.
Madam Chair, committee members, my name is Jeff Rue, the Insurance Commissioner. With me is Ms. Burke, our Senior Policy Analyst. We'll be brief. With the new changes, I really do think for some more substantive comments, I want to get back to my agency. I want to give it to the really smart people and have them look. So if I could sort of reserve the right to bring other things up down the road, I think we would like to do that. The biggest concern I have with version 5 is it has no definition of a health plan in it. And I think we need a definition. I think you need a definition involving the public health plan and the private health plan. And as I read the bill now, I don't know if it applies to both or not because it doesn't specify. And our concern is we need them defined so these terms can be limited to this act. I can't have them apply to the rest of our statute. We would literally have to re-review 1,000 different health policies out there to ensure compliance, and we'd rather not do that. So that's our main concern. I also think enforceability is a concern. There's a couple of vague terms in here. We've touched on a couple of them. Certainly the national average drug acquisition cost is something out there, and we're not sure of the dates and what, and how you would look at that and try to enforce an action in some way. A brief comment on the rules that we would be making. There's no way they will be done in time but when this goes into effect. The rules are not getting done that fast. They're just not anymore. We'll do what we can, but it certainly won't be done in time. And my last point really is I just want to be sure nobody's under a misapprehension here. When we in our statutes, we have authority over various things. And when we suspect a violation or when we investigate, we can take action and we can come up with an appropriate fine. And there's rights involved, administrative hearings, all of that sort of thing. But when a fine is imposed and paid, it goes to the state. It doesn't go back to a consumer. And in this case, it would not go back to a PBM. And I just want to be clear on that because I don't want anybody thinking that, we don't have the ability to do that for one. If you want to go in that direction, we would look at it again, but we don't have the ability to cut checks and hold money and bring it out to individuals. And with that, we'll stand for questions. I appreciate the amendments they brought in. They allowed for the money I initially put in for, and we'll see how that goes. And this is something that we talk about nationally. We have a meeting coming up in December that we'll be talking about the national level PBMs and the bills that have come out because they're all a little bit different. So we'd be happy to answer any questions.
Okay. Questions for the commissioner? Senator Hutchings.
Madam Chair, it's not just a question, and I don't know if this is common, but on page 4, they have some definitions. They talk about private and a public benefit plan going on to page 5. So I'm hoping those can be incorporated. Look at those.
Madam Chair, Senator Hutchins. Yes, we'll look at them. We noticed they were pulled out in the staff comment. We appreciate also pulling that up for us too. I did submit briefly with the comments to version 3 that are now posted a definition of a health plan, but it did not include, I think it specifically excluded public because at the time, at the end of the meeting in Casper, there were some discussions of whether we're going to include it or not. I got the impression that we were not going to include public health plans. But certainly it's up to the committee, whichever way you want to go on that. I just want to be sure they're defined and only applicable to the act.
So along those lines, and Commissioner, I'm looking at committee that I did mail out to some while back insurance's recommended changes, and I'm kind of winging it here under, just so that we don't have to haul you up and down too often. There was a suggestion, health benefit plan, and now this excluded the public, but I believe, and I think the committee believes that this should certainly apply to public plans, at least the state and that sort of thing. So if it's, we're to say health benefit plan means a policy, contract, certificate, or agreement entered into, offered, or issued by a healthcare or disability insurer to provide, deliver, arrange for, pay for, or reimburse any of the costs of the healthcare services. Now, then the second sentence, if it just said health benefit plan in this, is it section we want it to say? In this act or section? What does it need to say? Commissioner, is it section you want it to say?
Madam Chair, I think this act.
Oh,
is
in this
fine.
article? In this article, is that what
Article
we're?
would be fine.
Okay, so. All right, so we could start off for the purposes, in this article. Okay, in this article, health benefit plan, blah, 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 and then just say, health benefit plan does not include Medicare, Medicaid, or other health benefit program operated or maintained by the federal government. Would that be acceptable? I mean, we can't govern the feds, but we can govern the state and, you know, municipal things and whatever. Or the one where it says you, in this language you suggested, including those subject to ERISA. So remind me, ERISA, are those all the self-insured plans? So in that, if we put that in, then the bill would not apply to any of mainly like the big box stores and stuff, or what? Flesh that out for me and the committee.
Madam Chair, ERISA would be dealing with the employer plans. And interesting enough, that is what was allowed for regulatory purposes under the Arkansas case that went to court, was the ERISA. There's no mention of anything other than them for Medicaid, Medicare purposes. So where the committee goes with that, whether you want to, what you want to include in the public sector, I'm fine with. I just wanted to find at the end, I just wanted to find here, and the precursor language under definitions would say as used in this act, as LSO had mentioned on page 4, they put that in. And then all the definitions behind that would be strictly applicable to this act.
Okay, let me just, so committee, I'm not putting the amendment now, but while the commissioner's up, we may as well, rather than, bring an amendment and then ask them to stand up again. So going back then, if we insert on page 16, that's somewhere in the definitions. In this article, health benefit plan means a policy. Now, backing up. The language on page 4 from Arkansas specifies all these other things. And I saw somewhere, I'm not seeing it here, dealing with short-term plans, but for now, in this article, health benefit plan means a policy, contract, certificate, or agreement entered into, blah, 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 to provide, deliver, blah, 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 for the cost of the healthcare services. Health benefit plan does not include Medicare, Medicaid, or other health benefit programs or coverages operated or maintained by the federal government. Would that work? In my understanding of the Arkansas, the Rutherford case, I think it was that as long as we didn't delve into plan design, it was okay to do ERISA. My reading. Commissioner?
Madam Chair, I think it works as you proposed. The other way to look at it would be go back to the first part of our statute where it's already already is defined in 26-102 AXXXI.
Hang on, I don't think I have that. Let me, just a minute, I'm gonna have to get my computer fired up here. pull that number right there. Fortunately, I have my
Page
computer with
6
me.
of the statutes.
Is it in the bill already?
Madam Chairman, it's a staff comment.
Oh, but that's not our statute. I thought that was our, oh, wait.
It,
Oh, I see, 26-1. Okay, so that's not, I was confused about borrowing from West Virginia.
Madam Chair, it's what else LSO
But
had
that-
put on page 4.
Yeah, but the thing is that only. The problem is that the paragraph 34, public health benefit plan, means Medicare, Medicaid, or other health benefit programs operated by any governmental entity. And what we're trying to do is separate the feds from the rest of us and apply the bill to state plans, et cetera. I mean, personally, I think, and I think the committee agrees that we don't see the need, we don't want to have this only apply to private businesses and leave the public sector free, as it were. We should all be tied in a knot. What the heck? No. So I think that's, well, we might use what I drafted there as a placeholder. Committee, obviously remember that as everything goes forward, this is our last meeting of the interim, but there's always committee. I mean, it's not like nothing ever gets tidied up in committee hearings. So I think at least if we put that wording in, and I'll just keep it up here on my screen for later, if we insert that, at least we have a placeholder. And if we find a better way to write it later, we can write it later, but at least it's there and we won't forget. And it's much better to do it, if not here in committee, than on the floor. Because you never know what it'll say when it comes off the floor. Okay, and Commissioner, I'll stop talking for a second. I have another question for the Commissioner, but are there any more questions for the Commissioner? Representative Connolly.
Thank you, Madam Chairman. And Commissioner, and this goes with the Wilson Amendment, and to not make you jump up and down, but obviously there was concern last time that the workload for you would increase significantly. And, I'm trying to get my head around the money that's associated with this bill. And to start with, we were simply told that this is just going to help, a handful, honestly, of small pharmacies in the state. And then you came up and said, oh, no, 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 no. This will have a much bigger impact and obligation on us, and we need some personnel. So could you talk a little bit about those obligations and the need for additional staff?
Madam Chair, Representative Connolly, thank you for the question. Yes, depending upon which state I'm talking to, I either think I've done a halfway decent job in coming up with an estimate, or it's woefully inadequate. So at this point, I'm going with what I hope is halfway decent. When I talk with Arkansas, I think I testified in Casper that they came up with a 6-month window where they had 246 complaints in 6 months. Now that's one complaint might have 100 scripts written with it, but they can consider that one complaint. Our entire office for that 6-month period of time did fewer complaints than that in all areas of the insurance industry, P&C, title, car, home, auto, everything. And so that would have a huge impact on us, the workload. When I talk with folks from Oklahoma, and I'm going to talk to more with them in December, they've got exponentially more complaints. And so that's one reason I put in there the ability for us to assess $250,000, because that just sits there. And if I don't need it, I don't use it. That's great. But if I need it, I'm going to have a request for proposal where I can grab people quickly to help us process complaints before I get a staff trained up. I'm probably gonna have to spend some of the money to get a staff trained up. If you ask me right now to apply something to a MAC complaint, I have no idea. We just don't. And so we're going to have to hire people to train us. West Virginia hired a firm to go out and to ensure that there was no spread pricing, because they couldn't do it. They didn't have the expertise. They have 230 people in their department. We have 26. And so we're not going to be able to do that. So, I mean, if we're going to have to ensure, for example, spread pricing is not out there, if there's a concern, we're going to have to hire someone to do that.
Okay, Commissioner, I do have one other question. Going back to and if you have the, my draft amendment, which we're not considering yet, but just again, to save you from jumping up and down. In 26, 22, 502 and 503, in other words, the any willing provider statutes. We had a discussion this morning because it does define pharmaceutical services or products as a healthcare service. And then my amendment, if we do this, would change the word medical to healthcare as far as any group may contract with healthcare services outside of Wyoming, provided that insureds are not restricted from using any Wyoming provider. So my feeling was that that would address the mail order and just the ability of providers, all the providers, to participate in an insurance plan if they wished to, although it does still allow for different incentives and reimbursement. The discussion that we had this morning from the pharmacists was that even though this says pharmaceutical services or products, that the feds don't consider pharmacists providers. So my question is, given that we can't impact what the feds do, but we can impact what people do in the state, is it your interpretation, or and I looked up, and there aren't any rules at all on this bill in the administrative, the Secretary of State stuff, that pharmaceutical services or products you would consider the provider of those to be a pharmacist. And if, assuming that there is rulemaking going forward, if this bill proceeds, is that something that you could clearly state that providers, that pharmacists are the provider that fits under this 26, 22, 502 and 3? Would those amendments give you sufficient rulemaking to just be clear? And if you did do that, then would that apply to? So an insurance company might say, well, we base our definitions off what the feds do. But if we have a state law, any willing provider law, that says pharmacists are providers in this context, does that bind insurance companies in Wyoming then? I mean, it surely must in some way, or what's the point of having a law? But I baffled them.
Madam Chair, I'm concerned with, my impression was that the pharmacists were bringing that issue for reimbursement considerations. And I'm not sure if I have the ability to speak to that on what would happen here. If I think we could put it in rule. What would be the effect of that? I don't think we can dictate statewide what Medicaid and Medicare would pay. I don't think that's out of our
No, and
realm.
what I'm meaning is that if we assume, setting aside the provision of counseling services, which that's kind of what is at play with the Medicare rules and stuff like that, but just the selling of, a Z-Pack for however much it costs, is the pharmacist who sells medication, does that pharmacist selling medication fall under the coverage of the any willing provider law? And if it's a little hazy now, does the language give you sufficient coverage that you could make sure that's so in rule and have it apply to insurers in the state, not for a vague category of counseling, but for the sale of the pharmaceutical product?
Madam Chair, I think at first blush, we can do that. My concern goes back to, we're amending a definition outside of this act. And that always makes me worried a little bit about implications that I'm not aware of. If we were to go to do what you're thinking, it's safer if we put it in the act and define it in the act. So it's limited to this section and it doesn't have any implications outside of the act.
Well, I see what you're saying, but the existing statute of the any willing provider says healthcare services means hospital, medical, surgical, dental, vision, and pharmaceutical services or products. That's
Madam Chair,
already in
no,
law.
Madam Chair, I agree, and I think it reads that way. I don't know what I don't know, and version 5 came quick, and the amendments this morning came quicker, and I hate to commit to what I don't know with 100%
Don't
certainty.
join the crowd. We have a whole
Yes.
group here that doesn't know what we don't know. Okay, so that was a kind of a fuzzy answer, Commissioner. It's kind of unfortunate if we have evidently drafted statute and no one knows what it means or to whom it applies. And it's been in law since 1985. Just
And
saying.
Madam Chair, it has not come up even with the advent of the ACA. We went back, I remember talking about this when I first was hired to look at the ACA for the department, and we looked at this and we never had an issue with it. And so we don't have a lot of historical data to share with you on that.
Okay. Any more questions for the commissioner or Ms. Burke? Okay, thanks. Do we have any other state agencies that wanted to? I saw someone standing up in the back one time. Do we have more agency folks? No. Okay, let's then move to any other. We have sort of a hierarchy of wonderfulness. Any county or municipal type people coming forward, or school districts, or ma'am, come on. Oh, who is that? Oh, Representative Ottman. Did you have a question?
Thank you, Madam Chairman. I just wanted to say Carrie's on from the Wyoming Department of Health. She has her little hand up.
Was that you? Or is she, oh, she's online? Ah, good. Well, we'll just hold, okay. Can you let in the Department of Health? Sorry, you're such a small little square over on the side. Can you let her in? Hello, Carrie?
Hello.
We can't hear you. Oh, there you go. Okay. Hi, Carrie.
Okay. Hi, this is actually Corey Cooper,
Oh, Corey.
the pharmacy program manager with Wyoming Department of Health
Oh, good.
and Medicaid. And I want to thank you for the discussion about excluding Medicaid and Medicare from the statute. I think it's worthwhile so that Medicaid can stay in compliance and continue to receive federal funds for our program and the way we reimburse pharmacies. A large part, because the discussion has already been had, a large part of what I want to contribute today is just a little bit of background on a couple of issues that have come up during discussion. One is the definition or the inclusion of pharmacists as providers. From the federal standpoint, the pharmacist as an individual is not a reimbursable provider, but the pharmacy is. So that would be why pharmaceutical services are included in the definition, much the way that the hospitals are without naming the individual hospital staff that provide services. But the pharmacist or the pharmacy is who we are reimbursing when we reimburse for pharmacy claims in Medicaid. And it's how Medicare looks at it as well. The other issue that hopefully I can provide some clarity on is the NADAC pricing, or National Average Drug Acquisition Cost. It was discussed that this is, the definition lives with CMS. The actual price point lives with CMS as well. They are contracted with a vendor. Right now, that vendor is Myers and Stauffer. And Myers and Stauffer performs a quarterly survey of pharmacies across the country with an attempt to get a good mix of retail, of chain pharmacies and independent pharmacies, of rural versus urban pharmacies, to get a sense of the acquisition costs on drugs. And then they sort of aggregate the results of those surveys. And that's where the NADAC comes from. They only include drugs in that survey that are covered outpatient drugs according to the Medicaid and Medicare definition of covered outpatient drugs. So not all drugs will have a NADAC. And the NADAC is designed much the way the state maximum allowable cost and the federal upper limit are all designed to aggregate costs for a certain class of drugs rather than to be price points individually by NDC. So hopefully that sheds some light on the discussion. I certainly make myself available for questions if anybody has any.
So let me make sure I understand it, because so on page 10, starting in line 10 is where we have the NADAC information. It says no pharmacy benefit manager shall reimburse a pharmacy for a prescription drug or pharmacist service in an amount less than the national average drug acquisition cost for the prescription drug or pharmacy service. So what I understood you to say was that the NADAC is actually a class rather than a specific drug. So in other words, and this is not my area, but that a steroid category or something like that, but so that there might be 3 or 4 specific drugs that have actually really different, $13, $17, $24, and $40. And then there's an average, which is the NADAC. Do I understand that correctly?
Madam Chair, let me clarify a little bit because I was not clear. I get in my pharmacist brain and forget what I know that the average person doesn't know. So what that means is we'll take a common drug as an example, such as lisinopril. So lisinopril is a blood pressure medication. It's been generic for a number of years, and there are several different manufacturers who make lisinopril. And so the NADAC survey and the NADAC price point, the goal of that is to take lisinopril as from all the different manufacturers and all the different NDCs that includes, that are NDCs for lisinopril, and aggregate those into a price point. That is the NADAC price point for lisinopril, rather than a particular NDC that would be from one manufacturer having a NADAC, a different manufacturer's lisinopril having a separate NADAC, and so on and so forth. They're all aggregated into one NADAC price point for all of that particular drug.
And so in that case, and you may not know, but what is the variation among manufacturers of lisinopril, let's just say? I mean, are they pretty much even, or are they maybe varying 20%? Do you know?
Madam Chair, I am afraid I don't know that off the top of my head. I do know that if a pharmacy is reimbursed at a NADAC price point, at least through the Medicaid agency, if that is the price point that we pay off of, and the pharmacy has issue with that and says, I can't find it for that price. There is a mechanism built into the NADAC program at the federal level that they can appeal to the federal government to reevaluate the NADAC price that they have on a particular drug. So rather than appealing to the payer, they would have to appeal if their specific problem is an issue with the NADAC itself, they would appeal to CMS, who sets that NADAC price.
Okay, and so one last question on this before I open it up. So then if the insurance commissioner were enforcing this act and he or his designee is to look up and see if the complaint is valid, how do they look up the NADAC? Is it available on CMS's website or something where you look it up, or how does that happen?
Madam Chair, it is available on CMS's website. The NADAC pricing is publicly available.
Okay, and that you say that changes roughly quarterly?
Yes, Madam Chair, it does.
Super, thank you. More questions for her? Okay, thanks so much.
Thank you.
Very helpful. Okay, now I'm just helping you get your stand up, sit down, stand up. You can come up, ma'am. You didn't get a chance to say who you were, but what's that? There you go. If you'll introduce yourself for the committee, please. I'm sorry, could you talk a little closer to the mic? I couldn't quite hear what you said.
Details. I work with about 30 plus government I work with 30 different groups or so. The majority of those groups are government entities. I do the consulting work for Laramie County, the City of Cheyenne, Board of Public Utility. We do consulting with Waihi Federal Credit Union. We manage the city, the county, and the hospitals in Rollins. Same thing up through, all the way up into Sheridan. So I've been doing consulting work for a long time, and the self-funded world inside of healthcare benefits is very complex. And the biggest driver that we're finding and struggling with right now happens to be the topic of medications and how to control cost in that. As I go in and put together and really want to sum up and not make this painfully long for everybody, there are three big topics that I think are critical of this. One is having a required dispensing fee. The other is eliminating mail order catalog or mail order prescriptions. And the next is controlling where we're getting specialty medication. The Affordable Care Act's impact on specialty medication has been catastrophic to healthcare plans. And I literally have groups today in Wyoming that are large employers that are struggling on whether or not they can even maintain a healthcare plan because we're struggling with how to fund the specialty medication and the stream in which they're coming in. So if I go back in and look at the dispensing fee, to add dispensing fees or a minimum dispensing fee could have a significant impact on the plans if I total up the number of scripts that we have. I, as a business owner in Wyoming, I don't make the same amount of money on everything that I do. There are many of the prescriptions that there are many of the groups that I have that I barely make money off of, but I'm kind of helping somebody out. Or if I have a friend of a friend that calls, I'm not going to say you owe me money because I have my consulting license. You help somebody out, right? It's the right thing to do. And small pharmacies and the big chain pharmacies are struggling with the same thing. They end up sometimes having a lost leader. My grocery store puts stuff on sale. It's a lost leader, but dang it, if I want it, I have to go back in there and buy to get it, right? So a lot of those components have a big effect on what's happening in the pharmaceutical side of the healthcare plans. When I look at the next on eliminating mail order, I'm not one of those consultants that goes in and says the only way you're going to get this is by mail order, because we can't wipe our pharmacies out. And since I moved back to Wyoming over 20 years ago, I look at the number of our small independent pharmacies that we've lost, and it's been catastrophic, you guys. When I went to college in Casper, I think all of us kids on a Sunday went and bought our shampoo and lotion at Buy Right from Lois and Floyd Harnicle. Then we cashed the check for $5 more and went and got dinner. The small time pharmacies have had a big impact on us, but they're going away, and it's harder and harder for them to compete with the big box chains. So as we go in and look at that, to be able to say we're just going to block out the mail order side of that and eliminate it, it's not going to fix the small pharmacy problem and what they're going through. When I see people use mail order, and holy mackerel, have we seen it change since COVID hit. I've had friends of mine that they're seniors and they're like, I've got to get set up on mail order. I don't want to go to the drugstore. Like, all right, let's work through the problem. Mail order has a couple of things. Delivers it straight to home. Most plans are set up so that you get a discount. Pay for 2 months, get the 3rd month free. It's a lower cost to the plan. And when pharma is such a large component of what's happening inside of healthcare plans, that is significant. And it's something to pay attention to. I can't go back to the commissioners of Laramie County and say, you guys, it's no big deal. Just make more widgets and you'll get more money, because it doesn't work that way. The commissioners go, you guys have to find a solution to control cost. So as a result, just eliminating mail order as a source to get prescriptions in is not a viable source financially for any of the employer plans. The next is specialty medication. Specialty medication has gone up so dramatically. If we passed a bill, it would be to go back to the FDA and say, quit authorizing the use of a medication that costs $1 million a year and has an efficiency level of less than 1%. How in the world is an employer going to manage that? Or how is a fully insured carrier going to manage the cost of that without us going insolvent? Because if we're not careful, we're going to be in a single payer system with no place to go. That's how big specialty and being able to control the cost of that is. And one thing that your bill is not talking about that I think is critical, what about rebates? I haven't heard that word one time today. Not every PBM passes the rebates on to the employer group. So there's good PBMs and there's PBMs that go, hey, for the good guys, that works out really well for me. But let me tell you something. I have groups that are getting well over $500,000 a year, hands down with rebates. I know groups that are getting almost $2 million a year with rebates. And rebates have to go in to help us buy down the cost of the medication. And if we're steering it and we have a partnership with the correct PBM, then we can turn around and say when there's a rebate available, is the biosimilar the drug that really makes sense? Or can we go with the brand name drug and offset the cost by a rebate? You guys, this is a complex world. Please don't go in and pass a bill that's going to tie our hands when the rest of us that are really working hard and independent inside of this organization, we're working for one thing, the healthcare plan. I have a fiduciary responsibility to that healthcare plan. When I walk in the door and I sit down with county commissioners or city council people, the fiduciary responsibility falls on them because they too, as a sponsor of that plan, have a financial responsibility to keep that plan solvent. And if we turn around and do not pay attention to the pennies, nickels, and dimes, or the million here and the $500,000 there, we're not doing our job. Please give some thought into whether or not this bill is shaped enough to answer some of those questions. I don't even think it touches the surface of it. And I also think it handcuffs people like me that want to go in there and rip the money out of the cold dead hands of pharma, because that's where this is starting, you guys. The PBMs that I work with, we demand complete transparency. We demand the rebate goes back to the employer. You know what? As a consultant, I've sat there when I've watched small hospitals in Wyoming have their broker pocket $150,000 to $250,000 a year in their own pocket for rebates. It should belong to the plan. Put some skin into this thing and give some thought to it. Thank you very much.
Questions for Ms. Madvick? Senator Bouchard.
Thank you, Madam Chair. What PBMs do you work with?
Ms. Madvick.
Yes. So I work a lot with Prime Therapeutics, which is partially owned by Blue Cross and Blue Shield of Wyoming. And we've done some extreme vetting with Prime when we first started working with them to make sure that we were getting the rebates back to our client, make sure that they were doing their job and managing it. I work with Magellan. We've done some work with Navitus in the past, but Navitus is, they were bought out, right? So now they're controlled again by someone else. I do a lot of work too with Southern Scripts.
Follow.
Well, thank you, Madam Chair. You were talking millions. It's billions in the PBM business.
It's billions. It's
500 billion.
It is.
That's money they're getting rebates that often don't come back to the end user. And so that's the concern here is the lack of transparency. If you look at the big picture, there's 3 big PBMs that are 76% of the market. So I think that not having the transparency of what's really happening, there are people being harmed. And that's the main concern here. So pharmacy can't necessarily subsidize that. Wouldn't you agree? They can't just say, hey, it's okay if we lose 10% or 15% or so somehow we have to fix that. So doing nothing doesn't fix anything, does it?
Ms. Medvig.
Thank you. It's a great comment. The amount of revenue because of the billions of dollars that we sit here playing back and forth with pharma is crazy. How in the world do we get a med that has so many people are taken in Wyoming? I'm going to use some examples. We have a lot of autoimmune diseases in the Rocky Mountain region. And because of that, we see Remicade, Humira, HumiraPen, all these medications that run through it. And the PBMs, some of them go in there, and if your consultant and broker doesn't understand who to avoid, you end up putting a group in the wrong place. And others, I can tell you over the years, we've slowly had to go in and force PBMs to give us information. What are you doing? What are your dispensing rates? What are you doing on rebates? There's programs out there now where we can turn around and literally have the ability to watch what's happening with aggregate rebates inside of it. And nobody really wants to talk about it. But if we as an employer or we as a community make a decision that we're not going to do business with the rebates like that, that is our only way to, or with a PBM that's that unethical, that's our only way to be able to convert it and to start to get control of it again. I don't have a great decision on how do we distribute it from the time it hits the manufacturer, runs down into a warehouse and goes back out. We have to have people that we trust that are doing it. And when we know that we don't have a PBM that's doing the job, weed them out, don't do business with them. And I can tell you in our organization, Senator, we blackball them and that's it, we're done with it. Because if I don't, I can go back in, I can ask them to run a claims poll, say, hey, what did it look like for you? Some of them will come back and be honest, some of them don't. Sometimes it depends on the bulk of the business and how they're building their formulary is going to decide how a plan can particularly run. And as a result of that, we have to be able to control everything from distribution to taking it right back to the employee or the member that's receiving it.
Okay. No more questions. Thank you so much.
Thank you.
I am going to, you can get up. I realized as we were having this interesting discussion is that before lunch, we had said we were going to let the people who are here to give their agency reports do that so they can go back and do their thing and not sit through this. So we're going to recess this category and switch to that. My bad, but we need to at least let the agency people get out the door and go back to work. So we will pause this and go down to the item 1 o'clock item. COVID-19 pandemic impact on healthcare facility staffing. And if you're on that list, Hospital Association, Medical Society, Board of Nursing, Leading Age Wyoming, the list continues. Just be prepared. So some of you, any of you on that list, come up to the chairs and we want to hear how things are going, what you anticipate, what you know as a result of the mandates, et cetera.
Madam Chairman, members of the committee, Josh Hannes with the Wyoming Hospital Association.
That mic seems to, either acoustics are bad or my ears are bad or the mic is kind of fuzzy. Just make sure to lean forward to it so that we can hear well.
Sorry, is that any better?
I don't know.
Worse,
Is
the
it better,
same.
committee? Go ahead, Josh.
I'll try to be loud. Again, Josh
Yes, thank
Hannes with the Wyoming Hospital Association. And since Leading Age, Wyoming is also on this list, you can count me down for them as well. I thought what I'd do, if it's all right, Madam Chairman, is, and I provided some materials for the committee, just a couple slides. I thought I'd maybe try to give you all a sense of the environment as it relates to staffing shortages in hospitals and long-term care. And then I'd really be happy to answer questions and provide whatever information it is you all want to know. So if you look at, now there's a number of caveats with this information too that I'll point out as we go along. If you look at the first slide that I presented, this is from a staffing firm, a temporary staffing firm called Medical Solutions, which is one of the biggest in the country. We partner with them. They have pretty significant market share in the state. And so that I was able to easily get this information, but they're not the only firm that does this kind of work. So just be aware that this is limited to their organization. The first slide shows open job orders by specialty. So you can see on the list that if you look at med surg, ICU, ER, those numbers reach into the thousands. This information is accurate as of the end of October. And these are also unfilled positions. So this is not just requests that came in to the agency. These are positions that as of the end of October had not been filled. If you move on to the next one, this is job orders by state. Again, unfilled jobs you'll see at the far left, California, Texas, Florida, and then it drops down fairly significantly from there. Again, unfilled requests that have been made. And now if you go to the very last one, now this one I have a number of caveats on, so bear with me. These are requests to this firm in the state of Wyoming, right? But I don't want you guys to get too wrapped up in the number that's attached to these. I give this only as an illustration that's directionally accurate, meaning that if you go back to 2019, you'll see relatively few requests for temporary staff. And then as we get into COVID times, that numbers start to creep up. Now that big spike in the middle, I'd also ask you to ignore. That was during a time when we were running a project in cooperation with the governor's office and the Department of Health, where they made dollars available to bring in temporary staff to help with surges in COVID. The number is so much greater for a number of reasons. One is that without these dollars, facilities just weren't, they were trying to attract the number of travelers that they could based on the budgets that they have and the money available to spend. Obviously, the money from the governor's office and Department of Health helped us increase capacity. Additionally, because of the hospital association's relationship with this particular firm, they were able to make Wyoming a priority as we were in a surge at the time, had a number of patients and huge gaps in staffing. They were able to help us aggressively recruit nurses to come in for a short period of time. But again, the point of this last graph simply being that COVID has created staffing problems. And some of that is, burnout. Nurses are working long hours, they're working long shifts. They're seeing very, very sick people come into their hospital and die, and they're leaving the industry. The other complicating factor around travelers is that because the demand increased, those rates have increased, which has enticed some nurses to pursue those opportunities to travel and make more money. But then that just increases the demand from the place that they left, driving up rates even further. And it's not at all a sustainable cycle right now, but it is necessary. We have patients that need to be treated and we need staff in our facilities. And this is a way that we have to go about getting that staff. Now, just for a few other pieces of context, I've heard from other large staffing firms that they have about 49,000 open positions, so unfilled positions as of the end of October. For a little bit of context, in December of 2019, it was about 9,700. So you can kind of get a sense that we're in a bad spot as it comes to staffing our facilities. I've also heard, and I'll try to get a better citation on this, but things I've read show that there's about 167,000 open permanent nursing positions in the country right now as of the end of October. Anybody who knows different can certainly come up and correct me, but the point being is that we are having a very, very difficult time having enough people to care for these ill patients coming into our facilities and who are currently in nursing homes. I honestly don't know, frankly, back in the November, March timeframe, when we worked with the governor and Department of Health to get those temporary staff in, what any of our facilities would have done, but specifically nursing homes. I don't know where those patients would have went if we didn't have the staff to come in and help out. We're deeply grateful to our partnerships for our partnerships with the state to help staff some of these facilities. Now, another issue is you see that hospitals, their census is going up. Staffing is obviously one of the big problems. We could expand beds in probably all of our facilities. It's not the issue of creating space for patients. It's that we don't have providers to take care of them. And so that's when you're going to see difficulties transferring patients to more appropriate settings of care. It's incredibly difficult right now. And I guess I would allow a medical society to make any comments, or I'm happy to stand for questions and provide whatever information you all need.
Questions for Mr. Hannis, Representative Stivar.
Thank you, Madam Chairman. The mandates in all these nurses and medical professions that do not want to have the shot that are losing their jobs. Is this all tied into this too? How's that going to affect our already bad healthcare?
Mr. Hannis.
Madam Chairman, Representative Stivar. I think certainly you will see people leave their positions because of vaccine mandates. We don't want to lose anybody. But to be perfectly honest, it's not the largest driver of nurses leaving the industry right now. It is a concern. I'm not going to say it's not, but this isn't our largest problem. It's going to affect different areas differently.
More questions for Mr. Hannis? Representative Romero Martinez.
Do you have some information regarding demographics of groups or cross-cultural groups that place their family in nursing homes?
Mr. Hannis.
Madam Chairman, Representative Romero Martinez, I do not. I don't know where that information might live, but I'm happy to do some research and
I
try to
appreciate
find
it. Thank you so much, sir.
Representative Connolly.
Thank you, Madam Chair. Mr. Hannis, and maybe Ms. Bush as well. I'm going to go back to Representative Stivar's question regarding the impact of vaccine mandates. Is it possible too that there's some issue with concern among staff that has been vaccinated regarding needing to work next to someone who hasn't, and the concern about their own health and their family's health? That there is that concern as well.
Mr. Hannis.
Madam Chairman, Representative Connolly, there is from the provider side, and we've also heard concern of patients coming into facilities who don't want to be treated by those who are unvaccinated. Now, again, these are anecdotal stories, but they do exist on provider and patient sides.
Madam Chair, just so then, is it a fair summary that you're seeing issues on both sides? It's certainly not only kind of one directional in terms of how both providers as well as patients are looking at the vaccine mandate.
Madam Chairman, Representative Connolly, I'd say that's correct.
Thank you.
More questions, Senator Hutchings.
Thank you, Madam Chair. Mr. Hannis, thank you for answering those questions. Just a really quick one. Does the COVID-19 shot prevent people from getting COVID?
Madam Chairman, Senator Hutchings, I'm not a physician. I'm not going to comment on that. What I will say is that we believe in our association, and our members have taken a strong stance that the COVID vaccine is the best tool we have at our disposal right now to manage this pandemic. We encourage everybody to get the vaccine, particularly healthcare workers.
Representative Worf.
Madam Chair, I guess I have to ask this question because I just wonder if you had to assume the liability for those that took the shot and had an adverse reaction, would you be as willing to assume that position? The fact that there's nobody that takes on any liability for any adverse reactions that happen to this vaccine that's where I kind of balk at all this, because it's easy to say it's something you support when you don't have to bear that burden. I just found out my brother-in-law has had 2 strokes. And, you know, I can't say that it conclusively is because he got the vaccine, but I can tell you that it's troubling to me that the manufacturers have been insulated against any type of liability, accountability, whatever you want to call it. And I guess that's one of the problems I see with this is it's easy to say that, but I guess that's my question is if you had to assume the liability, would you be so willing to tell people that they had to take the vaccine knowing that there is no accountability for any repercussions if somebody gets sick because they got the vaccine?
Mr. Hannah.
Madam Chairman, Representative Worf. I think what I would say to that is hospitals and nursing homes currently do require a flu shot, for example, right, as a condition of employment. That's not new. And I guess secondly, what I would say is that I think we expose ourselves to liability by not taking all the precautions necessary to protect patients and staff. There's a school district in Wisconsin right now that's being sued for not implementing appropriate public health measures. I don't know that that would happen here, but I think we have a responsibility to our patients and the people that come into our facilities to do the right things, to create safe environments. And we make those decisions based on all the best available evidence, consulting with doctors and leadership and looking at what works to do better.
And let me just say, because you have a follow-up, but let me just say, so committee, we have a kind of a long list of people who we've asked to come and report on their workforce situation. And then we want to get back to the other bill. Just keep in mind, there are obviously many interesting subject matters in this whole COVID discussion. I mean, I get that and it's interesting, but what we really want to get from them is just reports so that we know what workforce problems we have to deal with. So let's just try to kind of confine our, specific inquiries to the impact on their workforce. And I mean, as I say, I know there's all sorts of interesting discussions that we can have, but we don't have time today to resolve them, and let's just kind of confine it. So follow up, Representative Worf.
No, Madam Chair, I will rescind.
Representative Stivar. Well, okay. All right. Any more questions for Mr. Hannes? Representative Romero Martinez.
Thank you, Madam Chair. You mentioned that, yes, people will lose will leave their jobs if they're forced to take the vaccine, but you also mentioned it's not the driving force. Can you tell us what you think the driving factor or force is in that issue? Thank you.
Mr. Hannes.
Madam Chairman, Representative Romero Martinez. It is one of the factors, but like I said before, burnout among staff when you're working short-staffed and forced to work longer hours, the ability to make more money, frankly, as a travel nurse right now, which, as we talked about, is sort of this vicious cycle, which just increases the demand and makes it more expensive. Those are 2 other large ones right now. And I know there's some other nurses in the room who might be able to add a little more color to that answer.
Okay. Did you have a follow-up?
Follow-up. And just point of reference, I think you did say you encouraged, you didn't say you would make them. But I wanted to also just make up, and then I'll make it brief, 30 seconds or so. And I don't mean to be pointing them out, but both of my nieces became CNAs. One of them left. I'm not sure exactly why, but I know one of them is making more money at a fast food restaurant than in the nurse. We've mentioned it before. And I have no questions. I just wanted to make that comment. I think it's been talked about. I have 2 people in my family that took the program that this legislature passed to become CNAs. They're both not CNAs now, 2 years later.
Well, certainly, like other healthcare groups in this room, they would be glad to have us pass a bill to pay them more, I'm sure. Okay, any more questions for Mr. Hannes? Conflict, right? He has a conflict. All right, thank you very much, Josh. Ms. Bush.
Good afternoon, Madam Chairman, members of the committee. Sheila Bush with the Wyoming Medical Society. As I understood the request, it was to speak to workforce situations as a result of COVID specifically. I'll preface all of my comments with many of the things I'll discuss with you today were issues prior to the pandemic. The state has grappled with physician shortage for a very long time, and we have explored different ways to address that. I think we've attempted to be creative. It's a multifaceted, very complicated issue that I'd love to discuss with you sometime. But if I understand what you wanted from us, it was giving a little bit of perspective on what the pandemic impact has been on physicians from the medical society perspective. And so I will offer, about 5 years ago, the Medical Society did our best to identify what percentage of the physician workforce in Wyoming is employed versus remaining independent. It's a very difficult task. I'm not sure that we did it all that well, but we did our best. And at that time, about 5 years ago, we were roughly 60% of physicians employed, roughly 40. Am I using the wrong mic? Okay. This right? Am I doing this right?
You're doing great.
40% independent. And so inside of a pandemic perspective, I would let the Hospital Association represent sort of those employed physicians because they are encompassed and embedded within that employment structure and most often with facilities and hospitals. So I'll bring you the perspective of kind of the 40% who remain independent. What I gathered from them in preparing these remarks was the pandemic significantly increased supply charges. So they're paying a lot more for supplies. They're having to pay more for any of their work staff. We have several clinics that reported they're going through, 4 and 5 individuals for front office help before someone is kind of going to stick with it and stay. They had to hire additional people for screening, which costs money. And then many of these clinics, if any portion of their income is on procedures, if any of those are elective, that income then either disappeared or was significantly reduced, again, as a result of the pandemic. And so within your independent clinics, you have physicians who are operating on a lower income with increased expenses. And they're unique in the sense that they can't really pass any of that cost along to their clients or patients in this situation because those reimbursement levels are capped inside of this system we all attempt to navigate. And so that does cause a lot of hard times for physicians right now. All of them really struggle to find staff. Paying staff is difficult. They're all paying the staff more than they were prior to the pandemic and continuing to struggle with retaining and recruiting that staff. And so I think that that's all I have as it relates to the pandemic specifically.
Questions for Ms. Bush? No? Okay. Thank you very much.
Thanks.
Let's see, okay, Board of Nursing.
Madam
Hello.
Chair, committee members, hi. Thank you for having us here today. I'm Lori Hart. I'm the Executive Director for the Wyoming State Board of Nursing, and I bring a regulatory perspective for CNAs and nurses, as well as 38 years as a nurse and a nurse practitioner. Nurses who entered nursing with a strong vocation to save lives are seeking jobs outside of traditional nursing. They're leaving nursing completely. Interestingly, the Wyoming State Board of Nursing at the same time has seen a dramatic increase in the number of nurses who are interested in outside kinds of things. We are seeing a tenfold increase in nurses who want to open aesthetics clinic. And you would believe from the kinds of phone calls that we're getting that we are the most Botox state in the nation right now. It would seem from, we also have nurses who are really afraid of making mistakes. They're afraid of losing their license based on the staffing issues that they're experiencing and the lack of staff. I want to share with you today the perspective of a few of the chief nursing officers from the state. All facilities are experiencing a shortage of nurses and CNAs. You've heard that. That's nothing new. That's the same nationwide. Nationwide, we've seen an 8% decrease, or 8%, excuse me, dropping of professional practice. So 8% of nurses have dropped out of nursing. At the same time, up to 20% of CNAs have dropped out of practice. So we're seeing a dramatic turnover. A facility in Casper indicates that they're not currently overrun with COVID patients, but they've still lost many staff. And they've lost them to higher paying travel positions, as you've heard, and they've not been successful in being able to recruit for these positions. Facility in Cheyenne faces similar challenges of loss of nurses to high paying travel positions. Interestingly, some of these involve nurses quitting one day and the next day coming back to their same unit as a traveler and receiving 3 to 4 times the pay. So travel doesn't always mean sleeping in a bed other than your own. What we're seeing because of this, though, are nurses who are burned out due to lack of time off, required overtime. One facility's had required overtime now for over a year. We're seeing nurses in all areas who are running at a sprint pace in a marathon, and it's not sustainable. Sublette County lost half of their nursing staff and only have 4 nurses to staff a 24/365 unit. Have you seen those signs posted at your chain restaurants indicating that they don't have enough staff and so they're closing early? I think we've all kind of come to accept that at this point. But how would you feel if you brought your sick child to the emergency room and saw that same sign? That may be where we're going. The mission of the Wyoming State Board of Nursing is public safety through the governance of nursing education and practice. Our focus is nursing regulation, and it is the Wyoming Nurses Association who provide the united voice for nurses. So I've shared with you some information from some of the leaders in nursing, but I'd also like Tony Decklever, who represents that organization, to share some information from individual nurses.
Ms. Decklever. Welcome.
Thank you, members of the committee. I'm Tony Decklever with the Wyoming Nurses Association. I'm a registered nurse, have been one for 38 years, and should be a traveler. Make a lot of money. The nurses they're just exhausted, and the anecdotal information that I get from many of the nurses they're just tired. They are overworked. They are beat up. I actually spoke with a nurse just a couple of days ago who was working in an emergency room, and she said that patient came in, COVID symptoms, coughing, just really, really, really sick. So she masked up, gowned up, put the face shield on, went in to take care of this patient. And the patient looked at her and said, "You're not going to take care of me dressed like that. Give me somebody else." And she said, "I'm sorry, sir, we're all dressed like this." And he said, "Well, I am not going to let anybody touch me that's dressed like that." He was angry at her because she's following the rules. And you know, a year ago, and we've all heard this in the news, a year ago, we were all, the nurses were the heroes, the healthcare professionals were the heroes, and now we're the enemy because we have to mind the rules. And patients don't like it. The visitors don't like it, the patients don't like it. We don't necessarily like it, but we have to do it. And it's hard. And when this is happening to us every single day with no breaks, we're very appreciative of when facilities will bring in a lunch or they'll do something special for us. But the nurses are saying that I'm taking my Jimmy John sandwich and running down the hall while I'm eating it because there's no time. There's too many patients, too much work. There's just no time to even take a break. They don't get vacation time, so they can't recover. They're tired. They're exhausted. The rules, and one of the rules being the vaccine mandate, but nationally, the number of healthcare professionals that are leaving the profession because of the mandate are only about 1 to 5%. It's actually quite low because many of us are already vaccinated. So the vaccine mandate in and of itself is not necessarily the reason why nurses are leaving. Nurses were leaving before the vaccines came out because we're just tired, and we're tired of being beat up, and we're just tired. And in some cases, the reason why people go to traveling agencies is because they have a bit more control over where they work and how they work. And so, you know, leaving one facility, joining an agency, and then going right back to the facility that they just came from, that's actually quite common. That happened when I was a young nurse. Because now I can say, I want to work on these days, on these floors, on this shift, and I get paid double what somebody else does. Now, when I was a young nurse, traveling agencies didn't offer benefits, but now they do. And so they're offering vacation, they offer insurance benefits. And so a traveling agency is very, very, it's kind of a good deal. But we know it's not sustainable because it's so expensive. And when I was a director of nursing, the last thing I wanted to do was use travelers because they were so expensive, but I had to have the body to take care of the staff. I mean, take care of the patients. So it's just really, it's tough right now. We're frustrated on in many areas.
Questions for Ms. Declever? Senator Baldwin.
Just a quick question. I'm just curious. I know when this whole mess started 2 sessions ago, I believe, as we were getting out of session, we first started really talking about when it canceled the state basketball tournament, et cetera. I know there was a push by the Board of Nursing to get retired nurses. You know, people that have been nurses that had retired and went on fishing or went on to other professions, et cetera, to get them to re-update, come back in, renew your license, which I didn't. But I'm wondering, did anybody take us up on that? Did we get very much of a push of retired nurses or nurses RNs that have gone on to something else? Did any substantial number come back in with licenses?
One nurse is substantial when you only have 4. So yes, we have had a few, but as far as a substantial end to increase that pool, unfortunately not. At this point, though, we really are celebrating one nurse at a time. And I think that's how we have to approach it, is what do we do to hold on to and to keep one nurse at a time? And I think that's the important part. We've looked at several things. We've looked at licensing. We're currently allowing under our emergency rules under our Nurse Practice Act, anyone who has a valid license in any state may practice in Wyoming. They could come tomorrow if they had a license in Nebraska, so that there's not a delay while they're getting licensed in Wyoming. We've talked about the emergency direct care worker that we've instituted. We've worked with the Department of Workforce Services to identify individuals who have worked less than 4 quarters in the past year. And we've provided the facilities the name of those and contact information for those individuals to be able to get in touch with them. Most recently, this week, we've actually instituted Nursing Connect. And this is an opportunity where nurses can register through our website to be able to then have their information shared with an employer who's interested in hiring them. So the hope is really to keep building our own. And again, this idea of one nurse at a time.
Senator Furphy.
Thank you, Madam Chair. Let me ask about, of course, it sounds like a pay issue for one thing, but we've got to attract new nurses through the system. Let me ask about how are the universities and colleges doing educating nurses? Do we need to change the curriculum or make other changes at our universities to encourage more people to head into this very important industry in our state? Thank you.
Either of you?
Madam Chair and Senator Furphy, it's certainly an area that we're looking at. We saw in World War II the first introduction of a 2-year nursing program, which was in direct need for nurses and a fast training of nurses. At the same time, universities are looking at what can we do to make sure that we are getting people trained as quickly as possible. And 2 years seems to be that magic number, and as effectively as possible. I have not seen major changes suggested, nor would I suggest any, because we have actually some of the best NCLEX, which is the exam you take before practicing, rates in the nation. So we're doing something well, and we're having nurses who are well trained. Where I think we have an opportunity is through more creative kind of education. So are we being able to attract people who are second profession nurses? Are we able to attract individuals who are single parents who have kids at home and need night and weekend kinds of education? And that's probably the area where as a state, we're a little bit behind what I'm seeing across the nation.
Madam Chair, if
Ms.
I could
Declever.
add to that, Senator Furby, part of the problem with educating nurses is that nurses educate nurses. And we have an extreme shortage of nursing faculty. And so our curriculum is wonderful, but we can only take so many people because by accreditation standards, you can only have one instructor for every 8 students. And so when we don't have enough instructors, then we cannot teach. The other, especially through COVID and I got some, I sent out a note to a bunch of nurses that I know in the state. And I asked them, what are some of the problems and what are you seeing? And from our nurse educator piece, it is the fact that nursing educators, number one, have to be nurses themselves. But nursing educators are paid abysmally. And so they are at the very bottom, educators at the very bottom of the pay scale. And so again, if you have an RN, especially if you have a master's degree, and you can work at a facility for triple the amount of money that you could work in education. And so finding qualified educators, number one, but then the other problem is that nurses need to be in a clinical area as part of their curriculum. And COVID has restricted that. So students can't get in. And then when they can get in, what they see is an overwhelmed nursing staff who doesn't have the time, the patience, or the ability to be able to teach them well, even when they're in a clinical area. So it's like one thing after another, and throwing money at it could help, but it's a multifaceted problem.
Madam Chair, may I? One more thing to
Ms.
that.
Hart.
This week I was in a meeting from the National Council of State Boards of Nursing, which is our national regulator organization. And they were discussing Washington State as a really good example. Their legislature there has passed a bill that is augmenting nurse educator salaries so that they are getting to be somewhat equitable with those that are working in clinical facilities. So what can you do? I think was one of the questions that was asked the last time I had the chance to talk to this committee. And that might be something that could be considered, because we are going to have a shortage of nursing faculty as we're all aging out before we have a shortage of nursing students.
Senator Baldwin.
You're going to get my name right, aren't you?
We'll read your name.
I was just going to dogpile on top of all that. And that is when we talk about nurse education programs, and that is our community colleges and our schools, our nursing schools are facing budget cuts as well. And I bring this to you from a WICHE perspective, of which I'm a commissioner, and it involves Washington State. It involves 19 states. There's a shortage across the nation. The Western United States, there's a budget cuts in all of our schools. And that doesn't touch just, the auto mechanics, it doesn't just touch the architects, et cetera. It affects nursing. And so they're having a more difficult time providing that education for our nurses. And that just compounds on everything you just heard from these two fine nurses. So that also adds to the problem. Wouldn't you agree?
Madam Chair, Senator Baldwin, yes. And the other thing that happened with the budget cuts is that our legislature instituted a program many, many years ago called the Wyoming Investment in Nursing. And that fund was helping with faculty, and it was also providing financial aid to nursing students. The nursing student fund part of that legislation has been eliminated. And so the WIN funding program right now does support nursing faculty, but there is no financial aid for anyone wanting to go into nursing.
Or questions for Ms. Hart or Ms. Declever? Representative Romero Martinez.
Thank you, Madam Chair. My question is more in a terms of a cross comparative or to compare and contrast. What do you have any information on what nurses and doctors get paid in the United States versus the countries in Europe? All of them, I guess, or can you get that information?
Madam Chair, Representative Romero Martinez. The salary schedule for healthcare providers is going to be way different depending on where they live, even in our country. I spoke with an RN just this past week who said that she had moved here from New Jersey and took an $11 an hour cut in pay to come to Wyoming. Well, you multiply that by 2,080 hours a year. That's significant. And she said that the cost of living out here was actually higher than where she came from. So the fact that we have no income tax here did not meet the difference in what she lost. She said housing was more expensive out here, gas is more expensive out here, food was more expensive out here, and yet her salary was less. You go to California and those nurses are making $180,000 a year, but the cost of living is so high that, you know, what they cash in hand is going to be, it's just going to be different no matter where you go. The other piece, and Sheila could probably speak better to the physician end, that also is dependent on specialty. So certain specialists make more money than family practitioners. Same with nurses. Nurse practitioners make more money than RNs. So it kind of depends on education, where you work and where you live. But we could look.
I think my question was a follow-up. I think my question was more like United States average, and I'm okay with information from low, medium to high, and compare and contrast to Spain, Italy, all of Europe. And I guess I'll just kind of nip this in the bud because this is kind of what I think I know anyways. I believe there was a special on 60 Minutes a few years back, and there was just a dramatic difference between how Europe works versus how we work. And the reason I'm bringing that up is you had mentioned there's a lot of reasons they're leaving. I think there were 3 major ones that you mentioned. Burnout, which I can confirm. I'm best friends with a lot of nurses and they've confirmed that. One of them, my good friend Joan, who actually took care of my mom in 3 different facilities. She bounced around all of Cheyenne. She went from Granite to the hospital, and you probably know her. And then she ended up at Davis, and just texted her to try to get follow-up. She said she was on vacation. Don't bug her for another week. She recently said, so I could confirm that. But the whole idea of, and she mentioned it to me. She said, the problem we face is we live here, we get X amount. People come here from Colorado, switch over for that traveling nurse pay and get that 3 times more. I guess what I would just kind of suggest is that, and don't take offense to this, all nurses, I'm not saying all nurses, but there are some nurses that do get greedy and they just do that for the money. And in Europe, according to the 60 Minutes report, doctors were paid substantially less. So I'm just giving you the information I know, but I'd like to see more real current statistical data. And they basically said, well, you get, don't quote me, this might be a little bit fuzzy here, but you're getting paid almost as much as a janitor, a doctor, something to that effect. And they said, why do you do it? And the doctor said, well, because I got into the business to help save lives, not for the money. And you don't see that in the United States. You see this big problem. And you did mention, and then final comment, so not really a whole bunch of questions. Just
Questions. Let's remember, we're gonna kind of be concise with your questions.
yes, ma'am. And since the question wasn't answered, I gave an answer that I gave good source on. You had mentioned earlier on curriculum being wonderful. My question is, how can your curriculum, if your curriculum is wonderful, but the application is not wonderful? The reason I'm suggesting that, what could we do to incorporate more cultural competency? According to the leader of AMSAC, that has not taken place. I know for me and my part, navigating the system over 30 years, it's not being practiced wonderfully. What can we do to, I guess the question is, what can we do to increase cultural competency training in collaboration with the appropriate department, specifically mental health.
So just to pin that down, because we're talking about workforce challenges, are you wondering whether increasing their training in cultural competency would increase their longevity at work? I mean, can we tie that in somehow, or?
I think we can. I'm not
I don't want to branch off into the entirety of nursing education here.
sure. I think we could
Try that.
do it however you want, but
Madam Chair, Representative Romero Martinez. I think the important thing with cultural training is, and it's more than that. We want to be cared for by people that are like us and that understand us. And I think being able to attract people to nursing that are a mirror of what our society looks like is really what we're working toward. We certainly face that. I moved here from Alaska, and we were trying to get more Native Alaskans into nursing. And the way that we did that was to bring in students early on in their training into camps, into other things that showed them what they could be. We made sure that they had the financial backing to be able to attend school and to be able to have instructors that, again, mirrored what their makeup was. And so those are all things that I think we would all like to see, but it comes down more than anything to money, I believe, money and opportunity. And I don't know that I know an answer to that, because it really does come down to a lot of funds that are brought into that. But I think all of us in nursing would like to see the nursing workforce mirror what our society is.
Okay, thanks very much. Let's move on to leading age. Did I see what happened to? Josh, are you coming back up again, or did you want to give a cumulative? Okay, all right, then we'll move past to Wyoming Healthcare Association. Carolyn, I think you're up. Welcome. Introduce yourself if you would for the community at large. And just a reminder while you're getting set, those of you online, and sometimes I forget. So again, remember, if you really want to, just wave wildly. Go ahead, Carol.
Madam Chair, Wyoming Healthcare Association. And it's nice to be here.
I thought that sounded like it was on. I just have a loud voice. Oh, there it is. I really appreciate the opportunity to do this, because there is so much happening, and I don't need to be a parrot, because the others that have spoken before me have done a very great job in saying what is. You have before you this little slick cover white file folder, and in it on the left side is something about Wyoming and our experience, which again, I'm not just going to parrot everything. I will talk a little bit about administrators in nursing homes. That hasn't been done just yet. I am hearing from them that they are doing CNA jobs. They're making beds, they're delivering trays, they're sweeping, they're doing everything possible to keep their facility going. And some of them have had COVID and just moved right into the facility and kept running the facility while they were sick. Their spirit is beyond what I ever thought would happen. It is indomitable. They're there to make this work and to keep their residents well. And they all have had deaths, of course, and they have closed some of their wings because they don't have enough staff. They are very fortunate in that a nurse, a PhD nurse in the state. It has a private business, and she is going into facilities and training people to become CNAs. And she can do CNA 1, she can do CNA 2, and she can do med aids. And that is because the Board of Nursing is making that allowable for her to do that. And thinking of enough nurses and thinking of the future, if we could follow that along and see that anyone that wants to progress after they are a med aid, the next step, of course, would be going to nursing school. And we can encourage that, and we will. There are so many things happening that we should talk about in depth, but there's not enough time. And in behind the one little sheet telling you about nursing homes, there's what went out as a survey Q&A, and it was just to show you what went out. And then I followed up with phone calls, and things were said like, you can make a CNA with training. You can't make more nurses. They've got to go to nursing school. Just very practical kinds of things that are said by administrators that are there and going to do everything they know how to do to serve not just their residents, but a community. And thinking about the difference, Wyoming is a rural state and sometimes called frontier. But it makes a difference on if you're really rural in a county, or if you live in Casper or Cheyenne, where there is more workforce. But those who are in the small rural towns and rural counties, they are in bad trouble. There are not enough. Our state is has a paucity of population, and we have to deal with that. And we have to deal with, we do not have an abundance of money. We've got to think about what are we going to do. And if you look on the right side of that white folder, you will see a robot with a little person in a nursing home having a wonderful time with a robot. I have no idea the experience of what has happened in Europe, because they are way ahead of us. Japan is way ahead of us. They are using robots that have arms and can do exercises to the music and lead people in a circle in doing exercises. They're way ahead of us. The thing I have been looking at are the ones that can deliver 10 trays. They have no faces. They're just like a little box, and they are programmed to go to certain places, and they can pick up trays. That would be a great help. I have looked at costs, and actually we could probably afford those. There is much more that could be done with robots. Nobody is looking forward to having them. However, I read, and right under the first couple of pages, there is one that tells you that they're using them in Minnesota. It's enough to let you know that they're, we wouldn't be the first, but we would certainly be right behind them in that regard. There are some top universities that are have been dealing with robotics, and MIT, Stanford, Mellon, Brown, University of Texas. I don't know. There's a top 10. We even have something happening down at the university in Denver. I know that your schedule is way behind, and I'm going to be quiet here. There is a third page that has some places to continue to do research. I would suggest, as you go forward, that in an interim study, that this would be a part of what you would look at. Although it looks like a machine is just a dead thing with no personality, they're well programmed, and it's something that might help us. We are in trouble. I'm not even sure how much trouble. I only know that when I talk to administrators, I have not been this stressed. I ran a prison. I mean, not just a city prison. I ran a state prison, and I was never that stressed as I am now for what we don't have, and we don't have a way to take care of it right now. Thank you for letting me expound here.
Questions for Ms. Passano? I guess I would say that I'm not sure that I would call moving into robots to take care of our elderly people as being way ahead. I understand why we might be going there in the need, but it's a sad statement when we call that ahead. I do have a question on the survey Q&A. Down on the bottom, it says, question 9, what is the biggest obstacle in hiring new staff? And so the first 3 are underlined. Then the vaccination requirement, the question was for the time prior to the executive order. Then the second one is since. Now, I assume that you drafted this, a little bit of while back. Do you have any update on that? And I will say, I've heard from our local hospital that probably for as many people as he's going to lose over the vaccine mandate, if there weren't a vaccine mandate, he'll probably lose as many people that don't want to work with unvaccinated. So it seems to be a 50-50 from his perspective. From your members around the state, do you have any updates on the impact of the CMS mandate that our people are hypothesizing and talking to their staff?
The latest phone calls, Madam Chairman, that I have made, that's why I'm saying we're really in trouble. The administrators that are willing to speak, thinking that I would not pass on their names, and they will certainly be giving religious exemptions right and left. And I have 2 administrators that tell me that if they're not able to do that successfully, they are going to have half of their staff gone. We are in Wyoming, and so many people are their own thinkers, and they're not going to let the federal government tell them what is right for their body. And a nurse, and I just heard that said here, but a nurse told me just this week that she's going to get out of the business when the December date comes, and nothing can be done, that she is quitting, and she will not go back to nursing. I can give you antidotes across the board. We are in trouble. And I think that the Department of Health, and certainly you all in the legislature, have got to, in your thinking and in the interim study, that you are going to know what to do with a growing number of elderly that are coming. And what are we going to do if we can't solve this? Where are they going to go? 70% of the people in our nursing homes, 18 across the state, are on Medicaid. Who is going to take care of them in their homes when they have no one? No, we've got you. It's your shoulders too, big shoulders. There is something coming that we have to make a decision about right away, because December 5th is upon us. Thank you.
Any more questions for Ms. Passman? Okay, thanks very much. Let's see, next up we have, I keep losing my paper. I have some papers. We really heard from Department of Health and on the CMS rules update. Josh, you had, or I'm sorry, where's Ron Stefan? Are they still here? They left entirely. Okay, I guess we don't hear from them.
I just came from the Judiciary Committee, and Stefan Johansson asked me to report to the committee that he felt like he gave his full comments this morning.
Okay, well, we'll go with that. He was pretty full. I'm gonna push Director Kula, because you're on here and then have your own line item, I'll just roll you down to there. Ms. Somerville, where'd she go? There we are. These giant posts. Kind of. Welcome.
Thank
Let
you,
us
Madam-
know how you're doing.
Thank you, Madam Chairman, committee members, Andy Somerville with WAMSAC. I am doing well and getting all of my steps in between judiciary and labor health today, so I appreciate that. Committee members, I just wanted to touch briefly a little bit to give a few points about what's been going on with the workforce during the pandemic for community mental health centers. So to start off with, as the pandemic started into the fall of 2020, we saw our crisis calls escalate significantly. That trend has continued, both with new clients that we've never seen before, decompensating, as well as established clients that are continuing to struggle with their mental health conditions worsening during the pandemic. That has led to a tremendous amount of stress on mental health care staff that work at community mental health centers. As this committee is well aware, we provide 24/7 response. We do crisis calls 2 a.m., 4 a.m. when they show up in the ER for the hospitals that we go to, which is most of them, to do Title 25 evaluations and all of those things. The job of a community mental health clinician, so we're talking generally about master's level clinicians, the average turnover is still pretty bad. It's about 3 to 5 years. It's a high burnout position. What we've seen this year is an exodus unprecedented in the last 12 months. We have some of our facilities that are functioning with about 30% less staffing than they should have right now, which is putting additional pressure on the clinicians that are left to pick up the load, to pick up more overnights and 24/7 call coverage. We are seeing these individuals either retire early out of the system. So there are a few, not a ton, of mental health clinicians that stay the long haul in community mental health, and some of them have decided to exit during the pandemic due to the stress that they are under. What we've seen more of is two things. One is those who have achieved their full licensure, so they've been with us for 3 years and finished their provisional term, moving on to open private practice with a primary focus on telehealth. So they don't want to open an office and see people in person. They want to either contract with a telehealth company or set up their own shop with telehealth. As for community mental health, there is a certain aspect of our jobs that has to be on the ground in the ERs responding, dealing with those things. We can't do telehealth for everything. It's a great tool, but it doesn't solve all of our issues. The other piece that we've seen specifically, I'll say in the last 6 months, is what I would just call a salary war that we have never seen before. So community mental health does not pay as well as private practice. You have to be in it because you love it. Or you're a provisional who need their hours to get licensed. And we've had several examples over the last couple of months where I would call them not federal contracting agencies, but federal type programs that aren't directly run by the federal government, but receive a large amount of federal funding, have raised salaries more than 30% above what we currently pay right now. There is absolutely no way for community mental health centers to close that salary gap. It is way beyond our reach. We struggle to maintain the salary levels with the funding that we have now. And so not only do we have an exodus of workforce, we have a workforce that is under severe strain. We also have these opportunities that are showing up where they're, even if they're the best person and they want to stay there, they can't say no to a 30% bump in salary. And usually those types of jobs come with no overnight call shifts, which is always an added benefit for people that like to sleep all the way through the night. So with that, Madam Chairman, I would stand for any questions.
Questions for Ms. Somerville? Ms. Connell, or Representative Connolly?
Thank you, Madam Chair. And Ms. Somerville, I should have asked others, and not just you to start with, but when we talk about staffing and staffing issues, ultimately, for me at least, the question is about client, patient, community outcomes. And I'm curious if you or honestly anybody else has any kind of information, whether it's anecdotal or empirical, about those kinds of outcomes over the past year.
Somerville.
Madam Chairman, Representative Conley, I'm not sure that I have any specific information, but on the anecdotal side, for us, it means pushing patients out longer before they can get in to see us, which raises the risk of them falling through the cracks in the system and ending back in the ER or wherever they were at before they can get care. So there certainly are those outcomes, and not having the staff bandwidth to handle the increase in crisis calls. Again, those are more likely to fall through the cracks and decompensate and cause, frankly, issues for law enforcement, hospitals, community. They lose their jobs. It has quite catastrophic effects. But as far as quantifiable data, I don't have that for you right now.
More questions from Ms. Somerville? Okay, well, I hope you're all collecting brilliant ideas on how to solve all of our witnesses' problems, preferably by the end of next interim. Thank you,
Madam
Ms.
Chair.
Somerville. Okay, next let's see, public comment. I don't know if I left out any people that were going to be here for workforce. Oh, come on up. I don't know if you really qualify as public. You're sort of more like the regulars anyway. Just come up in a little group if you're happy together. Hello, just introduce yourself for the group if you would.
Thank you, Madam Chairman. Jeff Gardner, I'm the Executive Director of the Wyoming Community Service Providers. And for the benefit of the committee, our membership supports people with intellectual and developmental disabilities and acquired brain injuries across the state. So certainly the woes that you've heard thus far from the other witnesses apply to our workforce as well. So I won't, certainly no need to belabor some of those points, but I think there is a significant difference in that we've talked a lot about and heard from facility-based, kinds of providers. All of our providers are home and community-based providers. So they're supporting people with intellectual and developmental disabilities in your community to live typical lives of quality. The levels of acuity range from a few hours a week up to and including people who have intensive medical and behavioral needs and who need one-to-one supports 24 hours a day. Similar to things that you've already heard, this was certainly not a problem caused by the pandemic. I've been doing this almost 2 years now, and I don't remember a time where we've not talked about workforce issues, but certainly the situation that we're currently dealing with is something that none of us who have been around a while have seen. Wyoming historically, I shouldn't say historically, in the last National Core Indicators Staff Stability Survey, which is something that Department of Health participates in, the turnover rate for direct support professionals, or those boots on the ground, people supporting people day to day, was 64.8%, which is the highest in the country. We will see, I believe that providers had through the end of June, so we should be seeing new numbers, and I would anticipate that obviously being much, much more. Specific to our member organizations, agencies, we have a span anywhere from 20 to almost 50% vacancy rates right now. And that's just In addition to the physical and emotional exhaustion of those direct support professionals, there's obviously a financial cost to our providers in terms of overtime, because similarly to, and I don't remember who said it earlier, but we can't hang a sign on the door that says we're closing early today. People need 24-hour care. And similar to what's been pointed out a few times, as Medicaid is our primary funder, we can't say to Medicaid, we need to pay our staff more, therefore we're going to charge you more. It's a set rate. So in the interest of time, Madam Chairman, I would certainly stand for any questions, but I just wanted to make sure that the committee was aware of, in addition to the groups of providers that have been that have addressed the committee today, there's another group out there that are in your communities and they're supporting people 24 hours a day.
Questions for Mr. Gardner? Representative Romero Martinez.
I don't know if this question is out of order. I'll be corrected if it is. Do you have any recommendations for our group?
Mr. Gardner.
Well, sure. And again, this has been mentioned, and I don't believe that money is the total answer, but I believe it is a significant part, if not the first answer. Again, repeating what's already been said, but I'm aware of one of our members who lost a 20+ year employee to a fast food franchise for more money. And that's just reality. I certainly am not going to go far down this path because it's not relevant to the topic that I'm commenting on, but you will see, if you haven't already seen, a cost rebasing study. Statutorily, the Department of Health is required to rebase rates for the developmental disabilities waiver at least every 3 years. That was completed, and the report came out October 1st. If you would like a copy of that, certainly please reach out to me. If you'd like to sit down and talk about the, all 90 or 100 pages of the report, I'd be happy to do that as well. But certainly that's a big part of it. I think training and the elevation of the direct support profession is another thing that certainly would address our workforce issues. Unlike some of the commenters earlier, direct support professionals have, at this point, very, very little upward mobility, very little opportunity for development and credentialing and those kinds of things. I can tell you that at least 3 of our members have put into place a credentialing program for the direct support workforce, which I believe development and the opportunity for development is key. I think it'd be a really good thing to look at working with maybe the community colleges, possibly the university, to look at even an associate's degree in direct support professional or a certificate program, something along those lines. So money, development, I think, are the 2 things that come to my mind first.
More questions for Mr. Gardner? I would like to apologize for not having you actually on the agenda. I should have thought of you, and I will try to do better.
That's
in the future.
okay. I knew where you were. So thank you very much, Madam Chairman.
Okay, very good. Thank you. Is there anyone else from public comment on this issue? Come on up, Marilyn.
Madam Chair, members of the
Hello.
committee, Mary Lynn Schickish, and today I'm representing the Wyoming Primary Care Association.
Ah,
Good afternoon. I'm Tracy Brocious. I am the CEO at HealthWorks.
The Wyoming Primary Care Association is an organization, and just for benefit of the committee, there are about 9 programs in the state that are community health centers, or what is known as federally qualified health centers. And they're programs that basically are required to provide services no matter whether a person has an ability to pay. They're required by federal law to also provide a sliding fee scale based on ability to pay, and they must be a nonprofit or a public entity. Here in Wyoming, they're all nonprofits. The notion of a public entity would be an example of Denver Public Health Hospital. The big public health hospital in Denver also has these health centers associated with them. The programs are, for instance, in Casper, the Healthcare for the Homeless. Similarly, in Cheyenne, it's Crossroads. Those are the homeless programs. Up in the Basin area, there's a program called Heritage Health Center in Powell. They also have an agricultural workers program where they provide healthcare agricultural workers. And they are expanding a bit throughout the state. For instance, they're going over to Loveland into the Grable area. And we wanted to share with you today that similar to what I know you've heard before is the same problems existing with this particular group of providers and their staff under the certain circumstances of the pandemic. And I thought it would be most useful for all of you to hear from Tracy and what she's experienced here. And with that, before she does, I would like to offer with the committee for consideration with many of the providers that have spoken today, if there might be a possibility through the budget process to consider, as has happened for some of the providers in the state, some potential retention dollars, which might be in the form of bonusing or some small bonus in the terms of recruitment of staff, because what you'll hear from us is similar to what I think you've heard from others. My second thought would be a recommendation that you reconsider funding a program that is currently on the statutes. And I'm sorry, I don't have the numbers at my fingertips, but Chairman Wilson knows exactly what I'm talking about, which is a recruitment retention dollars to providers to help recruit some of the out-of-state, specialty positions that we need in others. I think those are two areas where we could give some consideration going forward. Thank you, Madam. I'll turn it over to Tracy.
Okay, and Tracy, and so before you start, am I correct in being able to congratulate both of you on new jobs? Do I have that right?
No, Madam Chairman, I still am a contract public policy working for the Primary Care Association.
Okay.
And as I understand that Jan Cartwright did retire at the end of September and they are currently recruiting her replacement.
Thank you. But Tracy, that's
Yes.
new, isn't it?
Yes, this is a new position for me. Thank
Oh,
you.
congratulations. Okay,
you.
go ahead.
Thank you for a little bit of time today. I just wanted to kind of give you a little bit of an insight of what it looks like in a community clinic. HealthWorks here is, we have a patient panel of about 4,000 patients, just shy of that. About 92% of my patient panel are below 200% of the federal poverty level. And 60% of those folks are actually under 100% of federal poverty, which makes them in the Medicaid gap. We serve anybody who comes through our door. We take all insurances, but we'd also offer a sliding fee scale. One of the things the team I have, we actually have a broad array of services. We do primary care, we do mental health services, dental services, and we have a full pharmacy available to all of our patients and the community. This has been a great team to join. It's been a very cohesive team through the pandemic. They have actually experienced very little turnover because they are quite loyal to each other and to the mission of the clinic. I do have to express my concern that can very quickly unravel because they are feeling the stress of the pandemic also, just like everyone else has shared today. But let me give you a little bit of an insight what that looks like on a day-to-day basis. The team was very resourceful during the pandemic and had to figure out how do we manage a very sick population and very vulnerable population that no longer had transportation due to busing systems and things like that shutting down. And so the team was very creative in the way they rearranged their scheduling system. They see our patient panel, our well patients, if you want to put that in the morning, and have reserved the afternoon sessions and appointments for what we call the sick visits. But what a sick visit actually looks like is we have one room that we have isolated as a COVID room because we don't have any negative pressure rooms in our clinic. And the rest of those patients are actually screened in the parking lot. Our providers, they suit up in whatever the weather appropriate clothing is, which may be your boots and parka. And we bought extra large PPE to fit over their parkas. Their N95s, their face masks, and all of their medical equipment, including the rolling oxygen tanks if needed, and go out and serve these patients in their cars. Because that we, the infection control purposes, we can wipe down a room, right? That's not the concern. But if you have a COVID positive patient in a room, that room has to stay dormant essentially for 45 minutes for the air to exchange in that room for it to be ready for the next patient. Well, when you have a full patient panel in the afternoon and we're serving anywhere from 10 to 25 patients in an afternoon, we wouldn't have, even if we had all of our rooms converted to COVID rooms in our clinic, we do not have enough space. So the team has been very resilient. And when I inquired, like, why are you treating people in the parking lot and how effective is that? They're like, but this is just what we have to do. These patients need us. So I just wanted to kind of let you know that there are other front lines and to remind you that there are 16 of these locations throughout the state doing very similar, very creative ways of treating this incredibly vulnerable patient population. So.
Super. Questions for Ms. Shikic and Ms. Brochus? No?
Right.
Okay.
Thank
I
you.
guess we won't ask for a tour right now. We might not be. we might
Well,
be
you're
in the
always
way.
welcome. You're always welcome.
Okay. Yeah, it's like from the car, we'll have it. It's a drive-through. Okay, any more public comment on this workforce issue? I don't see any. Okay, then, what I think we will do, we have, probably, it won't be very long from Director Cooley, seeing as really none of the unemployment related bills passed the special session. And then actually, I'm going to go to Mr. Hayes because he's also sort of a report. And then we'll take a break and circle back to the PBM. So, Director Cooley. Give her a poke. She might have fallen asleep back there. Welcome. You're kind of worn out, Director Cooley. Are you okay?
I'm feeling a little worn out myself.
Well, I don't know how that could be sitting here with us.
Madam Chair, members of the committee, my name is Robin Cooley. I'm the Director of Wyoming Department of Workforce Services. It's a pleasure to be here with you today. I have with me Mr. Jason Wolf, who is Administrator in our agency over our workforce standards units, which includes OSHA as well as workers' compensation. And I guess I would ask a point of order. Do you want us to talk first about the OSHA rules and then move into work comp and UI after the break? Or I do have quite a bit of information about unemployment and quite a bit about workers' comp. So it might, and we can run through that quickly because I don't know how much of that you really want to hear. So we can go pretty quick, but I need you to let me know.
Well, I was going to do all of your work and get in Mr. Hayes before we circled back, but I don't know, how long do you think you have? How much information do you have? So the reason that I started with you on the agenda was because before the special session, it looked like there might be some bills dealing with setting up sort of a parallel quasi unemployment insurance system. So if that had happened, I was curious to see what that was going to look like or how that would go. Seeing as that didn't happen, we don't really need to hear about that. Are you reporting to Minerals Committee as well on the UI and workers' comp systems? I mean, are they, because I know sometimes they take that sort of thing into consideration. Has that been part of their request of you as well?
We have, Madam Chair, we've reported to them in part as well as JAC is, I believe.
So I'm not
Same information.
If there's something specific then to us, because I mean, we don't all need to know everything if we're not going to take action. And usually Minerals or JC will probably, I assume if there's action that needs to be taken, we'll probably take it. So you can probably kind of scrunch that down somewhat. And so then I think really the interest at this point might be more on the OSHA enforcement or the state primacy and that kind of thing, because I know there's been a lot of discussion about that, and we would probably be could stand to be better informed.
Madam Chair, that sounds good. We'll start out with Mr. Wolf then. If you want to take a look at the PowerPoint that we presented, if there are any questions related to that, we're happy to answer questions and with anything related to the new executive order or non-charging or any of that, as well as the workers' comp. So I'll turn it over to Mr. Wolf, please.
Mr. Wolf.
Good afternoon, Madam Chairman, members of the committee, Jason Wolf, Administrator for Workforce Standards. I think just an update as to where we sit today with the OSHA rules that were released to the Federal Register on November 5th. So I think maybe just back up a little bit. I think everybody knows that there's actually two rules that we're dealing with. We're dealing with the emergency temporary standard for that's specific to the healthcare industry on the OSHA side, and that was released back in June of this year. The new one that was released November 5th is the one that we've been talking about through the special session that would mandate vaccines for those employers that have over 100 employees. We are still currently working through some of the nuances of that. It seems to be changing by the hour, as you can imagine. Essentially where we sit today, however, is, I guess maybe I'll just pause for a minute, and I did provide you guys with a sheet that kind of gives you a little bit of history and background on OSHA and some of the timelines and stuff that we have as a state plan to adopt those standards. To be considered at least as effective as our federal counterparts.
Just because I have a lot of papers here, hold that up so I can see what I'm looking for in my.
So it was fairly generic, Madam Chairman. It just is titled Wyoming OSHA.
Oh, come on, next time you gotta like copy it onto like lavender paper or something for me, would you?
That shows that I kind of put some of this together myself. We didn't have a team of people doing it, so otherwise it would have looked a lot prettier.
Hang on, I'm getting there, just a minute. Oh, here we are. Nope, that's not it. This looks like it has holes on it, so. Well, oh wait, here, there's just, oh, I did have it. It's somewhere. Well, I know I've seen it. I'll just keep looking here. Oh, all right, thank you. Thank you. Okay, are we at least mostly there? Or you look on with your neighbor? It's not kind of cheating in this classroom. Okay, go ahead, Mr. Wolf.
Okay, Madam Chairman. So, and along with that, I did provide the three fact sheets that all kind of look like that. If you find them in your booklet, and those are in relation to the new emergency standard. So, as you guys have probably heard in the news, Madam Chairman, the new standard is supposed to take effect in large part. The vaccine part of it is to take effect. Everybody should be vaccinated by January 4th is kind of what that standard says in short. So as a state plan, Wyoming OSHA, we have, again, to remain at least as effective as federal OSHA, we have to adopt the standard as such to that effect. So I think where it is today, though, we are kind of letting some of the court process play out prior to moving forward with the adoption process on that. In large part, the consensus seems to be that the Fifth Circuit of Appeals has stayed the mandate. I think there's some varying legal minds on that, but I think Wyoming's position on that is that was applicable to the nation. And then what our understanding is, and we've attended a few different webinars this past week with federal OSHA. Our understanding at this point is that because there have been so many appeals filed on the vaccine mandate for at least the OSHA one and others. But the OSHA one, what they intend to do is take all of those appeals, roll them up into basically, one circuit, because there's so many different appeals filed in different circuits. So for example, Wyoming is part of a coalition that filed with the 8th Circuit. The 5th Circuit has already ruled. I guess long story short is we hope to know, and this is according to some of the stuff that was on the federal OSHA webinar and their Solicitor General. So the 10-day timeframe from the release of publication is Monday, the 15th. What we understand will happen at that point is the parties that have an appeal in place will effectively get a ticket to what they call a lottery. That district is then put in the hat, so to speak, for it to be drawn at random to determine which circuit will ultimately hear all of these appeals. So I think and I guess I'll pause there and see if anybody has any questions. And again, I'll preface this with, I am not an attorney. I just play one today. But in all seriousness, I think there's just been so much information coming out. Like I said, what I tell you today may very well change tomorrow. So
is there a specific circuit that we should pray for?
I will, Madam Chairman, refrain from opining. but,
Okay.
um,
Any questions just for now for Mr. Wolf? He's obviously going to go on, but no, go on ahead.
So after Monday, what we understand will happen is that fairly quickly, they expect that judicial lottery, they call it, to take place. And then we will know probably by Tuesday which circuit will ultimately hear all of these appeals. From there, what we expect will probably happen is, all the parties to the appeal will probably, again, motion that new district for a stay. And either that'll be granted or it won't. If it's not granted, I would imagine, all the legal minds seem to think that ultimately the Supreme Court will have the final say on all of this. In my understanding is that it will move in a very swift fashion. So we hope by the end of next week, we have a little bit more direction to give both the legislature and employers. Employers are wondering, we're getting inundated with calls from employers about what do we need to do? How do we need to act? In the background, what we are trying to do is get all of our ducks in a row so that if we do have to adopt, we're ready to kind of make that move and roll with it. But I'd like to give you better news, but for now, we're just kind of standing down and waiting for some legal things to play out.
Questions for Mr. Wolf? Representative Stivar.
Thank you, Madam Chairman. Do school districts fall under OSHA?
Madam
Mr. Wolf?
Chairman, Representative Stivar. So yes, under Wyoming, because we are a state plan, that is one of the reasons that state plans operate the way they do is
Follow up? The state plan I got here the other day, I can't find where school districts fall under OSHA or even Wyoming under the state plan. Is that state plan been updated since 2020?
Mr. Wolf?
Madam Chairman, Representative Stivar, I'd have to look. I think what we infer is that state, county, local, city governments are all encompassed under OSHA. We consider the school districts kind of a quasi-governmental agency.
Or questions for Mr. Wolf? Oh, Representative Connolly.
Yeah, thank you, Madam Chair. Mr. Wolf, I'm on the third page of your handout, and you have a summary of quarterly census and employment and wages. And it's not a meeting. That's what I was. We've got with mining and without mining, mining being under MSHA, so we're gonna put that aside for a second. Okay. So the industries that employ 104 individuals is 222. Oh, I've got, so we have 222 private employers. Now, the number of government employers, that's in addition to 22.
Madam Chairman, Representative Connolly, that's correct.
And so there would be 3,000 individuals who could possibly fall under the OSHA requirement.
Madam Chairman, I think I'll walk you through that. And I'm having a little trouble hearing you. I'm not sure if your mic is on, sorry. But if we exclude mining, because mining is not under OSHA jurisdiction, that is MSHA's jurisdiction. So we excluded those numbers from mining. really what we are looking at, total affected employees that would be affected, or excuse me, affected by a vaccine mandate would be roughly about 106,462. If you add those private employment numbers of 53,097 plus 53,365.
Representative Stiver.
Thank you, Madam Chairman. These numbers include railroad employees.
Mr. Wolf.
Madam Chairman, no, OSHA does not cover most of the railroad. And that there's some caveats to that, Madam Chairman, that where in certain instances, some of that will fall under our jurisdiction, but that is another federal regulatory agency that takes care of that.
Follow up. I see you handed some of the emergency temporary standards out. This one is the summary COVID-19 vaccine and testing ETS. On the second page, employees, I'm going to read this. Employees of covered employers not subject to the requirement. ETS does not apply to employers who do not report to a workplace where other individuals such as coworkers or customers are present, employees while they are working from home, or employees who work exclusively outdoors.
So what
How's
a
that
question?
going to affect Wyoming and what you're doing?
Mr. Wolf.
Madam Chairman, Representative Stivar. Yeah, great question. I mean, and I'll be really honest with you, is that this just dropped Friday, November 5th. It's 498 pages long. And so we are still wading through some of this. And just to caveat, these handouts that I gave you, those that Representative Stivar held up, these are actually on the federal website. So some of this, while handy information and good information, especially timelines, I would just kind of throw in a caveat that those timelines are for federal OSHA. Because it's a state plan here in Wyoming, those timelines will vary a bit.
What questions for Mr. Follow-up? You're good, okay. Okay, so actually I do, having brought up the 490-page document, which I highlighted that one too, committee. I note as we get toward the end of it, the department actually suggests that they are interested in finding out what employers think about applying this requirement to businesses with under 100 employees.
Yeah.
So I know it's in the early days yet. Have you heard any further discussion of that or rumblings or anything you care to pass along of interest?
Madam Chairman, yeah, so at the risk of being very presumptuous, I would say, having attended some of the federal webinars, I do get every sense that this is just the start, so to speak. And that I think they're starting with this amount of people because they feel employers that are this large, obviously, probably have the human resources to do it. But I got every sense that if this works, it will trickle down to lower employers, but that's just a guess.
No, again, so committee, as I say, I have read through both of the regulations, the OSHA and the CMS, and I have highlighted, obviously, there are things that were of interest to me in highlighting, but thinking of the Labor Committee. So again, before we leave at whatever time it might be that we leave, and sorry, I'm very fond of Senator Baldwin, but the sun is coming through the window right in my eye.
It's not bouncing off my head.
No, that's good. And if there's any bald people, if you just disperse one way or the other, okay. Any more, I do have another question for Mr. Wolf, but I just want to be fair. Oh, no, it's over here. Okay, the second question I have, and I initially thought of maybe trying to draft it up as a bill right away, but I realized that seeing as it's not been noticed, I can't. When I went on the OSHA website, I found it interesting that among their FAQs, they plainly stated that because they didn't want to disincentivize employers from offering vaccines, they are deliberately not going to enforce the requirement that when you have an employee who takes a vaccine that you have either recommended or mandated and has an adverse side effect, they will not be enforcing the requirement to report that. specific to the COVID vaccine, which whatever you think about vaccines seems to me be kind of a deliberate avoidance of seeing what's happening to labor health. So my question is, and seeing as you're here, and I as I'll ask you now, would it be acceptable under the state plan? And so I was delving into the statutes where it says that, that it authorizes the workforce services and the enforcement division to work with the feds, and we can't have things that are more stringent. Would it be though acceptable to insert in their language stating that if the federal OSHA declined to enforce requirements that were in place, that the state OSHA could still, that employers would still have to report that to the state so that somebody is tracking it? Would that be acceptable under how you guys work with the state plan?
Madam Chairman, and I think some of this kind of might go back to Representative Warp's question on liability a while back. But I think, and again, I think your language would probably not harm us. But I think my sense is why they're not enforcing it, or why we probably wouldn't enforce that, is because that'd likely get reported through. And I'll give you an example. We cover these all the time, but somebody had mentioned that, they often require like a flu vaccine or sometimes a chickenpox vaccine for healthcare workers to work in certain settings. We deal with, on the workers' comp side, those quite frequently, where somebody has an adverse reaction that is then covered under workers' compensation. So in all likelihood, it's going to be self-reported by the person who had the adverse reaction. If that makes sense.
And I'm not sure if I have it immediately right here, but too many papers again. There's evidently some sort of OSHA report that the employer is supposed to fill out about adverse effects of other things, but they're evidently not going to be asked to fill out the report on this. It said until May 2022 or later, maybe. I mean, that said it right on the website like that. And I just find that that's sort of an odd way of enforcing worker safety regulations. I'll talk with you further about that, I guess, it'll have to be an individual bill if I want to have a reporting option, but I'll check with you further now that I know that you're the guy. Okay, last questions for Mr. Wolf. Oh, okay, thank you very much. Director Cooley, do you have anything else? I sort of pushed a few things off your agenda, but is there anything else that we need to know?
Madam Chair, no, we're here for questions, so let us know if you have any. Thank you.
Okay, awesome. Thank you very much. Is Mr. Hayes sitting behind the pillar? I saw him coming. I just want to ask, before you get up too far, we're going to want a break. I would like to kind of let you present and go back to work. But if you're going to be a half an hour, I mean, it was a good report, but tell us if you think you want to report, say, under 10 minutes and leave, or would you like us to take a break first so you could talk longer?
I think we could go to take a break first because we have.
Okay, well, in that case, committee, it's 3:32. We'll take a 10-minute break back to 3:42. Thank you.
Good afternoon, Madam Chairman, members of the committee. My name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program for the state of Wyoming. Under the 2000 legislation, we were required to prepare a report surrounding the exploration of bundled payments for reimbursement patterns for hospitals and medical providers, surgicals, et cetera. And we hired Aon Consulting to do that. In August, we provided a report, which is fairly dry reading. It does have a pretty good 2-page summary up front. What I have done is asked our consultants, Aon, under the leadership of Wendy Smith, to give us a better presentation today, a little bit easier to follow, which has been passed around. It'll look like this. And they'll put it up on the screen here, and I'll ask Wendy to take over on this presentation.
Thanks so much, Ralph, for having us on. Just wanted to go through this deck and take you through what we see as happening across the country. My name is Wendy Smith. I live in Dallas, Texas, and I represent Aon in their delivery system transformation team. I'm the national leader. And what we do in that space is primarily work with large and jumbo and public sector accounts to help move to value-based solutions across the country. Can you progress the slide, please? So we're going to unpack surgery networks and bundled payments a little bit more for you, and certainly take questions that you might have. But employers across the country are looking at these solutions to reduce their surgical medical spend in their most common surgical categories, such as musculoskeletal, cardiac, bariatric. Oncology is a fairly new one. And then procedures like maternity, deliveries, colonoscopies, and things that are lower cost procedures, but have high utilizations. So what is the situation? So the value-based bundle increases the quality while lowering the cost. And how does that work? So in these surgical networks and in bundle payments in general, high quality networks are built of surgeons and facilities. And if you look at the surgical spend for most employers, it represents about 20 to 25% of their total medical spend. But if you look at the bundles, then that actually lowers the spend. If you compare fee for service to bundle by procedure, that lowers the spend by somewhere in the neighborhood of 25 to 50%. Another reason that employers like this solution is that you can do it off cycle. So if your anniversary date is January 1, you don't have to implement this on January 1. You can do an off cycle implementation, which allows for more specific communication and lots of different dialogue around how this is going to work and is there an incentive to use this, et cetera. How does this work? The surgical networks look at vetting. There's a heavy amount of vetting of the quality outcomes in certain ways. So credentialing, for example, is the surgeon board certified? How many sanctions has the surgeon had? How many medical liability cases? Have they moved around a lot trying to get out of one state and go to another with their record? So that is one way. And then a volume basis too. The more volume, the better that they get at the surgical procedure. Another thing that is looked at is appropriateness of care. So if you are already seeing, let's say, an orthopedic surgeon and you've been evaluated and they say have the surgery. If you are with the surgical network, there's a secondary assessment of appropriateness of that surgery. So again, if you're going to this high quality surgeon and they look at this case in a secondary way and they say, you know what, we don't feel like this candidate is appropriate. Maybe they have some comorbidities or issues that are complications, or maybe they just need physical therapy instead of surgical intervention. So if you look at the contracts, these surgical networks are working across the country in practically every state. Basically within about 150-mile radius, you would be able to go into one of these surgical bundles. And they also go very deep. So musculoskeletal, cardiac, bariatrics, as I mentioned before. Why? In this movement from fee for service to bundles, there's a lot of cost savings. There's better quality outcomes, lower complication rates, lower readmission rates due to these quality high volume surgeons. And also this is a very, very important part in my estimation, because in the carrier space, Rarely are you getting any kind of concierge or care navigation. And in these surgical networks, there's care navigation that is built in. There are care advocates that are built into this process that take you from a pre-surgical to your end of your surgery. Next slide, please. So the difference in, you guys have already legislated this, but just to point out a couple of things here on, the carrier versus the third-party solution. The carriers are a little bit handcuffed because they have broad PPO networks. So trying to steer to one health delivery system or one surgeon is difficult for them. Oftentimes they don't have the capabilities to pay on a bundle payment because their claim system is more of a fee-for-service claim system. There's many reasons outlined here, but you've already made that decision. So I'm going to move on to the next slide. So what's happening in the market? If you look at, companies like Walmart and the information that they've put out, they've actually done quite a few of their own centers of excellence and bundle payments, and it is mandatory for their employees to do this. So in 54% of the spine surgeries and 20% of the joint surgeries, there was that avoidance because there was an appropriateness of care given, and it was deemed that that spine surgery or that joint surgery was not necessary. There are other means that were more appropriate. If you look next at the reduction in major complications for high and low quality providers, 6.5% versus 17.1. And Ryan will talk about some of their own specific percentages in just a few minutes. The hospital prices for knee replacements have gone up dramatically, 27 over the years. And then if you look at, we're going to get into this RAND study next slide, but if you look at this 180% to 400%, there is very much quality and a cost variation in providers that exist in a given market for the same procedure. So you could be paying 180% of Medicare up to 400% of Medicare for the same procedure in the same market. Next slide, please. The RAND study that came out, there's actually version 3 out now, looked at across the country, what is it that commercial employers are paying for inpatient care? And it was deemed that compared to Medicare, which at 100% of Medicare versus the commercial average was 247%. So we see a lot of that, kind of that push to the commercial population and paying the bill for that. So that's another reason that we need to be diligent in moving to bundles. Next slide, please. So just to hit on some of the what's happening across the country, 27% of large employers are expanding centers of excellence to include additional conditions in 2020. We've seen that also in 2021. I'm sure we're going to see that in 2022 as we move into that strategy time. 47% of large employers are implementing COEs in orthopedics. Very much the mainstay of bundles is musculoskeletal procedures. 38% of large employers are implementing COEs in fertility and maternity. 17% are going into maternity. We're seeing movement into mental health, and as I mentioned, also oncology. Next slide, please. So I'm going to turn it to Ryan Burke to talk about Surgery Plus and why we partner quite a lot with them across the country and some of the more specific things that they can drive. Thank you.
Thank you, Wendy. It's a pleasure to be in your company. I guess this afternoon or this evening, depending on where we're all sitting today. I want to dive in sort of how we partner with AON on this and sort of what our experience is, but most importantly, the how. How are we able to do this, and how are we able to sort of transform the way we look at both quality and outcomes, the member experience, and then also ultimately, what are you paying for these services? So if we flip onto the next slide here, we've kind of taken and broken it down into 3 very important pillars to consider when you're evaluating alternative solutions to what has become the traditional care pathway. And the first is the members are what matters. We've got to get quality first, and we've got to get it right. As Wendy mentioned before, there's a huge variance in quality, and we think it starts with the surgeon. Oftentimes we're very focused on the name on a building, We believe that the best surgeon in the really good facility, that's what generates the most positive outcomes. We monitor these on every one of the surgical procedures we perform. We'll get into it in a little more detail in the coming slides, but let's focus on quality first and improving the outcomes for folks. Once we identify and align on quality, then it becomes, well, now what's fair price? What is the right price to pay for the services that are rendered? And we're able to use a lot of data. Right now, we're at about $43 billion worth of claims data to understand in any geography by procedure code, what is the average commercial reimbursement? How does that compare to Medicare? And where can we get that still is valuable to a provider, but isn't overinflated and becomes aligned with quality? And then we believe in access. Our sort of our final pillar there is really, there's a practical answer, and then there's the answer that sounds really good on paper, but not always practical. The latter is, well, we work with, that call it the 5 or 6, 7 best known hospitals in the country. And no one would argue that they've got great quality. The problem is it's not practical because people can't get to them. And so what we believe in is bringing that quality to a more local level so it becomes convenient for people, accessible to people. Then you can actually influence change because practically it becomes more realistic that they'll actually use the services that you're offering. So we move on to the next slide. We'll get into that quality piece, and I'll try to be concise as I can, but I'm somewhat passionate about this, so I apologize if I get long-winded. We look at credentialing surgeons and that critical piece of knowing not just you're going to a hospital, but which specific surgeon are you going to within that hospital. And we look at it from a sort of a staging process. The first stage of that process is, let's just pre-screen surgeons. Let's make sure that they have got an active and up-to-date license to practice medicine in the state. They're board certified. If they need to be recertified, they've actually gone through the work, kept up the continuing education, and resat for those boards that happen every 10 years. Do they have that extra year of training following residency that's hyper-focused on a very specific surgical area within a specialty that's proven across multiple literature articles to produce better outcomes? Has a state deemed that they've done something egregious enough that they reprimanded, suspended, or revoked their license to practice medicine? Unfortunately, we don't communicate that well across state lines. So it's really easy to have your license reprimanded or suspended in Texas or in Florida, where I'm sitting tonight, and move to California and no one's the wiser. And then most surgeons are going to get sued in their career. Harvard said about 99.6% of surgeons will get sued before they hit the age of 60. But you should actually pull and look at those lawsuits and where they sued 2 different times for putting in the wrong side knee replacement, or were they sued 2 different times and both times were during their residency. They're the 30th person named on the lawsuit, and it was just one of those catch-alls, and they didn't actually ever touch the patient. And then finally, it's important to know that when our members, and if we're fortunate enough to work with to stay their members, they're going to go and they're going to read online reviews and they're going to do their own research. We want to make sure that that optically looks appropriate. For the surgeons that make it through that, and it's somewhere between 20 and 40% of surgeons, so a shockingly low number, they then move on to phase 2. And phase 2 is where we really get into the weeds. There's an application process. It involves our medical advisory board. It involves our credentialing board. And so there's multiple parties working together to make sure that those that come into our network are the ones we want. So kind of putting that into practice on the next slide. This was an actual case study on the left. This is every orthopedic surgeon that participates in Blue Cross, United, Cigna, and Aetna networks. So in all 4 of those, in Tampa, there's 121 of them. We put them through the pre-screening, 25% made it through. So a shockingly high number that are eliminated before they even get to that. And that's not saying they're all bad surgeons. It's just saying if we have the choice, we'd rather exercise that choice to go through the ones that have met those criteria. They then move on to what we call interview and on-site part of the credentialing process. So where we're collecting information on application around surgical volumes, their protocols with regards to medical optimization for surgery, their outcomes. Are they doing things to lower or eliminate opioid usage after surgery? All of those things are really important. And then there's oftentimes an interview with a fellowship trained surgeon in our network to make sure that they feel the new surgeon is up to par and can come on board. And then finally, we then need to look at the facilities that surgeon performs their cases, and looking at CMS required reported data, leapfrog data around hospital acquired conditions and readmit rates and complications. And when you put that all together and it looks great, then you can start talking about price and start talking about contractual language. And so, putting into practice, how does it work and what have the results been and why we think this is a great way to measure quality. On the next slide, we talk a little bit about what our outcomes have been. And so if we look at 2020 and 2021, again, all of our decisions, we're relying on fellowship trained, top end specialty surgeons across the country that sit on our medical advisory board. This is just looking at orthopedics and spine. While we cover 1,500 different surgical procedures across our network, this is top of mind for a lot of folks. We look at joint replacements, 1,560 joint replacements with a complication rate through our network of 0.32% compared to the industry average of 8%. What did we pay for those joint replacements? On average, $20,000 all in. That's everything from surgeon, anesthesia, facility, implants, everything that happens within the four walls of that facility. What were the average carrier rates? Around 48. For your ACLs and rotator cuffs, we did over 3,000 with a 0.1% complication rate and a cost of about $3,500 per procedure. Industry averages are somewhere between 4.5% and 5%, and typically around $8,000 to $9,000. And then spine surgeries that have a historically very high complication rates and high readmission rates and high cost, performed over that same time period, 973 through our network, 0.81% complication rate, and average cost of about $17,000 compared to 13.7% industry complication rates and $52,000. So the process can work and has worked effectively across our 200 plus employers, including multiple states and municipalities, and about 2 million members. And we'll have about 3 million members on this platform as of January 1 across 300 employers. So as we move to slide 12, real quick, kind of getting into that cost and how it works. We've taken a slightly different approach than maybe what Medicare did and what some others have done with bundles. So we need to create flexibility to not force the administration of a bundle onto a provider that's not capable of administering appropriately. Because if they're not capable of paying multiple different providers within that bundled payment, you can run into a situation where members get bills that they shouldn't have gotten, and you can create all sorts of issues. So we decided instead to take a market by market approach, and either we administer the bundle, meaning we contract with every piece of that bundle individually and we pay them, or we pay that same amount to one counterparty and they administer it to all the downstream parties to that bundled agreement. And that flexibility allows us to leverage price and have a more expansive network, because you don't want a facility that doesn't employ their surgeons, doesn't employ their anesthesia, and outsource their pathology, trying to manage payment to all of those. You'll end up with a situation where it just gets messy. And so when you start to look at kind of how do we contract and what does that look like compared to your commercial, compared to Medicare, because it's really nice to come up and say we save people a ton of money, or 50% or 60%, but it's all relative to what you feel the carrier reimbursement is. And our database tells us, as example here, that a knee replacement, it's somewhere around $15,000 all in through Medicare. It's somewhere around $40,000 or 266% of Medicare through commercial carriers. Across the country, on average, we're at 127% of Medicare. And you can see through the other procedures, it stays pretty consistent. We're often asked, how can you get the best providers to take that much of a discount and reduce their cost by that much? And I think the color coding on here kind of tells that story. If you believe that the surgeon plays a key role in the outcome, we can see the surgeon isn't taking nearly as much of a pay cut as your facility is. Because typically somewhere between 78 and 85% of the total cost of a surgical event is driven by facility reimbursement. And then somewhere between, call it 7 and 10% for the surgeon and 7 and 10% for anesthesia. And so if we can show that accretive or incremental referrals that are paid efficiently, quickly, and without a lot of the kind of gamesmanship that goes on between provider and payer, we can dramatically lower the cost and still be an attractive found or new source of revenue for providers. So as you go on to the next slide, and I'll try to speed up here, give a high level overview here of kind of what's included. Think of it as everything from admission to discharge. We do cover pre-op consultations, and then the post-op consultations are considered part of that bundled episode of care. But there's certain things that aren't included. We don't warranty the outcomes because frankly, we think it's bad finance. If you think about why an employer becomes self-funded, it's the same proposition. You're gonna overpay for a warranty if you're controlling for quality. If you're not able to control for quality, then a warranty makes sense. But when you can control for quality on an incremental surgical basis, you're gonna pay more each time for the warranty than it's worth it. But we do cover everything, I said, from those pre-op consults, surgery, and then those follow-up visits. The next slide, and what types of procedures do we cover? We think it's important to have as wide of a funnel as possible. Surgery is a very, very stressful event to go through. It's why we pair every member with a dedicated care advocate. It is one of our employees that is trained to be their concierge service from start to finish, whether it's scheduling, travel and logistics, taking all of that off the member's plate, because whether you're having a hernia repair or carpal tunnel surgery or a joint replacement or spine fusion, they're all stressful. And so we think it's important to widen that funnel, and you can do so when you focus on surgeon quality and appropriateness of venue. So our network is built of hospitals and surgery centers, allowing us to cover more procedure types and impact a larger number of people and a larger percentage of your overall medical spend. On the next slide, so what does that look like on our network? This left map, that is what the traditional Center of Excellence model has looked like. It's a dozen or so very well-known hospitals throughout the country that do produce great quality, but you lose a couple of things there. One, you lose utilization because people don't want to get on a plane for surgery. And two, you lose quality if you think the surgeon has an impact on quality because you're contracting purely on the name of the facility and not necessarily who's operating on you. And so if you go to a Mayo Clinic, you're at a great facility. There's no questioning that. They produce great outcomes. But do you have the fourth-year resident assisting, the fifth-year resident doing the surgery, or the attending? And so managing that part of the process, we think, is critical to ensuring positive outcomes. We've got, as I mentioned, over 400 plus facilities. We work with the state of Alaska, state of Delaware, state of Florida. State of Alaska, everyone gets on a plane to the lower 48. State of Florida, most people stay within their local market. But on average, people are driving around an hour. As of right now, as you'll see on the next coming slides, probably a little bit further today, but we believe we can continue to build and expand our network in your area. We can kind of cruise through this real quickly, but it's, again, that combination of well-known teaching institutions, so that if a member of the state of Wyoming needs a revision cardiac valve replacement, well, we've got the ability to take care of them through the Cleveland Clinic, one of the best places in the world you could be for that surgery. But if you need your ACL reconstructed or your knee replaced, well, there's phenomenal options today through our network in Denver that maybe not everyone has heard of, but they produce great outcomes. And going on to the next slide, we ran a couple of different case studies to kind of talk about what we think this can and should look like. As we look at our current network today, you'll see there's not a lot in Wyoming. It's not probably overly surprising. We don't have a huge membership in Wyoming. Most of it is through employers that have worked with us for years, like AutoZone, Compass Group, that have members all over the country. But we don't have a large employer based in Wyoming. And so we haven't had the need to go in and really get into that contracting mode of building new network. But since we first started talking to Ralph and his team, we went into that contracting mode. And so you'll see on the right here that we are already in deep conversations with multiple facilities, multiple surgeon groups, to make sure that, one, they meet the quality standards, and two, that we can come to an agreement on what is fair and reasonable reimbursement. This starts to look a lot like some similar states. And so on the next slide, we start with Florida, and we see kind of the impact of working to bring bundled payments to a state. So on the left map here, this was our network at the time we contracted and won the procurement for the state of Florida. They went with our solution because we had the deepest center of excellence model in the state of Florida. On the right shows you where we are today. That network has continued to expand, continued to bring depth and maintain quality and cost, because we now have more members, which creates more leverage. It creates more urgency to get more and more convenient for members. And then on the next slide here, we'll show the unintended positive consequence. So the state came on board, our network continued to grow. And since then, we've brought on Florida Power and Light, which is NextEra Energy, Waste Pro, a large waste management company in Central Florida, multiple school districts, multiple counties, folks like Winn-Dixie, which is Southeastern Grocers. And not on this page is we're in the process of implementing an additional 12 to 13 municipalities and school districts in the state of Florida that are all benefiting from the bundled contracts that first were procured by the state of Florida through our program. Florida has also benefited from that as our network's grown. We get higher utilization, and they've had 100% increase in utilization and ROI since following the first anniversary of their contract with us. State of Delaware on the next is a little bit of a different story. State of Delaware, this was our network prior to being awarded that procurement. And in the state of Delaware, we had one provider. However, we identified during the process that state's pain points were very different than Florida's. Their pain points were there was limited access already. A lot of folks lived rurally. Quality and cost weren't very well aligned, and they're very limited because there were only really two systems or health systems in the state. And when there's only two, it means that every carrier has to contract with both. And so you lose pricing leverage. They get to kind of dictate price because they're the only option. And the state was unsuccessful in trying to go directly contract with them. And they were also very concerned about the idea of working with one versus the other, considering both were for-profit tax-paying healthcare institutions within the state. And they didn't want to pick one versus the other. And so they abandoned the direct contracting. They brought us in. On the next slide, you'll kind of see the results of that. We addressed their pain points, and you'll see the network growth, not only in the state, in where the vast majority of their population is concentrated. We've added numerous new providers. We've been able to get both of those health systems to the table to negotiate fair price and allow us to control for quality at the surgeon level. But the surrounding areas have also grown, because sometimes people actually want to go to Philadelphia or Baltimore. They have a procedure that really is best treated at Johns Hopkins, and we can do that and facilitate it. They've been with us about 27 months. We've produced over $5 million in contract-to-contract savings, an additional $500,000 on the surgical avoidance that Wendy mentioned earlier. And overall for the state, we've done just shy of a 4x ROI, and they're looking to enhance the program next year by making certain very high acuity, high risk procedures mandatory to go through our program because of those complication rates we showed on the earlier slides. Next slide, we've done this with a lot. I won't go through all of them, and I hope you guys have the printout to take away with you, but We've done it with a lot of municipalities, a lot of states, and we continue to show very positive results. The health insurance and benefits teams in the state and municipalities they care about their members. They get heavily engaged. They work with us to create the optimal utilization program, whether it's through communications or incentives and a number of different things. So we've continued to produce positive results for our government clients across the country, and are confident we can do very much the same, partnering up with Aon and their team that's got incredible amount of experience in this space, and we've frankly learned a lot from. And we try to be very, very seamless. On the last, I'll finish talking after this next slide. Try to be a seamless solution. We are appropriately licensed to manage claims. We don't have to integrate and force those claims to be managed through a carrier who struggles. They're not built to do that. So we're able to compliantly manage and adjudicate claims per our contracts. Typically, our implementation process only takes about 8 to 12 weeks. And we try to do all the heavy lifting, working with Aon to make sure that we're not a burden to get live, and that our teams work together to make it a very seamless transition and implementation. I'll kind of wrap up there. If there's any questions, happy to answer them, and maybe pass it back over to Ralph or Wendy.
Questions for Mr. Burke? Senator Furphy. Can you hear us okay, Mr. Burke?
I can, thank you.
Okay, just checking. Go ahead, Senator.
Thank you, Chair. I just have a question about quality of facilities. You may have the best surgeon, but if the facility isn't extremely clean and prone to infections, et cetera, that can be a real issue. Would you comment on that, please? Thank you.
Mr. Burke.
Absolutely, absolutely. It's a very well-educated point. You're spot on. It's why we look at both. You know, we think that surgeon criteria is critical, but once we identify the right surgeon, we then validate that the facilities they go to, whether it's a hospital or a surgery center, meet those standards. So we do actually look at the CMS reported data for readmits, infection rates, complication rates, and also HCAP scores, which are patient perception scores, because we have to admit, like, perception's still important. And so they have to meet and sort of exceed our standards, which is we set the floor at national averages, because our theory, and I think we've proven out, is that if you work with the top half of facilities, but maybe then the top quartile of surgeons, you actually bring that facility up. We also do interviews around what programs do they have established. If you're a hospital doing joint replacements, we need to see that you have a joint replacement specific program that involves ERAS protocols, which is enhanced recovery after surgery, that minimizes the use of opioids. It optimizes your recovery, gets people on their feet quicker and in a better state to recover. Kind of my favorite thing is we ask these surgeons and hospitals, and so what is your rules around eating or drinking before a joint replacement surgery? And most of us would raise our hand and say, nothing 12 hours before, don't drink or eat the night before. Well, for 15 years, we've had literature that says you should drink a Gatorade before your surgery. You're going into an incredibly stressful event on your body, and you haven't eaten or drinking in 12 hours. That's not optimizing you for recovery. And so joint programs and top surgeons, they've been doing this for, a decade, and have proven better outcomes without increasing risk by having a Gatorade before surgery.
Questions for Mr. Burke? So I do have one. So Mr. Burke, the original legislation prompting this study came out of this committee a couple of years ago. And one of our main drivers for this was, not just the question of how can we save the state money, but how can we increase volume at our in-state hospitals. And I understand that you're just starting to build up your network in Wyoming, and that's fine. But so I guess my question would be, what is your experience with, well, we have a lot of critical access hospitals. We only have 2 hospitals in the state that have more than 100 beds. I'm just picking that as kind of a metric. So maybe comparing with Alaska, I don't know if everybody in Alaska flies to Anchorage or Fairbanks. But talk to me a little bit about what you see elsewhere. How can this type of program succeed in an area that has a lot of small hospitals, low volume? What kind of procedures work in that kind of environment?
And it's been interesting, Madam Chairman, I appreciate the question. There is some development happening in Wyoming. Surgery centers are starting to do more procedures. There's a joint replacement outpatient center that's really has some phenomenal surgeons added over in I believe it's the Gillette area. And so there are some things in Wyoming that we are very optimistic about around quality and our ability to get effective and fair pricing. If they meet those standards, we want to engage them. We want to work with them. And I think they'll start to see incremental volume that today we otherwise send to Denver, to Salt Lake City, and surrounding states. So those employees that work for folks like AutoZone, those employees that work for folks like Geldwin and BNSF Railways, and there's a number of very large employers that do have some members up there. And if we can build network there effectively, maintaining that standard of cost and quality, they can see incremental patients that otherwise they didn't see before. When we kind of looked at some of the data here from the state, there is still migration happening out of the state with the current plan. There are people still going to Denver and to Salt Lake. And my theory, while I don't have anything to prove this, is they go there because they believe they're going to get higher quality care. The problem is they can go all the way to Denver and you can still find underperforming surgeons, underperforming facilities. And so while their thought process may be well informed and in their mind, they can end up in a worse place by going there. Our goal would be to keep those people in state unless there's a reason they should go out of state. And if they're going to go to Denver or Salt Lake, let's make sure they're going to highly, highly qualified surgeons that are hyper focused on a very particular special or procedure within their own specialty that have proven successful outcomes over and over again.
If I might also add in a couple of comments here. So I think one of the things that Ryan mentioned in kind of the state of Florida example, and we've certainly seen this across the country with AON, is once you have a client like yourselves, for example, and there's the reality that this is going to happen, and you allow that to be utilized in the conversation, then these health systems and ambulatory surgery centers all have to at least be willing to have that conversation about movement to a bundle and movement to standards that are required to meet the quality metrics.
But so what kind of medical procedures do you generally see that are, and I'm not trying to cast any disrepute on the smaller hospitals at all. I mean, I'm trying to get information to find out how they can succeed, how they could succeed in this kind of setup. What types of procedures do you typically see that are well handled in your network in hospitals that say have fewer than 100 beds? And obviously I'm just picking that as the metric because that's what I had available to me.
Yeah, I think fewer than 100 beds, what we find is not that the hospital is not capable. It's that most of the surgeons aren't capable. And so a lot of times in a more community-based setting hospital, you've got a surgeon champion for the joint replacement. And that surgeon does several hundred a year. They've built the program, they've built protocols, and the staff in the hospital actually all know it. They're all like, well, yeah, that's the surgeon people should see. But there's 8 other orthopedists there that are doing 2 a month. And so it starts to limit your choice of surgeons more often, in my experience, than it does necessarily eliminating more hospitals. Things like cardiothoracic, just being very transparent, they're not set up to be done in a community-based hospital. You know, you can do now stents and pacers even in a lower acuity setting that, you know, is just one surgeon specific type of quality standard. But when you get into your more complex cardiothoracic surgeries, the community hospitals aren't built for it. It's a team approach. There's numbers of layers to it. And so those are things that they're just not going to be well suited typically, even when they can meet other quality metrics for other procedures. Bariatrics is another one. Our bariatrics network is significantly narrower than our orthopedic network. And it's because you really need to require that they've got a program that's accredited through the American Metabolic and Bariatric Society, that they've been reporting and meeting those standards, because bariatric surgery has an incredibly high failure rate, whether it be through complications or not being able to maintain that weight reduction over time. And so you need to make sure they've got those programmatic details outlined and built in and reported on. And so those are, you know, those more complex procedures like that are tougher to do in a community setting.
Okay.
And just to add, what we're seeing across the country is definitely a movement towards outpatient. So whether that's a health delivery system owned outpatient facility, freestanding ambulatory surgery center, or an independent, there's, you know, much more acuity that can go over into that space, and we're seeing that.
Okay. Any more questions for the presenters? Thank you very much. Mr. Hayes, any final remarks there?
I stand for questions, Madam Chairman. If anybody has any questions directly for me.
Questions for Mr. Hayes? So, Mr. Hayes, what is your conclusion as far as the feasibility, you know, you being on the ground in Wyoming, as opposed to the consultants not? I mean, no disrespect meant to them. Do you detect any category of surgery or some other care type thing that would work in Wyoming?
Madam Chairman, members of the committee, this is a tough area because we're looking at two different things in some ways. We're trying to keep care in Wyoming, yet we still need the savings out there. I mean, Appropriations Committee wants me to cut as much cost out of this program as possible and keep those premiums low, but how do we do that and make sure the care is appropriate? When we look at our Wyoming facilities, we only have one integrated medical community group, which is right here in Cheyenne. And even they have their issues. Notice that within this presentation, they talked about the fact, do you have a facility who probably can't handle trying to do the integration where you're going to be including the anesthesiologists and everything and receiving a bundle payment and distributing that. Quite frankly, even our integrated one here and recently helping a member out with their particular bill, 4 items totaling over $60,000. 3 of them were already paid. One of them was not up for, but the facility turned them over to collections. So I question whether the billing department and our only vertically integrated group could handle this. So I agree with what was said here. It's better to have a vendor in place who does that contracting separately and paying the separately to make it work, because we just don't have the infrastructure and volume here. Now, remember, a lot of this is being driven by quality. This is narrowing networks, because in order to really save money, if you're going to take a cut and pay as a medical provider, you want something in return, which is trying to feed additional patients. So in some ways, as we mentioned here, you've got multiple, and I'm going to pick on the orthopedic group because they are one of our most expensive. Second most expensive for the program is orthopedics, cancer being number 1, and those switch now and then. But multiple orthopedist doing the same procedure in a community, somebody's doing it better, and there's a wide variation of cost. So does it have applicability in Wyoming? Yes. But what does it look like? You know, there are going to be areas in the state which is not going to be part of this narrow network, and people will have to travel. However, they're probably already traveling in a lot of these cases. But I think directing care to a higher quality provider, which ultimately reduces readmissions and problems associated with bad surgical interventions, does provide savings, both for the members and for the state and participating entities who are part of this program.
So do you have thoughts on follow-up, or are you going to, should we all just think about it for a while?
Madam Chairman, I'm actually looking for feedback from, of course, the legislature, which is why we provided you the report. But ultimately, you know, the governor's office is going to be weighing in probably the heaviest, but I do believe that they'd be looking for feedback from the legislature on this, which is why we're doing the presentation here today, to educate and let you know, yes, there is potential here, but there is also some other impact because again, narrow network, but potential savings.
Anybody with immediate feedback for Mr. Hayes? It's Representative Conley.
Thank you, Madam Chair. Mr. Hayes, my one piece of feedback is taking just a quick look at the very good presentation about what's available in the Rocky Mountain West. It looked to me like all Colorado, and then there's some possibilities in Gillette, it looks like, for orthopedics. And so we'll go with orthopedics. And what I don't see on the list is, for example, Premier Bone and Joint, which is in my, over the hill in Laramie. And so I'm just curious what it would mean for people in Wyoming. I need knee surgery. I honestly go down the street and I'm able to get it. One of the things we care about is access. And it would seem to me this might limit access a bit for people in Wyoming. And that honestly concerns me. So I'm curious about your thoughts.
Madam
that regard.
Chairman, Representative Connolly, that is an excellent point there. And of course, they haven't built a network yet. So this is just kind of an initial viewpoint. They made some outreach to certain providers. This hasn't taken a deep dive because we haven't moved in this direction. So they're kind of looking at what looks like a possibility, some of the community providers that they're aware of, who hold potential. So I'd say it's a little early on that particular area, but this actually kind of works alongside. We have our main program, which people can still utilize. And then you have this very narrow network group that works right alongside our Cigna plan. And in essence, people have a choice. So maybe they don't have to go to this narrow network, but they would continue with the Cigna network. And of course, the reimbursement's different. So it's kind of alongside, but there are also, if you're going to save money, there's incentives to the patient and lower costs to take them that way, which also provides lower costs to the state overall, hopefully better outcomes. And it lowers premiums and employer contributions, which gets right into our budget.
Madam Chairman, just to follow up, Mr. Hayes, I noticed that the excellent return was in Florida. And when you looked at their map, in Florida, the number of providers that they had was the dots were filled up. I mean, all of Florida was filled up. And so I could see it with that kind of economies of scale. And so again, I am a bit, that would be my concern. And then there'd be, I think, additional costs to individuals who had to travel to even Gillette from the majority of the state that's in the northeast corner, or to, it looked like Loveland or Boulder. If you're in southern Wyoming, you'd have to travel for days, I would imagine, for any of those surgeries. So again, those would just be my immediate feedback of my kind of concern about it. Otherwise, it looks great.
Madam Chairman, members of the committee, that is correct. There are additional costs which really don't show up on that side, but that's already happening. We already have people who are traveling to Billings for orthopedic procedures or various procedures, to Salt Lake, to Colorado, with, for perceived quality issues or whatever. So, or the fact that, if you're on the border, that often dictates where you're going to go. I don't think you see very many people actually having surgeries in Evanston, for example. Everybody goes to Salt Lake. If you're in Jackson, very few happen there. They usually go over to Idaho. So we're already seeing the outmigration. People are traveling for these medical procedures. It's just that maybe they're traveling in a different direction.
Any more questions from, or comments from Mr. Hayes? What's that? Oh, Mr. Burke.
Thank you, Madam Chairman. The one point I was going to make is we do see folks traveling, state of Delaware as an example, even in Florida, folks live in more rural populations. One of the nice things is with we believe in access, and we're going to try to give the best access without sacrificing quality and cost for every single one of our clients we work with. But their care advocate, every single one of our clients allows our care advocates and our organization to cover the costs of that travel up front for a member, to eliminate that barrier to entry and really enhance the member experience. And so if there's a hotel stay needed, we're booking and paying for that hotel, and it gets passed back as part of the claim. Because when there's such a big delta between what you're paying today and what you would be paying, it's about 1 to 2%, sort of 1 to 2% increase on total claim dollars when you pay for those services. So it's a very small incremental increase in the cost of the care compared to the savings you're getting, but does wonders to improve member experience because it makes it much more affordable for them to go seek out that high quality care. So just one point we didn't touch on here, but I wanted to mention that I'm pretty sure, and I may have to go back and check, I cannot think of a single plan sponsor across our over 200 that don't allow us to do that for their plan members that need to travel.
But would you visit the person's home and feed their horses and cows while they were gone? That's what we really want to know.
That's a tough question. That's the second best question I've gotten. First one was with State of Alaska. They got to pick 3 locations, and we had to describe to them how we would get the member from that location to our provider. And it involved seaplanes, snowmobiles, cat machines. It was quite the adventure, but it's a very good point and a unique challenge.
Very resourceful. Okay, very good. Thanks very much. Mr. Hayes. Oh, I'm sorry, Representative Romero Martinez. Didn't see your hand.
Thank you, Chairwoman Wilson, Chairman Wilson. I just wanted to maybe you had asked for something to report back. I just wanted to throw this out there. I hope it's applicable. Over the past few years, medical tourism has gained popularity among highly industrialized countries such as the United States. The number of medical tourists from the United States, and I'm talking about going all the way to another country, so Japan, Thailand, etc., has increased from about 750,000 in 2007 to 1.4 million a decade later, and that number continues to go up. US outbound medical tourists are thought to make up about 10% of the worldwide total. Data suggests that 150,000 to 320,000 US travelers list healthcare as a reason for traveling abroad each year. I know we're trying to keep healthcare in Wyoming, but minus the adventure to feed the horses and have quality protocols and metrics met, is medical tourism something to consider or something to think about anyways? I don't know that it's a question. I just wanted to provide that information because I think it is. And it's been about a decade ago. I mean, if you're an individual in the state of Wyoming and you're trying to get healthcare in a broken healthcare system and everybody has the answer, but we don't, that information went into a 5-point grievance that sits in a HIPAA file, which I don't mind sharing with you people, at the Department of Workforce Services in my name. So I just wanted to put that out there. I'm good with it. Just something to think about. I appreciate it.
Maybe what we should think of, because we are trying to build up our Wyoming hospitals, maybe we could start advertising to other places medical tourists who come here and rest fully by looking outside their window at the prairie. Mr. Hayes? He has no answer. We've stumped him. Okay, thank you, Mr. Hayes. I think we will, I hope that this study has been useful for you and gave you a lot of thoughts. And as you think further on it, check back with us, because I do say that, JAC has their concerns, obviously, and we're all concerned about the high cost of healthcare, but we're also concerned about having a robust healthcare system in the state, so that if you have a baby or a car crash right here, you have a service. Thank you very much for the report. Okay. Representative Ottman, I see your hand up. Did you have a motion? Before you make the motion, I want to say something. If the motion is what I think it's going to be. But I can't hear you.
Madam Chairman, it's up to you.
Okay, let me just say a couple things then. So committee, Representative Ottman has a motion that we've been going around kind of campaigning for as far as reconsideration. The motion and the vote are not debatable. So I'm going to just give a little explanation ahead of time why we're going to do this. One of the things that, as I pointed out after the vote, was that without the bill that we were considering, House Bill 38 proceeds forward and will basically be implemented next summer in whatever shape we manage to produce, which I think even those of you who are not that wild about the bill would hate to see that. And further, having checked with LSO, I know there were some folks that had some concern about, for example, the ARPA paragraph, finding that with the motion to reconsider, we can't amend that in. I know you all know Chairman Baldwin and I, we, enthusiastically accept amendments in committees during session. And obviously that can, further cleanup can happen, even though we wouldn't be able to address that right now. But so I hope that, as they say, vote your conscience, but I really think it would be valuable for us to be able to carry on with this. Go ahead, Representative Ottman.
Thank you, Madam Chairman. Committee, having voted on the prevailing side, I move to reconsider 22 LSO-0177 Community Health Services continued redesign efforts. Thank you.
Thank you, Representative Ottman. So LSO, just to make sure, I don't usually manage these things on the floor. Now we need a vote on reconsideration, is that right? So this is not a vote for or against the bill, it's just vote to reconsider, is that correct?
Madam Chairman, yes. So this first vote will be just simply to bring the previous vote back before the committee for reconsideration. These motions are not debatable. So it'll just simply be one vote and then a vote to decide if the committee should ultimately sponsor the bill that was referenced.
Okay, go ahead and call the roll.
Madam Chair, this is a roll call vote for reconsideration of 22 LSO 0177 version 6. Senator Bouchard?
No.
Senator Furphy?
Aye.
Senator Hutchings?
No.
Senator McEwen?
No.
Representative LeBeau?
Excused.
Representative Connolly? Aye. Representative Flitner?
Aye.
Representative Hallinan?
Representative Hallinan, we can't hear you. Representative Hallinan?
No.
Representative Ottman?
Aye.
I'm sorry, was that aye?
Aye.
Representative Romero Martinez?
Aye.
Representative Stivar?
Oh.
Representative Wharf?
No.
Co-Chairman Baldwin?
Aye.
Chairman Wilson?
Aye.
Seven aye. 6 no.
Okay, and then vote on the bill.
This is a roll call vote for committee sponsorship of 22 LSO 0177, Community Health Services redesign efforts. Senator Bouchard. Senator Furphy.
Aye.
Senator Hutchings.
No.
Senator McEwen.
No.
Representative Clifford. Or, excuse me, LeBeau.
Excused.
Representative Connolly. Aye. Representative Flitner.
Aye.
Representative Hallinan.
No.
Representative Ottman.
Aye.
Representative Romero Martinez.
Aye.
Representative Stivar.
No.
Representative Wharf.
No.
Co-Chairman Baldwin.
Senator Baldwin votes aye.
Chairman Wilson.
Aye.
Six to seven. Yeah. 6 aye.
7 aye.
Oh.
7 ayes, 6
7
no.
ayes. I'm sorry.
Okay. All right. So I think we are having passed that. Thank you, members. We are back to the PBMs. Let's see. Let me find my papers now. More papers. Honestly, someone sneak by and steal all my papers. Okay, Senator Baldwin, remind me, we're hearing a public comment, right? Is there anything else I'm forgetting other than to circle back to public comment?
One more there.
Oh, so come on up. Mr. Hayes? Welcome back. It's been so long since you've been here.
Thank you, Madam Chairman. Again, for the record, my name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. I did have a public comment this morning. I didn't get a chance to get called this morning. I just wanted to point out that there is a fiscal impact that I provided associated with the pharmacy benefit manager bill. And as drafted right now, we were estimated an additional cost to the Wyoming Employees and Officials Group Insurance Program of approximately $7.4 million.
And 7.4
Million.
million. And is that a biennium or a year?
That is a year. So basically, while, as the bill is structured right now, there's no cost to the member as far as when they go to the pharmacy. But when we get into the additional claims cost associated with it, it increases premium, which is a shared cost between the participating employers and the covered employees and their dependents.
Questions
that's
for
all I
Mr.
have.
Hayes. Representative Connolly.
Thank you, Madam Chair. And Mr. Hayes, this isn't facetious, nor committee, but really, that amount of money, $7.5 million a year is what you truly believe would be the cost if we pass this bill?
Madam Chairman, members of the committee, yes.
Thank you.
Okay. And just so the employees group insurance is what, somewhere around 700 million a biennium? Am I remembering correctly, or 300 million a biennium?
Madam Chairman, members of the committee, this coming year, we're anticipating about $320 million in paid medical claims, which is part of the prescriptions. So roughly that's almost 2% of our total medical spend.
The 320 million was per biennium,
So that per year.
per year. Okay, so.
That members of the committee, we
right.
cover we cover a large group of people. So we're covering roughly between 37,000 and 38,000 total members.
Representative Connolly.
Thank you, Madam Chair. Mr. Hayes, is that because of the anticipated dispensing fee?
Madam
Hayes.
Chairman, members of the committee, it's various pieces of it. It's quite frankly, doing the pharmacy of choice, which wipes out the $2 million of savings that we get through the coupon program, and which is basically money back directly from the pharmaceutical manufacturers. And that program saved us $2 million last year. Additional dispensing fees, that's part of it. That's about $2 million. And then cost to the pharmaceuticals, increased costs using the new, and I'm guessing on this one, I think I'm low, quite frankly, on that one is probably over $3 million.
More questions for Mr. Hayes? Okay, thank you very much.
Thank you.
Okay. We will continue in hearing public comment before we read the bill. As we've said earlier, because we did hear comment on the topic in Riverton in June, and then on the first draft of the bill in Casper. So if I don't want to turn anyone away, but it'd be better to focus our time on people who either have not testified before or have some specific comment on a feature or a changed feature in the bill, rather than just more, because we have received a lot of information about the concepts of PBMs. So it'd be better to either condense those or let someone else bring them, just so that we can have time to work the bill before we, once it gets to 10 or 11, we don't work very well, probably. So who? Oh, you weren't on labor years ago when we stayed until 9 o'clock upstairs on the 3rd floor. That's right. That's nothing. Okay, so those of you who have just come on up and fill up kind of the seats. You don't need to come on specific groups or anything. Just come on up and be friendly with each other. That's always good. We try to be civil here in Wyoming, unlike other places. And Fielden, sir, go right ahead. Introduce yourself and tell us who you are.
Thank you, Madam Chairman, members of the committee. My name is Jonathan Buxton. I represent the Pharmaceutical Care Management Association, PCMA. We are the national organization that represents PBMs. We provide coverage of legislative issues for our members, and we work to maintain the benefit that they bring to the drug pipeline. As we've said in the past, and I'll try not to reiterate too much because I take the chairman's admonition earlier to provide new information. We are the only entity in the drug supply chain, PBMs that is, that are putting downward pressure on the price of drugs. There is no other group. Wholesalers, manufacturers, we are the only group pushing down the price. And so when we have a set of tools, we use those tools to provide a better benefit and an affordable benefit. And so as we look at this bill, we look to see, does this improve the healthcare of the people of Wyoming? And does this lower cost? And that's the simplest filter to look at this bill. Unfortunately, most of these provisions, the answer is no. It doesn't improve healthcare and it doesn't lower cost. Ronald Reagan famously said, government solution is to a problem is if it moves, tax it. If it keeps moving, regulate it. And if it stops moving, subsidize it. And this bill does all three. It mandates and it interferes in the freedom to contract between business entities. It sets parameters for what businesses, how they conduct themselves. This is mandates from the government to private entities, directing them to subsidize an industry. But let me be clear, we as PBMs need our pharmacies. We need vast, vibrant networks. And so we negotiate with those pharmacists. And the pharmacists in the rural areas of Wyoming are much like the pharmacists in my home state of Oklahoma. They're in network, they're covered. It's the ones in the inner areas where they're having to compete that are struggling. But we need vibrant networks. We need our pharmacies to succeed. And so this bill, in a lot of ways, puts those pharmacies at risk. They don't necessarily understand that if you set the floor can become the ceiling when it comes to reimbursement. This is, once again, government mandates, government regulation. You have taxation in here. And this has been a little confusing. I mean, I do come from Oklahoma, and this, I did have a great chance to come into town last night and have a ribeye, which I felt like I needed to mention. But that is the official state meal of Oklahoma is a ribeye. So we have a lot in common. This is a land of opportunity. This is a land of people out there trying to make their way. And when the government steps in, puts their thumb on the scale, they are taking money out of somebody's pocket. And it is important to recognize there's no hidden pot of money. We're not like the federal government where we can print money when we need it. Money is coming out of someone's pocket. And the provisions of this bill prevent my companies from being able to negotiate contracts and provide valuable, affordable services to employers. And so these bills, this bill takes money directly from the employer's pockets. You just heard from your committee or your own insurance plan where you act as employers to all the state employees of the state of Wyoming. This is going to cost you money. The same thing is happening to all of your self-insureds, to your small businesses that are fully insured. This will increase cost. This is government mandating specific market performance. And so if I go much deeper, it's going to be repetitive. But so I will finish with that. We welcome any questions you all may have.
Questions for Mr. Buxton? Online. Representative Hallinan.
Thank you, Madam Chairman. I have a question for this gentleman. I like the idea that as part of your amendment to this bill where it says, reimburse the provider for a drug using the maximum allowable cost price that was in effect on the date the prescription was filled by the provider. How would this particular item harm your PMR?
Mr. Buxton. So he's referring to the potential amendment. And
Yeah.
that's good. I'm glad he asked that because I was going to ask if that is workable, require tweaks. So if you would, thank you.
Thank you, Madam Chair and Representative Hallinan. I would not be the best expert to speak on that. I'm happy to. I don't know of any of our members that are shifting when the reimbursement occurs. And so I might actually turf that to Lugina as she represents a plan, a PBM. But I can't think of a situation where the reimbursement would be anything other than the date it was filed or filled. So I don't know that I can speak to that as eloquently as Lugina perhaps.
Welcome, Lugina. Thank you for staying. We had several people who had flight reservations and they have changed their flights so that they can stay and answer questions. So we do appreciate that. And so if you have, and just to flesh out Mr. Buxton's thought there was, I got the impression, that there were often these clawbacks and that people were ending up not getting paid what they thought they were going to get paid. That's what we understood. But so if you could answer Representative Hallinan's question, and go ahead and formally introduce yourself just for the purposes of the committee.
Good evening. My name is Lugina Mendez Harper. I'm a pharmacist and I work for Prime Therapeutics, which is a PBM owned by several healthcare plans, Blue Cross plans across the United States, including the Wyoming Blue Cross Blue Shield plan. I have had the opportunity to talk with you several times and always enjoy coming. And I've had the fortune of seeing different parts of Wyoming with all of these meetings. So thank you for that. But to answer the question, so I believe one of the pharmacists was talking about how claim adjudications for pharmacies are different than medicine in that it's real-time claim adjudication. So when a pharmacist is filling a prescription, they're processing that prescription and sending a claim. And that claim comes back and says, okay, this is what you're going to be reimbursed for the drug. This is what you collect from the patient or the member as a copay or cost sharing. And this is your reimbursement for the drug and the dispensing fee. So that all happens electronically. So indeed, the MAC, when they're adjudicating a claim, the MAC is that day that the prescription is being dispensed. The concept of clawbacks, clawbacks is a really broad term. It can be used for a variety of things. One of the things that I believe the pharmacists are primarily focused on is DIR, which is the direct and indirect remuneration, which is the construct for Medicare. So that's something that will continue to happen because it's a federal program. It's not a state level program. Audits is a opportunity where you might see a clawback again. The purpose of an audit is to identify, to look, it's our transparency into the pharmacies. Are you adjudicating these claims correctly? Does this make sense? I think I've talked about it before where we'll have like an insulin claim come through and the quantity should be 10, say it's a vial of insulin that comes in a 10 ml bottle. And sometimes someone just inadvertently makes a mistake and we'll put 100 or 1,000. So we'll see claims like that come through, flag those and say, hey, can you look at this? Because we think there might have been a clerical error. Can you fix this, reverse it and rebill it if it's still in their pharmacy? So that's an instance where you might see a clawback, but it's because we're seeing something that's happening. That's a desktop audit where we're actually doing it usually the next day where we're messaging them saying, hoping that we can catch it before they've dispensed it so that we can get it fixed before it goes out the door. Then there are audits where folks come in, we call them on-site audits, where that's where you have a team of people come in to audit a pharmacy where they're actually physically there. The desktop audit is just us looking at claims going, hey, there's something weird, that, can you look into this? But so the on-site audits is another instance where you may see a clawback. Again, I'm using that as a very broad term, but that again is where we've audited the claims that were processed in the prescriptions that are in-house and making sure that they match up. And if there's something that doesn't match up, then that's when we would go back to say, this is a recoverable amount of money because something happened. Again, using that same example of insulin, let's say we didn't catch it right, the next day to message them, and let's say it was a month later, there would still be a recoverable event because they didn't actually dispense 100 cc's of insulin. They actually only dispensed 10 cc's, but they were paid for 100 cc's. So that's what the purpose of an audit is, to make sure that we have the ability to recover monies that are due back to the payers. And again, it may not rise to that level of fraud, where somebody's intentionally saying, I'm going to make this money. It can be just a clerical error. It could be, so that's, I think you acknowledge that in the amendment that you put together where you added some language about, not only just fraud, but also waste and abuse, and then some, unwilling errors that are made. So I think, I really appreciate the fact that you listen to, there are instances where that may be happening, but again, it's trying to make certain that we're good stewards of that healthcare dollar, and that if indeed we're paying you for 1,000 cc's of insulin, that you actually dispensed 1,000 cc's of insulin. So that's kind of a broad way to answer it, but specific to MAC, it's done that day for the claim as it's adjudicated.
Okay, any more questions for Mr. Buxton? Senator, excuse me, Senator Hutchings.
Thank you, Madam Chair. Mr. Buxton, thank you for coming all the way from Oklahoma. We've had in the testimony people from Louisiana or Philadelphia come in, and one of the things in my research on this, I've watched several videos, I've listened to several testimonies of different states. I've contacted senators from different states, and they're all encouraging us to do this. Our own National Council of State Legislatures has put together a webinar, and not once have I heard anything that you've just claimed, and I'm not trying to slam you or anything, but it concerns me. I've talked to these people that were on the videos. They've called me. And again, the encouragement is there that we need this to be done. So it just surprises me that at the midnight hour, we're hearing this from another state that wasn't on the webinar or hasn't called and contacted any of the bringers of the bill in the past to say, hey, this is going to do this, this, or the other thing. So I'm just concerned why that's coming up now.
Mr. Braxton. Or Buxton,
Thank
sorry.
you, Madam Chairman. Senator Hutchings. So I do need to clarify, I do represent PCMA, and so Melody Schrader, my boss, was here previously. She had a conflict. So we've been engaged. We've been at the meetings. I actually got to sit down and listen to all of the meetings on YouTube over the last couple of weeks, which is a lot more fun at 1.2 speed. So I'm going to speak to Oklahoma because that's home. And I've been intimately involved in this issue since 2014. I've been involved in 2 negotiations between pharmacists and PBMs. One was a rousing success. One was a horrible failure. But we have sat down at the table and we have tried to work these things out. When it comes to the members of the legislature in the state of Oklahoma, they have worked rapidly to address an issue they don't understand. They were overcome by the acronyms and anecdotes, if you will. They were rightly concerned about their independent pharmacist, but I don't believe they had sufficient actual knowledge of the drug supply chain to make decisions that help keep costs down. And so they ran headlong into passing legislation that has bogged down our insurance department with over 100,000 MAC complaints. It is not helping keep costs down. Costs continue to rise in Oklahoma as a result of this. And so I think that they acted out of fear and not information. And I've told that to their faces as well.
Follow up, Madam Chair.
Oh, follow up.
Yes, ma'am. So I get your history with Ms. Schrader, and but still 29 states. So over half the nation, 81 pieces of legislation. This group has spent more time than I even want to talk about delving into the legislation that have passed in some of these states and chosen the best parts of each piece of legislation to put into ours. They've passed, there's been no court cases saying, oh, you've done the wrong thing, you acted too fast, you were fearful. I haven't heard any of that. And all I'm getting from the states is you need to do this for your state. So again, I'm just not swayed just yet. That's just a comment. And I believe you can tell that, right?
I'm not sure that wasn't really a question. So I see Representative Hallinan
like
has his
to-
hand up. Okay. Representative Hallinan?
Thank you, Madam Chairman. I had a follow-up on my question. I think we heard from a lot of different pharmacists saying that they had these clawbacks that affected them. And they didn't have any of the complications that were mentioned by Regina. So if they're not having any of these, if they're not really having any of these complications, why can't we at least put this provision in the law in the state of Wyoming. And the fact is, if Regina says that they're not doing this, if it's not affecting the pharmacies by lowering their reimbursement, then they have nothing to lose by putting this into place. So why would not the PBMs be in favor of this bill that has this provision in it? So with that in mind, I'd like to hear what the comments about this provision would be from these folks. Thank you, Madam Chairman.
Ms. Mendez Harper.
Thank you, Madam Chairman and Representative Hallinan. Sorry, I can't, I'm old. I'm trying to read
very
it, a little
print.
writing.
You're right.
So a couple of things I wanted to address. I want to just make sure I'm understanding the question from Representative Hallinan. Are you talking, the question that you're asking, is it specifically about the MAC paid on the date that it's reimbursed? Or is that not the provision in the amendment?
Thank you, Madam Chairman. I would say yes. I'm talking about that provision that they would not lower the payment on a later date after the initial purchase of the drug.
Okay. So, and again, that's where I'm trying to address it as a global. If you're just talking about MAC, that's how we do it. It's claim adjudication right then and there. But my issue is that clawback in general, when the pharmacists are talking about different variations of clawback, it's not just MAC. They're talking about audits. They're talking about DIR. They're talking, so that's why I'm trying to explain it. If it's limited to MAC, I think that it's fine. And but I want to just put a caveat here. This is one of the struggles that I've had with the various meetings that we've come to is that we've been here as an industry trying to understand what are the problems, validate that. Is it happening? Let me figure out what it is. How do we address it? Do we need legislation? And I've tried to be very, responsive and, giving feedback anytime it's requested, and trying to provide rationale. Like I'm saying no here, but this is why. Or, if this doesn't work, how about, can you think about this item? But the challenge that I have is that I got version 5 and the amendment literally, well, the amendment was last night and version 5 was the day before. So it's hard to have the time that we need to read the language and understand it. And I'll give you just one more example. In your amendment, completely followed your logic about why you wanted to loop in PBMs in the insurer definition and the healthcare services. Completely made sense to me. But as a PBM, I'm like, I need to look at Wyoming state statutes because technically a PBM is not an insurer. We don't collect premiums. We don't assess, we don't assume risk like an insurer does. There's an entire portion of statutes that applies to insurers, both federally and at the state. And I haven't had time to look into that to say, like, I see the rationale, I see what you're trying to do, but my concern is I'm not an insurer. And if we do say, yes, let's go ahead and put us in this definition, what does that mean for us as a PBM? And how does that, and we need time to understand and read and have smarter lawyer, I'm not a lawyer, but have some of our legal team look at that and say, well, maybe we can do it this way, or there might be another way to avoid some of the things that I'm worried about. And I don't even know if those are legitimate worries, because again, I haven't had the opportunity to engage with folks internally that can guide me in that. So I just share that because that's one of the things that I've struggled with, because my commitment has been to be here, to listen, to respond, to meet timelines, and try to come up with some solutions. And it's difficult. I want to say, yes, I can agree to that. But everything, and that's the other thing, is that this is so interconnected. You do something on the right and it affects something on the left. And so it's a matter of like, okay, First I need to understand it, and then I need to see how does it affect the entire picture? And are there unintended things happening that we need to protect against? So it's just a challenge. And so I'm hoping that I'm not coming off as evasive. That is not my intent at all. I want to work with the pharmacists, come up with a solution. But I think that, giving us the time to look at language, interpret, react, and try and offer some solutions would be very helpful and very beneficial. And that's what's been done in previous legislative sessions. And Senator Hutchings, if you wouldn't mind, I would like to address the question that you posed to Jonathan about, you've reached out to several states and certainly admire that. But I also want to let you know, some of the states that are passing a lot of the PBM legislation that has been happening in the last couple of years, they're trying to catch up to where you guys already are. Some of those states didn't have PBM licensure. Some of those states didn't have MAC laws. They didn't have audit laws. They didn't have a lot of the things that you already have. So they're playing catch up in a lot of those regards, which is fine. And we're working with them. But then also, I did talk about in Texas or how we save money for insurers. At the meeting in Riverton, I was asked by one of the committee members, let's talk about transparency. We need to know what you guys are doing. And I shared with you all that there's a transparency law in Texas where you have the manufacturers, the insurers, the PBMs, all reporting various elements to the state of Texas. And one of the things that we as PBMs have to report is how much money are you getting in rebates? How much are you passing on? How much are you passing on back to the insurer? And how much are you passing to the member at the point of sale? Because the contention was you're keeping the rebates, you're not giving it to the insurers, you're not helping members at the point of sale. And when all of the PBMs reported into the state of Texas, it showed that that was all happening, that PBMs are passing those rebates back to the insurers. There are plans that have provisions in place where the rebates are shared with the member at the point of sale. The fact that we have kept, and but I will be honest and truthful, there are some PBMs that do have spread pricing, and they did report that into the state of Texas. And so there was a column there that said the PBMs kept X amount $1 million in rebates. But then you look to the right and you say, okay, they kept these $1 million of rebates, but they saved this $1 billion in overall drug costs. So that, I think, is getting to the question of we're driving down healthcare costs by exerting that pressure on manufacturers and trying to negotiate the best rates we can get with pharmacies. And then when we get those good rates from pharmacies, we're sharing those with members. That's why we have mail order pharmacies that, they're all automated. They're able to do volumes that are just mind boggling. And so that economy of scale is something that we pass on to the insurers and to the members by lower copays and lower cost sharing. So
Okay, let's tidy up our questions
Yes.
just so that we make sure to move on. If there are, let me just ask before we go on, and I will call it back. How many people are there in the audience who want to testify still on this bill? 1, 2, 3. Did I count that right? Those of you that are on the other side of the pillars, did I count right? 3 and 2 online. Okay, all right, go ahead, Senator Hutchinson.
Thank you, Madam Chair. I'll be real brief. I keep hearing you talk about lowering prices for the insurer. This is just about your relationship with the pharmacy right now. And that's what we're dealing with. If something happens with the insurer later on, we'll write another bill and we'll get you in on that. Thank you, Madam Chair.
Okay, let's, Representative Hallinan, did you have a question?
Do we get a chance to respond?
Yes, I have one question for Regina. I appreciate the fact that you save some money for people that are buying drugs. But at the same time, you have a monopsony. And with that, you can use your market power to drive the profits down or the income down to the pharmacies. And the pharmacies, that's not fair. You are a big company and they are just little folks out there. You need to have some government control of the way that you can use your monopoly power. And I think one of the most basic things is that you would not be able to reduce the price that you pay for these folks for the drugs that they buy. And that would be a fair way to deal with it. And you would give up some of your power, but you can still make plenty of money. I would like to see you use that power against these drug manufacturers, not against the little pharmacies. Thank you, Madam Chairman.
I guess that wasn't a question, but
No.
Mr. Buxton, did you have something that you wanted to answer to Senator Hutchings' question? I guess it was a question. Is there a question?
Thank you, Madam Chairman.
Oh, okay. Okay, so let's just.
So, Madam Chair, this can answer Representative Howland's question or comment as well. This bill impacts our ability to drive down those costs from drug manufacturers. If rebating is outlawed, we cannot force down the cost of medication for our plans. This does more than just impact our interaction with the pharmacist. This impacts our interaction with our employers that we're providing plans for, and it impacts our ability to drive down the cost. Because again, we are the only people in the supply chain driving down the cost of prescription drugs.
Okay. Katie, I think we have a couple of folks on. So I think, any more questions for, yes, Representative Stivar? For questions for Mr. Buxton.
This is just a comment. I've sat here through all these meetings and I keep hearing the pharmacists say, you know, they pay $20 for a medication. They only get reimbursed $5. Especially medications. The one pharmacist, explain why that's happening then.
Mr. Buxton.
Thank you, Madam Chair. Representative Stivar. I would argue that it can't be happening the majority of the times. Unless a pharmacist is sitting on a very large trust fund that they can subsidize their business with, which I don't believe they are. I think they're making it every day, like all of us out in the workforce. They are able to turn profits on the majority of scripts. This is a small population of their scripts. One of the presenters earlier today spoke of like 289 scripts in the last month. They're in business because somewhere the math works. And so they, if we have to start increasing the cost of and paying them exactly what they paid for every single drug, that is going to increase the cost of the plans and reduce the ability of people to afford insurance.
Representative Stivar, Madam Chairman, and Representative Stivar. I just want to clarify one thing as well. So we as PBMs don't set the price that the pharmacists pay for the drugs. We have no visibility into that. That's why we use national different databases that we pay for to try and get different price points, but we don't control what price they're paying for their drugs. So, and I think that Madam Chairman picked up on that with the amendment where there was some language in there that was struck or proposed to be struck, stating, you know, you can't have PBMs be held accountable for the purchasing practices of someone else. We don't control that. We don't set the price. That's their contracts that they've negotiated with their wholesalers.
Okay, any more questions for Senator Bouchard? Do you have a question for Mr. Buxton?
Thank you, Madam Chair. I'm looking at a list here. And these are in red over here is all what they're not getting paid this amount of money in this list. I'm sure you've seen lists like this. Now, 2004, I started working for a software company to help run businesses. You're making this sound like somehow we're doing this on paper and we're going to audit all this and we're going to figure out how it is later. You're not going to tell me that we don't have all this on a computer system and we don't know what that amount of money is that they're getting paid. There's a list somewhere that somebody has. Who's making that list?
Senator Bouchard, just to be clear, are you asking them the MAC list or how they're making the MAC list? Just clarify for that.
Madam Chair, we're talking about dollars and cents. I mean, when I go into a grocery store, they know what they're paying. And if they actually made a mistake, they don't call me up and say, hey, we made a mistake. I mean, businesses actually go to great lengths to understand, through software, how much gross profit I'm gonna make. The amount of money we're talking about on these lists, if these guys aren't getting paid, you go out of business doing that, because the amount of net profit that businesses make is a very small amount of money. And I feel insulted that some of the things that I've heard from the same testimony that they said last time they were here, they're talking about 90% of the time that they've made money, and then they're telling you about the 10% that they didn't make money. Businesses that continue to do that go out of business. And they said it kind of tongue in cheek and almost flippant last time. They said, they're telling you about the 10% they lose money. They're not telling you about the 90% they made money. I'm telling you that the computer systems today and the data that's out there, they can know exactly how much they're going to pay for something, how much it costs. And these pharmacies know, they know exactly what they paid for it. And there are times where it's just like in other business. Let's look at the automotive business so we can get out of this realm for a minute. If you go in and make a partnership with a parts house and they tell you, we're going to pay you on a pink sheet, that's the pricing you're going to get. And then you go and start buying parts from another parts house, well, they're going to say, we're going to give you a blue sheet pricing, because we won't give you the pink sheet, the best price. And but everybody knows what that is. Those things are all in the computer. I mean, I could look up a dozen different parts houses and know all the pricing of everywhere on whatever sheet that I'm getting paid on. That's because everybody went to great lengths to make sure when we make a profit or we do an estimate, we know what we're going to sell it over the counter. Now, all of a sudden, we're talking like this is all Greek. Like somehow nobody knows what these prices are, and then we're going to audit this 2 years later and claw it back. I think I'm being lied to here. I mean, I'm just not,
So Senator Bouchard, let me just clarify. So it sounds like you're saying the PBMs know what the pharmacy is paying for to acquire their good. Is that what you're saying? So when I go to the grocery store, I should know what King Soopers buys their milk for? I don't know. I just buy my milk, right? So I mean, it's not clear to me that is actually.
Madam Chair, to be clear, when we were talking last time in the same committee, remember we were talking about bananas. I went and looked up bananas, and I can tell you that I was pretty close to what Senator McEwen was talking about. And he has a grocery store. I don't think that this is so foreign that we don't know. I mean, even this, to have these in front of me and look at these prices. I'll tell you what, I got a call yesterday, Madam Chair, where the guy couldn't get a prescription filled. I called the pharmacist, and it wasn't even this same topic. They told me the price. Would you believe I'm looking at this chart and it says the same price that he told me yesterday? And it's a totally different pharmacy. Isn't nobody here? So there must be across industries that does happen. We know that they have industry pricing, and we know that somebody has a record of it. For them to just say that I mean, what are they looking at, a ledger somewhere and looking it up 2 years later? Oh, look, we paid this. It's all computerized. Everybody knows what's going on.
Okay, Representative Worf, did you have your hand up?
No, madam.
Okay. Any more questions and kind of if we could confine them to questions and just so that we can keep moving on. Any more questions for Mr. Buxton? Representative Romero Martinez.
Thank you, Madam Chair, and my questions are on my laptop, which just turned off. Stand by. Technical difficulties, I might have to just wing this one.
Good thing well, maybe it should be on a paper ledger.
Well, I'm doing both. So I'll start by just winging it. So that's just wrong.
Hey,
plugged
can we
in.
circle back? Is it a
Circle back,
vital
please.
question from Mr. Buxton? Maybe some later person can answer it?
Circle back.
Well, I think that
Well,
we're
Mr.
gonna,
Buxton, I'll just wing it. You said you're the only group driving down costs. And I would tend to disagree. Maybe the only, I would even say paid or high paid driving down costs on a major global contract, but just a little background why I know, and thank you for coming here. My family originated in New Mexico, and how they drove down costs was two things. They learned from Native Americans how to use herbs and natural medicines. And two, we learned from veterinarians how to use veterinarian medicine on humans.
okay, Representative Rivera Martinez, let's stick with questions on this bill. Guys, we've been talking about this subject since June, okay? If we could not discuss the entire penumbra of the pharmaceutical industry in the world, just let's stick on the bill so we can work the bill and go. Representative Rivera Martinez, try to identify the questions specifically for Mr. Buxton regarding the bill.
Thank you, Madam Chair. I was thinking in the lights of question, comments, and concerns, and I think that's a worthy comment that everybody in this world needs to hear. And my question regarding this form here, there's the pharmacist that lost 100 and whatever, 50,000 or in a day, in a month or a year. How did that happen?
Thank you, Madam Chair.
Mr. Buxton.
Representative Romero Martinez. Pharmacists are reimbursed according to the contract that they sign with PBMs. Those contracts set the parameters for, how they're going to be reimbursed. And those contracts tend to be negotiated either by the pharmacist in about 25% of the situations, or by these PSAOs, the Pharmacy Services Administrative Organizations. So pharmacists are reimbursed according to the contract that they sign willingly, freely with PBMs. And so they may not have the ability to, or they may not purchase drugs through their PSAO at a rate that matches the reimbursement rate. And that's where the gap would be. PBMs are paying according to the contract. Pharmacists are buying drugs according to a separate contract. And if there's a gap, our members are paying according to their contract. And it's a bad purchasing decision on the pharmacy side through their PSAO most likely, or their buying group is one of the terms that we've heard used here.
Thank you.
Okay, any more questions? Thank you. Katie, do we have someone online who wants to testify just for a little change of scenery? Pick one. Anyone. Magner, did you say? Okay, Mr. Magner, welcome. If you'll just introduce yourself for the committee's sakes, thank you.
Sure, absolutely. Just make sure everyone can hear me well.
I think we can, thank you.
Excellent, fantastic. Well, Chair Wilson, Chair Baldwin, and members of the Labor, Health, and Social Services community, thank you, or committee, thank you for giving me the opportunity to provide comments. My name is Matt Magner. I am the Director of State Government Affairs for the National Community Pharmacists Association. Just a little bit of background, NTPA represents the interests of America's community pharmacists, including the owners of more than 19,400 independent community pharmacies across the United States and 47 independent community pharmacies in Wyoming. So a lot of what I was going to say would sort of echo what was mentioned by the pharmacists that you heard from earlier. So I'm just going to try to keep my comments short and instead of echo what they said, add a little bit more to that. First, I want to talk about the the provisions in the bill that would protect patient choice from the PBM conflicts of interest. So many PBMs own their own pharmacies. And so when an independent pharmacy contracts with the PBM, they're not just contracting with someone who's reimbursing them, they are contracting with a competitor. And PBMs often use that their position in the market to avoid competition with the independent community pharmacies. And they can do this by steering patients to their pharmacies. They can do it by penalizing patients who choose to utilize an independent community pharmacy as opposed to the PBM-owned pharmacy. And so the bill would address these conflicts of interest. It would give patients the power to make healthcare decisions. They would still have to choose a network pharmacy, but they would have greater authority to choose the network pharmacy of their choice based on what's best for their health. It would not prohibit a patient from choosing a mail order pharmacy or from choosing a PBM-owned pharmacy. It would just make sure that they're not penalized if their health is better served by a different pharmacy that's not owned by the PBM. And there was a mention of perhaps not including that provision in the bill, and it would just use the existing any willing provider. My concern is that the current any willing provider law does not protect the patient and patient choice adequately. It would still allow the PBM to steer patients, to take away the patient choice and steer them towards a pharmacy that the patient would not otherwise choose. Another issue that has come up a lot is the retroactive clawbacks, that nature of that reimbursement. And I will, and this can come in a few forms, and I think there was some confusion about the use of the word MAC. As the bill as it stands now, it recognizes there is a term, maximum allowable cost. And that was a reimbursement methodology that was pretty common not that long ago. However, many states have addressed maximum allowable cost lists with appeals, with an appeal process, much like the state of Wyoming has. And so we have seen a move away from MAC to different reimbursement methods, such as generic effective rate is a common one. Brand effective rate is another one. And so that's why the bill would address those things. And so I think there was a question about when a MAC is presented, there's not really a change to the MAC you were told. And that might be true for the old definition of MAC, or even I should say the current definition, because Wyoming has not changed the definition yet. But when you have a reimbursement methodology like the generic effective rate, under that reimbursement methodology, a pharmacy can be reimbursed at one rate one day, and then weeks or even months later, a significant portion can be clawed back by the PBM to reconcile to this generic effective rate. And so this retroactive nature, as you heard, makes it difficult for pharmacies to know how much they're going to make on any given prescription. And so there's no certainty when they are reimbursed. And another issue that's missed is when a patient's cost share is tied to the initial reimbursement at the pharmacy counter, and then it's later clawed back. That patient was paying off of an inflated amount. And it's, if you consider the last time you got a check from your PBM, you can see that patients aren't getting the money back, even though they are paying off an inflated amount. And we don't know exactly where that reconciliation, that clawback goes. Does it stay with the PBM? It's definitely not going to the patient. Where is it going? We don't know. So addressing those reimbursement or retroactive clawbacks is something that we're very happy to see in this bill, and we hope stays in the bill. I'll also talk about the reimbursement transparency. There's been questions about the reimbursement transparency, setting a reimbursement benchmark that would, include NADAC and a dispensing fee, and concerns that the impact that would have on costs. And I think that cannot be looked at in a vacuum. You have to see the other forms of reimbursement transparency that are included in the bill, including making sure that PBMs cannot reimburse their own pharmacies more than a non-affiliate pharmacy to address that conflict of interest. Addressing spread pricing is something. And so when coupled with all of this reimbursement transparency, why would you have this benchmark? It really addresses the fact that a PBM sets the reimbursement amounts for their competitors. And so if you set this benchmark based on NADAC and then a professional dispensing fee, then you can take away that conflict of interest. And with that reimbursement transparency, when other plans have tried this, so in West Virginia, North Dakota with their Medicaid expansion population and the CHIP program, Louisiana, Kansas, and Iowa, they've all tried this method in their Medicaid programs. And I point out Medicaid because that's where we have some public access to the information. But they have not seen their costs go up. In fact, North Dakota and West Virginia have seen tremendous amounts of savings when they move to this transparent NADAC plus a professional dispensing fee model. So I think the question, if you were to implement this type of policy, the math doesn't work out that you can just multiply each prescription by the professional dispensing fee and say it's going to raise costs by this much. Again, that's looking at it in a vacuum, and it's not looking at the other transparency provisions in the bill, and it doesn't address the fact that the whole model's going to change. And so with that, those are just some of the high-level topics I wanted to address, and that I hope the bill continues to address as you move forward. I'm happy to answer any questions you have.
Any questions for Mr. Magner? None. Thank you, Mr. Magner. Very good. You're very informative.
Thank you.
Okay. Do we have someone else in here who would like to speak? And then we'll go back to the online again. Oh, Representative, oh no, I see you, Mr. Spencer. We'll call on you after this next witness. Good afternoon. Is it still
evening.
afternoon? It's not 6 o'clock yet.
Yeah.
Does that make it afternoon?
9 o'clock somewhere. It's 9 o'clock somewhere. Good
It
evening.
is dark out.
Madam Chairman, members of the committee, my name is Heather Roday and I'm representing Blue Cross Blue Shield of Wyoming. Just a few quick remarks. First of all, wanted to thank the Herculean efforts of the co-chairman to try to simplify a very complex bill with her proposed amendment. The scale of the bill and the amendment is significant, and we are concerned about the impacts to our members and our employer clients, especially when the draft that we've talked about is going to increase costs even more, potentially, than what we have seen previously. The bill is still a state-driven mandate that increases the cost of healthcare and makes it even harder to manage and predict. So yeah, we're not super excited about it still. I think the other thing I'd also like to point out is we are actually concerned about the lack of transparency in the process of bringing the bill forward. Originally, it was sent to a work group that met twice, and the opposing views were never really considered. And I don't feel like we ever
Madam
really
Chairman,
had a dialogue.
Point of order.
Yes.
Excuse me. I would appreciate if you just stick to your testimony. That was a work group that was assigned by one of the chairmen. We had zero budget. Everybody had a chance to be heard. So how the process was done was the way it was done, I guess. We can bring a bill forward any way we want. And we had people in the state of Wyoming that were asking for some help. And that's where we are today. So I have a big problem with the direction of her testimony at this point. Thank you.
Ms. Roday.
Madam Chairman, my apologies. I think the point I was trying to make is that I believe that we need more time to have further discussions with a greater impacted group of stakeholders. Therefore, we would encourage more time to work on this bill. And I think it's quite controversial. And in other aspects, we have had many months and many meetings of folks that working together. And I would hope that we would have that opportunity again. Thank you. Stand for any questions.
Yeah, questions for Ms. Roday? Okay. Let's go back to the online. Mr. Spencer, I believe we have.
Good afternoon, I guess. Not quite evening yet.
That's good. I thank you for that enthusiasm. Mr. Spencer, go ahead. If you
You're
just
welcome.
Introduce yourself for the group.
You bet. My name is Bruce Spencer. I represent the Mountain Health Co-op, which is a small health insurance company. It insures 2,500 lives. And if you remember from last meeting, that small company had a very large impact on Wyoming health rates, lowering them by 10% by simply coming into the market. And I think that's important because I heard some questions or testimony or statements that, well, this is a big industry thing and you can afford to give these pharmacists the money. And I can assure you that my client is not a big industry. But I do want to, I'm going to try to stick to the concerns that we had with the bill, which I think is what you asked. And so I want to just sort of go down and I worked with the pharmacy guy at Mountain Health Co-op, and he gave me some comments. And so I'm going to use those as well as my own as I was looking through this. And one of the big concerns that I have involves the mail order and saying the sections on mail order. And part of the problem is it's not so much the regular prescriptions, that's just fine. My client doesn't mandate mail order. In fact, my client doesn't use preferred pharmacy networks. They offer a contract to everybody, except for specialty drugs. And I think you heard the consultant for counties and employers quite correctly tell you just how expensive specialty drugs are. And that if they are unchecked, they can submarine a plan. And that is not a misstatement. And so we use mail order pharmacy for specialty drugs because we get the best price from them. But more importantly, those mail order pharmacies can do the patient follow-up that's necessary when you have a specialty drugs. These drugs have severe side effects. Some will cause people to have suicidal tendencies, blood clots, other things of that nature, and they need follow-up, not just dispensing. And the large mail order pharmacies that do specialty drugs have sufficient staffing and experience to provide that follow-up and monitoring. Now, I know it's from a distance, it's on the phone, it's a mail order pharmacy, it's not your local pharmacy doing it. But because of the patient protection that's required under their contracts, those mail order folks have the assets and the staff with which to do it. I'm not sure that our local pharmacies will on specialty is what I'm talking about here. So some of the things that we're concerned about are definitely specialty related. And that would be on page 6, starting on line 22 and going on to page 7 through 9. I think that impacts specialty to some extent. At the very next paragraph on page 7, there's a 90-day provision that you have to write a contract out to all companies, all pharmacies. Well, my client already does this. My client offers a contract to every pharmacy. So this is adding an extra layer of bureaucracy that we really don't feel is necessary. And in fact, we have a concern about the language that says geographic coverage area. Well, does that mean Wyoming? Or does that mean the coverage area in which my client provides health insurance? My client writes insurance in Wyoming for Wyoming consumers, but that coverage is nationwide. So if somebody from Wyoming needs pharmacy services in Boston, does this paragraph apply? That is our geographic coverage area. It's nationwide. So we have concerns about the language that's being used here and in some other areas of the bill. So I note on page 8 and the paragraph C, it starts on line 7. This is the first time I've ever seen a private cause of action in a bill that's intended to be handled by the insurance department. First time, I've never seen it. And I can tell you, I think the witness testified, well, if we don't like what the Department of Insurance says on a claim, then we want to be able to sue. Well, normally, in the normal course of business, if you don't like what an agency has done, you appeal the agency decision through the Administrative Appeals Act. And that would be the normal course of business. Establishing a private right of action, that's a big deal. And given the testimony you've heard earlier about the number of appeals that were filed with insurance commissioners, you might be clogging your courts. But that was a provision I'd never seen in any other bill. If you go to page 8, again, B on line 21, pharmacy benefit manager cannot charge a bill related to adjudication of a fee, and then it lists a bunch of fees. Well, those fees are going to get shifted. They're going to get shifted to the health plan, which in turn is going to shift to the Wyoming consumer. So, maybe everyone needs to pay some of their fair share, but our small company, Mountain Health Co-op, has concerns about increasing those things on adding plans. And that same concern appears in the bill on page 10 and line 2, sub 3, prohibits a PBM from deriving any revenue in connection with performing pharmacy benefits management services. Trust me, that money's going to be charged to the health plan. So on MAC pricing, well, I'm sorry, the paragraph that starts on line 10 on page 10. You have the pharmacy benefit manager can't be less than the national average drug acquisition cost. And actually, my pharmacist guy said that number is fine. That's an amount we can figure out. As a lawyer, I have a concern about where you're getting that data. If it's a privately created data list, I'm assuming you have to pay for it. Is it protected by copyright? Is it available? Is there an issue with legislative delegation of authority to some other entity who's creating this? So I worry about those things. But also in that paragraph, you have wholesale acquisition cost of a drug mentioned. That term is not a very good indicator of actually what a pharmacy is paying for a drug. And the reason is, behind the scenes, after the purchase, the pharmacy is going to get money back from the wholesaler or their PSAO, volume discounts, rebates. There's a bunch of money that comes back to the pharmacy that's not in that wholesale acquisition cost number. So you're not getting a complete transparent picture of the actual cost of the drug and the reimbursement to the cost. So we have some concerns in that paragraph about that. and also a guaranteed dispensing fee. I think others have mentioned the cost to that. It is significant. So I want to move down to the part of the bill that talks about MAC pricing. And that is on page 20. And basically, the way I read the new language, it says, well, if we can't meet your MAC pricing list, and a PBM gets its MAC price by going out and trying to figure out nationally, where's the lowest price for a generic drug. And then they say to their pharmacies, well, we're not going to pay you any more than the lowest price. You can get it at this price. We're not paying you more than that. What this bill says is, well, no, if we've made a bad deal with our wholesaler, sorry, your MAC price has to be the price that our wholesaler charges us. So we can't, the PBM can't say on behalf of the Wyoming consumer, we would like you to go out and get the lowest price possible. Instead, it's, well, I guess we're forced to take the price for the deal that you made with your wholesaler. Basically, this paragraph eliminates MAC pricing because MAC pricing is about going after the lowest cost. And if you say, well, MAC pricing is the cost I get it from my wholesaler, you eliminate any incentive to get a lower cost. So we definitely have concerns about the paragraphs on page 20 on MAC pricing. That's it. Those are my concerns. Again, as I stated before, I believe that those cost increases are definitely going to be passed on to the Wyoming consumer. That is a policy decision you folks make. So you can make the policy decision to address all of the concerns of pharmacists. And I think you can address some in this bill without impacting the cost too much. But the ones I mentioned, we feel are a large cost impact. And we would encourage you to not make the public policy decision to harm the Wyoming consumer and pass on those costs, rather to take those issues out of the bill.
Great. Questions for Mr. Spencer? Representative Connolly.
Thank you, Madam Chair. Mr. Spencer, we heard from Ralph Hayes of our employee group insurance that this bill would cost $7.5 million to the state for state employee insurance. Do you have a figure of increased costs that you think? No, but you.
No, I'm afraid I don't. My company is just too small to do that. But his increased costs are going to be the same increased cost that any insurance plan has. And so, you know, by a matter of scale, if you look at the state plan and you see how many lives are insured, if you've got insurers that have more lives than that, their costs are going to be even greater.
I was going to ask, thank you, Madam
Mr.
Chair.
Phillip,
Yeah, I was going to ask you to do some arithmetic, but I think I won't, you know.
I'm a lawyer. We don't do math.
All right, thanks.
Any more questions for Mr. Spencer? No? Okay, thank you very much. Very helpful.
You're welcome. Thank you.
Anyone else in the audience? I think we had, I'm not sure I have got, we surely haven't done away with all of the previously raised hands, do we? Ms. Carroll's back.
Madam Chair, committee members, I am actually here testifying on behalf of Andrea.
And just announce yourself, because there are people listening in sometimes and they don't always know. So just, even though we can see you, say who you are.
My name is Melinda Carroll. I'm a pharmacist. I practice here in Cheyenne at the King Supers. My testimony is really going to be more on behalf of Miss Todd Harlan, who had to leave, catch a flight earlier. And due to that, was not able to stay and testify. And she wanted to be able to do that. So with the questions on NADAC and the guaranteed dispensing fee, that piece in this bill, I know that we have heard several comments on how it will increase costs and do these things. as you guys, and there's no good definitions out there. So as we know, NADAC is a CMS defined price that is paid, as we heard Corey Cooper testify to, as we heard the NCPA representative testify to. And honestly, that's out there for everybody to see. Now, as for the dispensing fee, I would like to say that Wyoming Medicaid rules also has this in their rules definition. Chapter 10, Section 16 defines how they are going to determine a dispensing fee for the pharmacist. If we already have that in a statute, why can we not use that language that is already there? And then with that, I would like to say if taxpayer funded safety net program that reimburses pharmacists according to NADAC plus a dispensing fee, we're simply asking the private industry to do the same. And if you noticed in the testimony from the NCPA representative, he was talking about their Medicaid programs that went to this form, and their Medicaid programs having significant savings. I would encourage the committee members to look at those, because that is true. Not everybody is as fortunate as Wyoming is to have a Medicaid program that already uses what they would refer to as a PBA or a transparent PBM, somebody that passes through all of those rebates, all of those savings to the program itself. It's a very transparent program that we have in Wyoming. So I commend you all for that, because you guys, I'm sure, had to have a hand in that. That is really what I would like to kind of just drive home there, is that we already have language that we can use for those issues.
Okay. Any last questions for Ms. Carroll? Okay. Any other tests? Do we have anyone else online? Senator Bouchard? Are you what? Someone, is there someone behind the post or what? Or were you asking? Of Ms. Carroll? Okay, sorry.
Madam Chair, thank you. Could you explain? I mean, I don't know anything about your system, but I do know enough about computers and how it works in business. There has to be some way that everybody's seeing especially these NADAC prices. And I mean, even if we knew that price on NADAC, everybody could know where the playing field is. So I'm trying to figure that out, because we've talked about that term loosely, NADAC, but I'm sure a lot of the committee members maybe don't know exactly how that works. So could you explain that?
Ms. Carroll.
Madam Chair, Senator Bouchard. So that is a national database that you can look up at any point. It's free to look into. That is a different pricing structure than MAC pricing, which we have been referring to. So NADAC takes out the variability of the MAC pricing, really, because that is why it actually requires to have a dispensing fee with it, because if we are only being reimbursed the cost of the medication basically at that point and not for any services given. So the current pricing system with MAC takes into, they keep on stating the 90% that you make money on, the 10% that you lose on, which I would argue those numbers, that's another point though. With that, that's how you make your money up, because they don't pay you a dispensing fee at that point. Their dispensing fees are 0, 50 cents, $1, things like that. And that's to pay for our services and our overhead and our labor costs and everything like that. So when you have those different pricing, you have a way to make up that if you're going to make some more money on some drugs and less money on others. The problem is you're making less money on a larger portion than they would like to say that we are. In your packet, you guys do have that report of that pharmacy that lost $10.5 thousand in the month of October. That's current numbers. And if you extrapolate that out, to other pharmacies in Wyoming. Yeah, and over the year, it's about $23 million that pharmacies are being underpaid.
More questions for Ms. Carroll? Okay, thanks very much.
Give me One more,
Yes.
Madam Chair. So what I found very interesting from this list that we have in front of us is I had someone that called basically, and there was a huge increase on a drug, and I'm not even gonna name it. But what's interesting is that and so I ended up calling the pharmacy to find out, because, you know, I have somebody who's irate and they couldn't believe that they had just bought it and it went up. Right. And so what's interesting is the pharmacy told me the same price that's on this list is how he said, this is what my cost is. So it's really apparent that I just walked into this thing. He wasn't even one of the guys that I think had been here. I was talking to him about a totally different subject of a particular drug and why this person was having a hard time getting it. And then I asked him specific questions about PBMs, and then he told me what his price was. And I'm just fascinated that it's here on the same price. And interestingly, it's at the same it's at a loss. I mean, the pharmacy is losing money. So if I can talk to a pharmacy that wasn't even involved in our conversation, have this price, and it's the same, there has to, I mean, everybody knows what's going on here. So I just didn't understand, how did one of them say that they were shaking their head when I was asking that question?
So actually following up on that, so Ms. Carroll, so I'm wondering, when we had a previous, I think it was the Medicaid gal was explaining about, we gave us a sample of lisinopril. Are there some drugs that only have one manufacturer? I mean, so that it would be an average of one? So if he happened to pick that kind, then there would only be one producer.
Madam Chair, let me add one more thing. The insurance company wasn't going to pay for the script either. So it was customer pay because it was COVID. And so if the person says, I don't want to go to the hospital because I'm going to try to get better on my own, and a doctor, so I mean, one of these is Symbicort. If you look at what Symbicort is, actual cost is $1,092. Plan pay is $979. Copay is $60 on insurance. But imagine walking in and saying, well, you have COVID and it's not Symbicort, which is it's an inhaler. And imagine not having your insurance turn you down and have to walk in and pay for this. I mean, it's all awry. All of it is.
So that's certainly beyond the issue, really.
That
deals with the big pharma and the wholesalers and a lot of.
Except, Madam Chair, it got me to the same cost levels that I'm seeing right here on an unrelated conversation, unrelated to what we were having. And I was just surprised to look at this today and see the same price.
Madam
Ms. Carroll.
Chair, Senator Bouchard. So yes, those prices, there are 3 major wholesalers in the United States that pharmacies purchase their drugs from: Cardinal, McKesson, and AmerisourceBergen. So those 3 wholesalers are the people that we have to contract with. Can you see their prices? I would imagine that you can. What the representatives from PCMA were talking about was there are different contract price for different pharmacies because your buying power, basically. So the buying power of Walmart is going to be larger than the buying power of independents. However, I would argue that you're still getting reimbursed less than you're paying oftentimes. But between Cardinal, McKesson, and AmerisourceBergen, there's about a 3% variance in any of those offerings. And so, yes, you could very reasonably come up with drug prices that are being paid by pharmacies, and establish that, that cost. And Madam Chair, to your question, are there drugs out there that have just one manufacturer? Yes, there are. So yes, you would have an average of one.
Even the lawyer can do that math. Okay, no further questions for Ms. Carroll? Okay, thank you. Any more, one last, oh, we have some more. We are doing more work after this bill unless I cancel the entire rest of the meeting. So if you will, welcome back. Glad to see you. Try to focus kind of on the issues of the bill, if you will.
Okay, thank you, Chairman Wilson. My name is Camilla Hancock. I'm a pharmacist from Basin Pharmacy. And I am kind of the reason this whole ball started rolling, so they thought it was appropriate for me to end today. To begin, I wanted to thank everyone for their time and their service here today. And in light of yesterday being Veterans Day and knowing that there are veterans here, I'd like to thank you for your service. As I was preparing my remarks yesterday on Veterans Day, I was thinking of servicemen and servicewomen here, and I was wondering what you were thinking of when you thought of home, what you were fighting to come home to. Was it a faceless multi-billion-dollar company? I highly doubt it. Chances are you were thinking of your family, neighbors, high school games, county fairs, visiting with friends at a local diner, and running into classmates at a grocery store. Perhaps you even thought of your local drugstore. Maybe not, but they were there. Pharmacies, they donate to and sponsor local teams. They buy your children and your grandchildren's 4-H animals. They eat at your local diners, and they employ the mother of the grocery store's bag boy. They care about and care for your friends and family. And what's more, they reinvest into Wyoming's communities. What about PBMs? Are they investing into our communities? Can they recognize you by sight? And are they working late, short-staffed, selling their 401ks to stay in business and unpaid to ensure that their communities have medications and vaccines during a pandemic? If so, I have yet to see it. Committee members, the journey towards this bill has been difficult. It's had lots of hours spent in here, but I began working on it over a year ago. It started with seeing a gross injustice and was followed by many, many hours on the phone, cold calling pharmacies, or hours on the road with my crying children in tow to go and personally meet with pharmacies. Why did I continue doing such a thing? Because every single conversation involved the same emotions: gratitude that something was finally being started, anger towards the responsible parties, and desperation. All those emotions were ones I had seen in my own father. I knew I had to do something for the good people who were working, so hard to barely scrape by. People who couldn't even spare a moment to come here and voice the concerns for themselves. I also knew I was fighting for my own children's future. I want to raise Wyoming cowboys. But if pharmacies have to leave Wyoming, my family and I will have to as well. And I know I'm not the only one in that position. Thankfully, I have been directed towards those who know a lot more about the political landscape than myself. These good people were willing to help me with my little homegrown Wyoming vision. It has been through the help of people like Melinda, Matt, and Representative Flitner, who from the very beginning helped me and listened to the people who I was trying to represent. Thankfully, others have since joined and helped this homegrown cry for help become a tangible Wyoming born and bred piece of legislation. Now it comes to you. Will you support our cause? This bill is not asking for the moon. It is asking for us to be treated fairly. For our Wyoming pharmacies who employ Wyoming citizens, who pay Wyoming taxes and reinvest our money into Wyoming communities, to be given the opportunity to serve our Wyoming neighbors. That's what we are fighting for. What will you be fighting for? Thank you.
Questions for the pharmacist? Okay, thanks so much for being down here. Okay, any more? Anyone online, Katie? All right, then public testimony is closed. And is there a motion on the bill? Moved by Stivar. Was there a second? Seconded by Worf. Okay. Committee. I don't suppose anything on one will be a conforming amendments if there are any things. Anything on page 2? Anything on page 3? So committee, here's where I'm just going to bring up for your contemplation the amendments that I passed out to you. You know, as I expressed earlier, and to be honest, it's not entirely clear to me whether that my amendment is the best thing. I mean, it's, to be honest, I think that I think that there's a lot of questions and definitions that are missing from this so far, but you know, we do what we can. Anyway, so by attempting to insert the Healthcare Reimbursement Reform Act of 1985 and also looking ahead to providing funding for the Department of Insurance, my first amendment would be on page 3, line 17, after the word chapter, to insert "and the Healthcare Reimbursement Reform Act of 1985, which would bring in the concept of the any willing provider. And I granted that we did hear some question as to whether all that language, whether that would work. It does seem to me that it brings in the pharmaceutical language. And of course, with this, I mean, there's not really a lot of sense of amending this in unless we do the deletions on 7 through 8. And I guess I should pause there and ask for a second. See, I keep yakking on without, thank you, Representative Stivar. What a good heart you have. So, so having already started to explain the amendment, I guess, Senator Baldwin, would you like to chair while I yak through this? Just to not have me.
I'd
call
be
on
happy
people
to shake my head while you yak.
Okay.
Go ahead, Madam Chairman.
So maybe you want to ask if there are any, if there's any discussion.
Is there any discussion on the proposed amendment at this point? Senator Hutchings.
Thanks, Mr. Chair. Thank you, Madam Chair, for bringing the amendments. One of the things I'm concerned about is that issue with the pharmacist not being provided. Is there any way that, or am I too far down? Am I not too far?
Madam Chairman, go ahead.
So thank you. So Senator Hutchings, that's a good question, and I'm glad you brought that up. I did talk, and the commissioner is still here, but so there's two separate things here. The concept of is a pharmacist a provider for Medicaid and Medicare? We obviously can't address what Medicaid and Medicare does, right? It seemed to me, and we may want to get the commissioner back in, that in their rulemaking, that the whole point of having an Any Willing Provider Act for Wyoming insurers on other things, doctors, physical therapists, whatever, is that it applies to non-federal insurers selling in the state. To me, the wording pharmaceutical services and products is clearly connected with the pharmacist. I mean, and if it's not, it seems to me that by rule, the Department of Insurance could clarify that. If, Mr. Chairman, if you want to ask Commissioner Rude, because I don't want to speak, you know, I don't want to commit him to something that he maybe is not comfortable with.
Would you like to speak to her babbling?
I beg your pardon.
Madam Chair, before the commissioner speaks, I think he did, if you don't mind, or excuse me, Mr. Chairman.
Go ahead.
You did speak to the fact that for this act, we can make them the providers. So I'll let you speak to that.
Go ahead, Commissioner.
Mr. Chairman, Madam Co-Chair, we can clarify and rule if needed. I think we have the authority to do that under the way the statute's written. I'm talking with Ms. Burke. We're going back and forth whether we even think it's needed to clarify, but I certainly think we have the authority to do so in rule.
Madam Chairman, comments?
No, that's so the motion would be to insert the reference to the Reform Act and then delete pages 5 through 7 and 8 through 1 through 10, just to be clear, because I think that there's I mean, I see the intent of what they are working on there, but it seems to me to really go crosswise with the any willing provider and really set up a different categorization of how providers could deal with their customers that would be a whole different way than every other healthcare provider in the state that insurance companies already have to deal with. And I thought that actually just added confusion. I mean, if you consider the insurance company, they know what it is to have an open provider list for these various types of providers. And I thought that made it simpler.
Further comments, committee? Silence from the committee. Thank you, Commissioner. Would you like to go further or explain anything further, Madam Chairman?
Not on that part. I mean, I think it would be easier I don't want to do the whole 2
Okay.
pages at once. I think I would better do it
I,
bit by bit.
okay, well, you've heard the motion in the second, committee. All those in favor of the proposed amendment? Oh. Yes,
Chairman, I'm wondering if just procedurally, we can wait because it's the whole amendment, right? And what if we have an amendment on the amendment? I think, can we just wait to the end and then vote on the amendment before we vote on the bill?
I will leave that to the discretion of the chairman. I suspect not, but it's up to the chairman.
Mr. Chairman, I do think that it's divisible in essence, the way I've done it up like this. The first part with page 3 and then the deletion, down to just above where it says page 8, line 19, that's a separate part. I mean, that can really be done by itself. And other things about inserting erroneously or something, I mean, they're not tied together really. I think that it would be easier for all of us because other people might have something to amend in the middle part. So that's just my.
I would agree. I would ask LSO. I have a hard time seeing over there.
He's
If
fled.
they have, or, yeah, you already lost one member over there. You chased her off. If you're understanding exactly what this first part of the amendment is that she's discussing here with us.
Thank you, Mr. Chairman. It just sounds like the co-chairman has divided her amendment, and the initial kind of 3/4 of the first page will be the amendment that is presently before the committee as a result of the motion.
Precisely. Okay. So going back to that. Committee, all those in favor of this, Senator Hutchins is going to throw one more thing in.
Just quickly, per minute goes down to a little squiggly line that says one provider who provides. That's number one. Condition.
Mr. Chairman, so
Go
just
ahead.
to show that what's in italics is the statute that I'm referring to. That all won't go into the bill, but I wanted you to see what the context was. So the actual only amendment starts up on the line number 3, where it says page 3, line 17, and that's supposed to say after chapter. Insert and then delete pages 5 through 7 and page 8, lines 1 through 10, and insert down through where it says 26-22-503C is amended to delete medical and insert healthcare services. So, ultimately that might end up on a different page in the bill because I think LSO puts them in order of their titles or something like that. So it might not stay on this page, but that would be the language.
Right, and then the rest.
And
that's
I
just a
apologize for
demonstration of what it was.
failure of the line numbers on the
Okay.
side.
Okay, now before I say it one more time, anybody else got something you want to say? Okay, nobody's jumping on board. All those in favor of the proposed amendment, please say aye.
Aye.
Opposed, say nay. That amendment passes. Moving on.
You wanted,
Let's just, where were we on? We were at page 3, is that correct?
page 4 is all staff comment.
Okay, yeah, page 4 is done. Okay,
So, Mr. Chairman, just to say, so that by that amendment, we've deleted through the middle of page 8.
right. So moving to page 8. I believe 2652-107, is that where we begin? Right
Yes.
there, okay. Further amendments beginning on page 8, line 12.
12.
Nothing on page 8.
Mr. Chairman, I do have.
Go ahead, Madam Chairman.
Line 19, I was just going to insert after the word fraudulently or erroneously. it seemed to address the problem that certainly many things that we make a mistake on is not fraud, it's just by mistake. And that seems like a perfectly good reason to say, whoops.
Second on the amendment, discussion, Senator Hutchings.
Yeah, Mr. Chairman, I'm a little concerned about the wording there, and I think this comes up a couple times in the amendment. And we have in 2652-103, Charlie, India, small Romanet I, if you want, a definition already, and just wondering if we could use that instead of deleting that line. Let me,
I'm sorry, where's she?
thank you.
Can you clarify where you're at, Senator Hutchings?
She's on, I'm on page 1. She has line 8, or page 8, line 19, after fraudulently insert erroneously.
Correct.
And I'm asking that, could we just either strike that and use the language from 2652-103, subsection Charlie, Romanet I, where it says audits in which suspected fraudulent activity or other intentional or willful misrepresentation is evidenced by a physical review of claims data, statements, or other investigative methods. Or, since it's already in our statutes, can we just leave it at that and not try to reinvent the wheel?
I guess my question to that is that address intentional things, and this amendment would attach errors or something that was unintentionally done. You have a comment to that, Senator
Well,
Wilson?
Mr. Chairman, so the
unintentional.
first letters in C say subsections A and B shall not apply to. So they're just saying it, all the previous audit section won't apply to fraudulent or willful. So A and B presumably applies to plain old mistakes, which is what
I've got to kind of figure out what she's doing.
So for example, up in B5, it says no audit shall consider clerical. No audit shall consider any clerical or record keeping error as a fraud.
Oh, I see.
So
what
I'm
you're doing.
just,
I see what you're doing.
it seems like they can still, it says errors that are, well, anyway, the point being is that you could have errors and it just seemed like,
I see what you're doing.
okay, is that?
Further discussion on the amendment committee? No further discussion. You've heard the motion and second. All those in favor of the proposed amendment, please say aye.
Aye.
Opposed, please say no.
No.
That amendment passes. Moving to page 9. Anything on page 9?
Mr. Chairman, I have another one.
Go
So
ahead.
this one, I think, is really just in the realm of cleanup. If you look on page 9, picking up in line 15. So it says, if you look up at on line 11, a PBM may not engage in any practice. Okay, so this is what they can't do. And then picking up on 14, in any way bases reimbursement on outcomes, scores, or metrics. Then it says, notwithstanding this, they can do it if the pharmacy knows in advance. It seems to me that we could just clean that up a lot and read it. This is what the amendment is. Continue, pick up on 14. In any way bases pharmacy reimbursement for a drug on patient outcomes, scores, or metrics, then insert the word unless, delete the next 3 lines and the line 19 through if, and say, if the patient outcome, scores, or metrics are disclosed to and agreed upon by the pharmacy in advance. It doesn't change what it is. It just takes out 3 lines. Why say you can't do this unless they do that? Why not just say unless? I mean, it seemed, I was just trying to clean it up.
Okay, before we move on, is there any second on that amendment?
Oh, I'm sorry.
You're very enthusiastic.
I am not very good about that, right? I'll try to.
Is there a second on the amendment? Second, okay.
Madam-
Discussion committee.
Mr. Chairman,
Oh, go ahead, sir.
I think a point of clarification might be helpful at this point.
Okay.
This provision says that you can't base reimbursement for the drug on patient outcomes. And then it clarifies that you can base reimbursement for pharmacy care. So there's really two concepts that are going on in this. So
And
that that's why it was divided out. to
And
try
that's
and
why you
make
get
that
the
clear.
big money.
Okay.
Yeah.
Mr. Chairman, may I withdraw my amendment?
Second and amendment are withdrawn. Further amendments on page 9.
It's just, we have to pay by the word.
Okay. Page 10. Silence from Madam Chairman.
No, Mr. Chairman, I do have an amendment here. So my amendment on this one is on page 10, delete lines 8 through 22. And if I have a second, I will explain it.
Okay, you have a second.
Thank you, Mr. Chairman. So here's my reasoning on this. So far, we don't have a written definition for national average drug acquisition cost, which I understand it's a real thing, but we haven't said in statute what that is, whether it's CMS. Usually there's the CFR quote and that kind of thing. We don't have a definition for national dispensing fee average or determine who calculates that, how it's calculated. So I feel like there was a lot of material in here that is not defined yet. And I really hate it when people try to write definitions on the floor. It just doesn't seem to work very well. So my thought, Mr. Chairman, was that with, and this is where things admittedly do hang together. With the requirement, we've got the MAC list later, we've got my proposed reimbursement for the price that was in effect. We have paragraphs J and K at the end of the bill where the PBM has to reimburse all the pharmacies the same, whether they're affiliates or not. It just seemed to me that we didn't have to put in something that was lacking in definition.
Discussion committee. Senator Hutchins.
Thank you, Mr. Chairman. Hate to be the one jumping in all the time, but spent a lot of time with the pharmacist on this. And by doing that, striking 10 through or 8 through 22, she's getting rid of the whole section that's allows the pharmacists to get reimbursed at even their cost. I would like to divide her amendment if possible and keep lines 8 through 21 up to B or the comma, or maybe put a period there. And then later on, we can work with the second division in dealing with that dispensing fee. But I'd hate to see that whole section go away and the pharmacist not get reimbursed at all. And I know her intentions are well, but I think that we don't want to get rid of that whole section, Madam Chair.
I'm just looking at it. I'm not sure it's divisible. I think they're connected and
Well, but we're not on the floor.
We would
We're not on the
delete it.
floor.
We would delete
We're
that
on- we're on A
section
floor, yes.
and then deal with that dispensing fee later on. And then, Madam Chair, we will get you a good definition of CMS in there before it hits the House or hits the Senate. We will make sure that's
Committee work.
done. How's that?
Madam Chairman, would you be in agreement with that?
Would you, Madam Chair?
My agreement is not necessary
No.
to the vote.
Mr.
Okay.
Chairman. Mr.
The
Chairman.
voice
The
again.
voice
Your
again.
voice.
Voice in the corner.
Go ahead, sir.
We should give him a big hand that he could just kind of
Yeah.
put up above Senator Bouchard's head because he's behind there.
Mr. Chairman, thank you. If the intent is to avoid, at this point, the issue of what a dispensing fee would mean, I would ask the committee to look at lines 14 and 15, where that term professional dispensing fee is used in the provision. So I guess, unless I'm misunderstanding Senator Hutchins' amendment, that may be worth further discussion.
I see what you're saying, Mr. Brody, Mr. Chair, through you. I see what you're saying. So what I'm basically saying, I'm willing to work with that. So what we're gonna have to do is once, I guess, we divide, then is it possible to amend that particular wording out so that we can work on that later?
Mr. Chairman.
Go ahead, Madam Chairman.
Since, yeah, we don't want to lose this section. It's too valuable for the pharmacists.
Madam Chairman.
Mr. Chairman, thank you. I think probably the simplest thing would be to do to vote up or down on my amendment, and then Senator Hutchings can offer a separate amendment
Roger.
if she wishes on line 14, inserting a period after dispensed, delete through the beginning of line 16, and then do it again on 21 and 22.
Yes,
And that way you
ma'am.
take out the dispensing
Yeah,
fee.
I
in
think
both
that's a
places.
good idea. And like you say, it'll make it easier on everybody. Thank you.
Okay, unless there's further discussion on the original motion and second. All those committee members in favor of the amendment, please say aye.
Aye.
Opposed, say no.
No.
That amendment failed. Further comment on 10. Go ahead, Senator Hutchins.
Mr. Chair, on this page, I would like to amend line 14 through 16 of this bill, or this page 10. After the word dispensed, put a period, strike until we get to line 16, where we have the average period. Then, Mr. Chair, on line 21, after the B and the close parenthesis, we'll put a period and strike to the end of the page for clarity and deal with that later. Thank you.
Do we have a second on that amendment? We have a second. Discussion committee.
All right.
Go ahead and restate that, Senator Hutchins.
Mr. Chairman, I would like to repeat it on page 10, line 14. After the word dispensed, we're going to put a period. We will strike through to line 16, where you have the word average. We'll strike through that and keep the period. Then we'll go to line 21. After the closed parentheses, we'll put a period and strike through to the end of page or line 22. Does that make sense? We're gonna get rid of.
Did everyone get that? Further, any discussion on that amendment? Committee? No discussion. All those in favor of proposed, go ahead.
So I want to ask a question.
Okay.
If there's no price.
Senator Hutchins.
Thank you, Mr. Chair. Senator, I believe the issue is the pharmacists want to keep this section, but they're willing to negotiate with the dispensing fee for now, and we can deal with that later on as we get more information and possibly bring it back if we can get something reasonable in there. Like I say, they're willing to negotiate with us on that. And I think for their sake, if they want that, then that's what I'd like to do for them.
And on that note, I would remind the committee that this certainly is not the end of this bill.
Exactly.
This bill will go before a House or Senate committee.
Yep.
And at that time, certainly, or House and Senate committee at some point perhaps. And that we will have the opportunity to fix that the corrected way, working with pharmacists, working with
Exactly.
PBMs, everyone, if that's acceptable.
Exactly, Mr. Chair.
Okay, once again, all those in favor of the proposed amendment, please say aye.
Aye.
Opposed, say no. That amendment passes. Moving to page 11.
Mr. Chairman.
Go ahead, Madam Chairman.
Mr. Chairman, thank you. All right, here's another one, and this is kind of for people to think about, but picking up on my amendment would be on the bottom of page 11, delete lines 24 through the bottom, and then on lines 12, 1 through 6. And then I have some language on the second page of your amendment, and let me just explain. Oh, is there a second? I'll explain.
Do we have a second on the amendment? Second, go ahead and explain your amendment, ma'am.
Thank you, Mr. Chairman. Thank you, Representative Flitner. So the idea is not necessarily to get away with the spread pricing, and I understand with the discussion about the impact that that has on costs. I, however, feel just I'm not happy with the idea of us inserting ourselves into contracts of private businesses and telling them how they can set up their payment scheme. However, I'm perfectly happy to give direction to the state of Wyoming's employee group insurance, because I feel that that's quite well under our purview. So what I was going to suggest, and admittedly, this would only solve part of the problem, because they have what they say 37,000 lives. That's like, you know, a tenth of the lives in the state or something like that. But I just, as I say, I'm not too crazy about telling private providers how they can write their contracts. So if you look then on the top of page 2 of my amendment, what I did, there's a bill working its way through Congress, and it's actually on its 3rd committee, which gives me some hope that some bill actually will pass Congress in this world. And it deals with prohibiting the feds from using spread pricing. So I just took that same language, pretty much tidied it up a little, because the feds are kind of wordy. And so you can see there, there's a whole language. So what it says is a contract between the state employees and officials group insurance, so that's EGI, in other words, the state insurance plan, and a PBM or a claims administrator. This is, as I say, pretty well adapted from the feds, that makes the benefits manager or the claims administrator responsible to, in other words, if it applies to you because you cover drugs, requires that payment for such drugs. So I'm on the line number 5 here. We have at least decent line numbers here, is based on a pass-through pricing model under which the payment is limited to ingredient cost, professional dispensing fee. Now here we have actually some language on dispensing fees, which we might want to look at later. What the federal bill says is the dispensing fee is not less than what the state plan would pay. So that ties it to the Medicaid that the pharmacist was talking about, or in this case, Medicare, whatever, but in our sense, it would be Medicaid. Is passed through its entirety to the pharmacy. Payment is limited anyway. And so then in paragraph C gets to what we're aiming at. Any form of spread pricing, blah, 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 is not allowable. So in other words, my amendment takes it from prohibiting spread pricing for everybody, all insurance companies in the state, to just the state's plan, which I feel like is under our jurisdiction. That's what the amendment does.
Discussion on the amendment, committee. No discussion. Question. All those in favor of proposed amendment on, I forgot what page we're on, page 12, I believe. All in favor, say aye.
Aye.
Opposed, say no. That amendment passes. And we're
So
gonna-
are you good with that? Are you following me?
Okay, I see a thumb.
Okay.
Okay,
Oh,
let's
swift.
move to page, are you ready to page 13? Everything else on page
I
12?
don't have anything on 13, although there was a question about the definition of
Oh.
promptly, but I'm not,
We'll
that's
leave it
not on
alone.
my bill.
Page 13. Anyone? Page 14.
Mr. Chairman,
Go ahead, Madam Chairman.
this is just an option again. Page 14. So if we see what we're doing, backing up on page 13. For purposes of this section, a PBM is not considered to have retaliated. That's what we're talking about. On the top of page 14, it says takes an action in response to a credible allegation of fraud against the pharmacy. And then again on paragraph 2, I was just going to insert waste or abuse. I mean, I'm not really sure what exactly that would be, but that was, I just trying to make a lot of people happy. So
First of all, do we have a second on the amendment?
I talked again.
Oh, there's a second. Discussion on the
I did my
amendment.
talking already.
Madam Chair, is that from, excuse me, Mr. Chairman, is that from your military life? Because I don't,
Well, that could be, I don't.
I don't think it's
neither confirm or
necessary.
deny
I
the
don't think
source
it's
of my thought.
necessary. I think it's just, it's a fun addition, but I don't think it's necessary.
Further comments on the amendment? No comments. Question on the amendment? All those in favor of the proposed amendment on page 14, say aye.
Aye.
Opposed, say no.
No.
I'm not sure, but I think that one failed. Okay. Okay, let's move to page 15.
No, Mr. Chairman,
Nope.
I have another one.
Oh,
Oh,
14.
boy.
Madam Chairman, go ahead.
Thank you, Mr. Chairman. So this amendment would delete, excuse me, starting on line 8, paragraph D. And my reasoning was just, again, Department of Insurance has enforcement capability. There are existing criminal and civil penalties in 261107. And we had this discussion about whether we have the doctrine of administrative exhaustion. We did have testimony from the gentleman from Montana saying, wow, this is really different. And, as a former healthcare administrator myself, I'm really averse to lawsuits. So I think that's why that was my thought.
Do we have a second on the? amendment?
Oh, stop me earlier. Just here, take the hammer and say stop.
Do we have a second on the amendment? Oh, silence
Really?
for lack of a
Lawsuit
second. That
favoring
that
me.
amendment failed.
No, I think it's
Oh, you brought it
brought
up.
up as unconstitutional.
Okay, let's move to page 15, madam. Anybody with anything on page 15?
Mr. Chairman, I don't have anything here.
Anyone else have anything on 15? Page 16.
Mr. Chairman,
Go ahead, Madam Chairman.
Mr. Chairman, if you look on my amendment, I have some wording here, and then we actually heard from the pharmacists that we might need to, they were gonna trim down my amendment even more. What I understood from the pharmacists was to keep line 6 and 7 to just say, or a generic drug, and stop there on that particular line about drugs and biologics. So it would put a period after the word drug on line 7 and delete the rest of 7. And the first 2 words in line 8 is what I understood from the pharmacy folks. Ms. Carroll is nodding her head. That's different than what I have on my paper, but it's even more concise.
Okay, cuts down some words. Second on the amendment. Oh, we got lots of seconds on that one. Discussion, Senator Hutchins.
Mr. Chair, is Madam Chair deleting up to the semicolon or the colon?
Mr. Chairman,
Madam Chair.
Or to the
I'm
drug,
putting a
period.
period after the word, the first drug.
Okay,
So it's to a pharmacy for a generic drug, period. So then the brand name, the biologic or other
gotcha.
is all deleted.
Thank you, ma'am.
Further questions about the amendment? And with appropriate renumbering by LSO, I might add. No questions or discussion? Question on the amendment? All those in favor of the proposed amendment, say aye.
Aye.
Opposed, say no. That amendment passes.
So happy.
Anything else on line 16 or on page 16?
Well, Mr. Chairman, I have to admit, my original amendment deleted all of this because I don't really. I really got, as a matter of fact, I think it got more confused as we got more testimony about this. So I haven't made a motion yet because we heard from the gentleman from the Pharmacy Association on Zoom that MAC sounds like is kind of moving away, and that's not even a thing. I feel like there's some real uncertainty on this entire page now based on what he said. So I'm not quite sure. Maybe I might stop there, but I think that whole page might need some more work. But I'm not sure what the work is.
Okay. Is there any discussion? It's not a motion yet, so we don't. need
Well, let's work it, and I'm willing to work with them to work it. So
So we'll leave it as is.
just leave it as is and we'll work it.
Okay. Page 17. There's not much to do on this page. It's really short there, man.
Nope.
Anybody with
Chairman?
anything on 17? Yes, sir.
Got the hand this time. This is possibly just to correct a drafting error based on some comments by Senator Hutchins, but my understanding is that the bill should include a definition of pharmacist services, and that definition should align with the definition consistent with Arkansas that we speak to on page 17, lines 13 through 17.
Correct, sir. Mr. Chair, that was correct.
14 through 17.
But I'll work with him on that, Mr. Chair.
Why don't you make that motion, Senator Hutchins? so
Yeah,
it's
go
not
ahead,
always me.
Senator Hutchins.
Oh, make the motion to go ahead and make that alignment. I make that that motion.
And do-
Second.
There you go. You got a second. You guys are
Second it.
pros. Do we have discussion on that amendment committee? No discussion. Question called? All those in favor of proposed amendment on page 17, please say aye.
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 Opposed, say no. That amendment passes. And that will take us to page 18.
Mr. Chairman.
I don't recognize that voice, but go ahead, Madam Chairman.
Mr. Chairman, I do have one small amendment here, and that was just on page 9, or I mean, I'm sorry, page 18, line 9. I was going to strike the new language and go back to the 2. I mean, it seems to me that if the pharmacists have to keep all their stuff for at least 2 years anyway, I mean, I don't know. It seems to me that you could easily want to audit back more than 6 months if there was some screw up. I was going to leave the other ones because it did seem to be in a small state. They ought to be able to do things more speedily, but oh, I talked again before I got a
You
second.
did. Is there a second on that amendment? You have a second. Now you can talk all you want.
I said everything already.
You already
Someone's
said
got
it
to
all.
stop me.
Any discussion on the amendment?
No.
Ready for the question? Question on amendment. All those in favor of proposed amendment? Page 18, line 9, going back to 2 years, say aye.
Aye.
Opposed, say no.
No.
Well, there were a lot of no's. I believe that amendment failed. Okay, anything else on page 18? Page 19. Nothing on page 19. Page 20.
Mr. Chairman.
Oh, go ahead, Madam Chairman.
Thank you, Mr. Chairman. And I leave this up to Ella, so if it's on the bottom of 19 or the top of 20, it was before the F in any case, wherever they want to put it. Mr. Chairman, my motion would be to insert little VI, because I'm bringing in the end of the existing paragraph E. Oops. Well, I had that wasn't explanation. I'm just telling you what the motion is. The motion is to insert little VI, reimburse the provider for a drug using the price that was in effect on the date the prescription was filled by the provider. And you'll see in my typed amendment, I deleted the word maximum allowable cost because perhaps it's based on something else I did here. And I will further explain if I have a second.
Okay, if we have a second, she'll further explain. You have a second. Go
Thank you,
ahead.
Mr. Chairman. So we have heard various things, which seems to be the way this bill goes. I had understood that there was a lot of changing of the price that they thought they were going to get. And then we heard that that doesn't happen because it's all instantaneous. Although then we heard from the gentleman online that if you're not using the maximum allowable cost, but that you're using some other scheme, which I don't remember what he called it, that maybe that would happen. So it seems to me that this insertion of this little 6th line and obviously if there was fraud or something that doesn't fall under this, that would be extraneous to reimburse, I think. That this really just ensures that people, which to my mind is the really key part of it all, to know what you're getting paid when you dispense the product. And that does seem to be something that surely, I mean, I could agree on that with no totals, but I may have misunderstood the whole thing. So that is my, I'd be glad to take any questions.
Discussion on the amendment. Question being called. All those in favor of the proposed amendment, say aye.
Aye.
Opposed, say no.
No.
That amendment passes. Oh, let's have a raise of hands. There was a late no there. Let's have a raise of hands. All those in favor, please raise your hands. That amendment passes, 7 ayes. Okay, that completes page 20, or do we have anything more on page 20?
Mr. Chairman, I did.
Okay, go ahead.
And my motion here is because of now I won't explain it. I'll explain it later. On page 20, line 8 through 18, strike the new language. And I will explain why if I have a second.
If we have a second, then do we have a second? I see a head shake. You have one. Go ahead and explain it.
Thank you, Mr. Chairman. So my reasoning to strike that is we just inserted the language saying that they have to pay the price that was in effect on the date that the prescription was filled. It does seem to me, that base, and along with paragraph J that is below and paragraph K, that protects the pharmacist from having to provide something below cost without knowing about it. Now, it's still possible, out of the goodness of their heart, they may see their patient come in and they may look at the computer and they may say, well, I'm only going to get paid $17 for this and I paid 20. I mean, that's possible. Healthcare providers do that all the time, right? That's the sad world that they all live in. But it does seem to me that to make, whether the PBM is the white hat or the black hat or the purple and red hat or whatever hat they got on, to make another provider responsible for knowing and having to cover the purchasing decisions of their contract party. I mean, it seems a little bit, I don't think that that's really the way things work in business. And so that's why I put in the line that we just voted for. We've got we're going to have paragraph J, which I'm not touching, that says the PBM shall not reimburse a pharmacy less than the amount that they reimburse an affiliate. So in other words, I have to think of a polite way to saying this. If they're making life difficult for the small guy, they have to make them difficult for their affiliate the same way. So that, to me, evens the playing field. And then paragraph K, which I'm also not touching, they may decline to provide. Now, I understand that because they're good people, they won't want to decline to provide. I get that, but that at least gives them to option, say, you know what, you're better off going to pick herbs in your backyard and make yourself mint tea because I can't provide. I mean, that's just what I'm trying to do there. I'm trying to make this not interfering in businesses more than necessary. That's my
That's your
conversation.
goal. Yeah.
That's right.
Discussion on the amendment. Discussion?
Question?
Ready for the question? All those in favor of proposed amendment, please say aye.
Aye.
Opposed, say no. That am-
No.
A late no, but not enough. That amendment passes. Okay, I assume we're getting off of page 20 now.
Yes, we
Okay,
are.
page 21. Changes on page 21. Seeing none, that takes us to the final page, page 22.
Mr. Chairman.
Go ahead, Madam Chairman.
Thank you, Mr. Chairman. All right, folks, I have one last insertion and it's on the bottom of page 2 of your amendment and the top of page 3, grouping together. This was language provided by the Department of Insurance. They would like one FTE and an appropriation of $189,000 there. And then on the second part, $250,000. So this is to administer, and considering also that we put in the Healthcare Reimbursement Reform Act, they could plausibly have complaints from other people that felt that there was network inadequacy or something like that. You will note, committee. Oh, I'm
Would you like a
explaining
second
it.
on that?
Yes, I would.
So we have a second. Go ahead, Madam Chair.
Gosh.
It's
I'm
late.
gonna have to get one of those drug, and there's more ahead of this. Note that the funds come from special revenue funds. Okay, this is not general fund money. This is, the insurance department is funded by the fees that insurance companies pay to be regulated. That's where this money comes from. And so it's essentially asking the insurers to cough up a little bit of money to regulate the PBMs. And I feel like, and if they end up, I mean, the insurance department is an upstanding agency. Obviously, if they don't use it, they'll be happy and they'll revert it and it won't have to, and it, it does say, let's see, ending 2022. And the second one is annually, but that can obviously be adjusted, and once it goes through JAC, it probably will be, although as I say, it's special revenue. seems like a fair enough ask.
Discussion on the amendment.
Let's do it.
No discussion, question. All those in favor of the proposed amendment, say aye.
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 Opposed, say no. That amendment passes. And there's only one more page, but unless you want to change the word "and," I don't believe we'll have any changes on that
Can we
page.
spell it differently? Just put fiend?
The end. Okay, committee, that brings to a termination our working of the bill.
Mr.
Any
Chairman.
comments in general? Oh, I see a hand. Go
Mr.
ahead.
Chairman. Just two things, and it's just because it's late, I feel I should raise it just in case it was forgotten. The first being that the bill still currently doesn't contain a definition for health benefit plan. I don't know if the committee had discussed a
I did
placeholder.
I had one on that, Mr. Chairman.
So I don't know if that's something the committee wants to consider. The second
drafted
thing
one.
is that based on testimony from the Department of Insurance, they indicated that the rulemaking would not be complete within the time of the effective date of this bill. So I just wanted to remind the committee about those two issues.
Thank you. It's hard to believe Madam Chairman forgot one, but do we have a post? Senator Hutchings, go ahead.
Definitions there, so, Madam Chair,
As something different, but we had a definition from somewhere, Virginia, I believe, West Virginia. So if you look at page 4, if that doesn't suit your fancy in the top of page 5, then we'll take what you have.
Mr. Chairman.
Madam Chairman, go ahead.
So thank you. Thank you, Senator Hutchings. And so I have actually drafted something that is shorter. And my reasoning is the bottom of page 4 has private health benefit plan. And then on the top of page from Wyoming statute, and the top of page 5 has public health benefit plan. My thinking was, I think as a matter of fairness, this bill needs to apply to the state EGI, to public employer plans, not just the private sector. Otherwise, I feel like it's not, we're asking one type of employer to bear costs that others are not. And because and it's possible it may need to be reworked later if we see that mine is too simple, but I feel like it's the one that I'm going to suggest would at least give a placeholder that includes public and private together in one paragraph. And John, I have it typed up so I can send it to you. You don't have to write it down, but I'll tell the committee what it is. So, and can I have a second?
Do we have a second? We have a second. Go ahead.
Thank you, Mr. Chairman. So I would move on page 16, on the top of the page, I think, because they're probably in alphabetical order, I guess, somewhere probably line 2. Here is what this really, and this is based off more or less from what Department of Insurance sent me, but I kind of squished it. Although it does say, the commissioner said he's used LSO's definition from West Virginia. Okay, so what it says is, but I added some. In this article, that's right, in this article, health benefit plan means a policy, contract, certificate, or agreement entered into, offered, or issued by a health carrier or disability insurer to provide, deliver, arrange for, pay for, or reimburse any of the costs of the healthcare services. Health benefit plan does not include Medicare, Medicaid, or other health benefit programs or coverages operated or maintained by the federal government. So in other
Discussion.
words, that would include everybody, public or private, except the feds.
Discussion on the proposed amendment. No discussion. We're ready for the question. Question being called. All those in favor of proposed amendment, please say aye.
Aye.
Opposed, say no. That amendment passes.
Okay, and I will send it to John right now.
Okay. Yes, ma'am. Oh, Representative Holland, I'm sorry, I didn't see you. Go ahead, sir.
Well, thank you, Mr. Chairman. I think that we all need to remember that monopolies are there. They are there to take advantage of their power over the people. And the state has the obligation to do something to prevent them from abusing that power. This is a monopsony. They are buyers from the people, and they will use that power to defeat the people in their pursuit of happiness. So the state has an obligation to do something to control a monopsony. These are monopsonies, and they are using their power to take away our rights and the rights of these pharmacies to operate. So it's every bit popular, it is every bit appropriate that we are passing this bill. And I am very much in favor of it, and I urge unanimous support for it. Thank you, Mr. Chairman.
Thank you, Representative Hallinan. Is a further comment on the bill? Go ahead, Representative Conley.
Yeah, thank you, Mr. Chairman. Mr. Chairman, I actually was very much in favor of us passing something that would help our small pharmacies. But honestly, I wanted us to take a small bite, and I thought that we could have taken a small bite. Maybe just addressing the clawback provisions or the reality of clawback, the lack of transparency. But honestly, I am deeply concerned about $7.5 million of additional costs to EGI. I'm concerned about understanding that that would just be multiplied to others in the state with private employers. The costs are enormous, and we haven't dealt well enough yet with that reality. So at this point, I can't support it.
Thank you, Representative. Further comments, Senator Hutchins?
Yes, Mr. Chairman, I appreciate the previous comments, and I too am, I feel the same. But in all my research, I haven't found one state that's made these comments. And I guarantee you, I will spend as much time as I did this summer working with these people with this bill. And if we find out that happens, we will withdraw this bill. So don't think we're just gonna go willy-nilly into this. I will investigate as much as I can, and I'll make sure you get all the information you need to feel comfortable by the time we hit session. I'll do my best. Thank you, Mr. Chair.
Further comments?
Actually, Mr.
Ready?
Chairman.
Go ahead.
Thank you, Mr. Chairman. So I just want to follow on that. Once it's a committee bill, we can't warily withdraw it. I mean, I understand, but I mean, so there is another option, which is, because if the committee does not vote to sponsor it, that doesn't mean the bill won't go forward. I'm pretty sure that our two members who have been working on this will continue working the bill. So I mean, I just want to say that is certainly another possibility if there's a concern about not having everything pinned down tightly enough yet. So I just wanted to
well
remind people of
described.
that.
And I guess I would add the commentary to this and explain, I will be a no vote on the bill, and it's not because I don't like the bill, but I've tried to imagine through the time, as all this time we've been working on this, trying to bring this to 90 members or 60 members or 30 members on the floor. If you can imagine how long it's taken you to get to a partial understanding of this bill, it's a complex issue. And I'm not sure we're to that point where we can take it to the floor. It's a passionate issue. I like everything I've heard out here. But I think it's going to be a difficult one to put forward on the floor. For that reason, I will be a no on the bill. I suspect it will pass, but I will be a no. So with that, are there any further comments on the bill? Go ahead, Representative Romero Martinez.
I have the same concerns over the 7 point whatever million it might cost. And I just want to one last time, urge all the said no votes to take the risk and have a unanimous aye.
Further discussion? I see a hand. I saw your hand on Zoom, actually, it was behind me, but go ahead, Senator Furphy.
Thank you, Mr. Chair. I'm going to be a no vote on this bill. Whenever I see a bill that has this many amendments in one day, I go, I'm not sure it's ready for prime time yet. That concerns me. We need to take more public input on this bill. And secondly, I'm very concerned about raising the cost, not only to the state, but to our citizens as a whole. So I need to understand that. And then finally, when I see a bill that has that many staff comments in it, I'm going, whoa, we better be careful and we better spend more time on this bill. So that's why I'll be in the vote. Thank you.
Thank you, Senator. Further discussion, or are we ready for the question? Question on bill. Let's go ahead and call roll on whether this be sponsored as a committee bill.
Mr. Chairman, this is a roll call vote for 22 LSO 0147, Pharmacy Benefit Managers Act enhancements as amended. Senator Bouchard? Aye. Senator Furphy?
No.
Senator Hutchings? Aye. Senator McEwen?
Senator McEwen, are you still with us? Excused. We'll question again at the end of roll call. Go ahead.
Representative LeBeau? Excused. Representative Connolly? Representative Flitner? Representative Hallinan?
Aye.
Oh. Oh.
Who did you say?
Okay, we got
Hallinan.
aye from Hallinan.
Representative Hallinan?
Aye.
Representative Ottman?
Aye.
Representative Romero Martinez?
Aye.
Representative Stivar?
Aye.
Representative Worf?
Aye.
Chairman Wilson?
No.
Chairman Baldwin?
No. What? Let's try McEwen one more time, see if he happens to be out there. Senator McEwen, are you available for a vote? Apparently not. We'll call him excused.
8 ayes, Mr. Chairman.
Yes.
Thank you for all your work. Okay, let's give the gavel back.
Thanks a bunch.
Hi, Dr. Hallinan.
Are you getting tired yet? I am.
Okay, here I am.
I
Okay,
think so.
Committee,
Gee.
we're back together. All right, committee, we have two last items just for your consideration, whether you want to dispatch them quickly or not. I have brought back up our House Bill 1006, which we have, at least on the House side, seen a whole lot of times by now. This was the bill that we voted to sponsor in June, and then we kind of re-voted to put it in through special session. And it was introduced on the House, considered and passed the House committee, and then didn't make it to the floor. The reason that I brought it before you tonight, and I will tell you frankly, I am one of those people that is perfectly happy to take a half a loaf if I can't get a whole loaf. I don't, I will just tell you, I think that there are some things that we should take out of this bill because they plainly did not have enough support on the floor. I mean, I would love to have the bit that we put in about reasonable accommodation for work, but we saw what happened to those bills on the floor. It didn't work. I think possibly if the committee wants to, you know, if there's a motion to do the bill, I think that we could have a half a bill, half a loaf, as it were, covering requiring reasonable accommodation for healthcare facilities for visitors. We could have the prohibition on vaccine passports for essential businesses unless they have reasonable accommodations. So you remember we talked about like curbside delivery and that sort of thing. And I'm just talking at the 30,000 foot level. I mean, we've seen this bill so many times. I just figured that. And so then in the House committee, the item on the personal objection to the K-12 vaccine was, did not pass. And so I would take that out and then really take off, either take off all of the unemployment, the employment part, or just say that it's only based, it doesn't cover people who are covered by a federal requirement, and I have some potential language on that. In other words, take the parts that we can and get rid of the parts that that we didn't have enough votes for. We could do that. Or we could not. But, that's up to the committee. So I just would like to, if there's, if there is a motion on the bill in a second, then we can work it. And if there isn't, if people would rather go home.
My
then-
question for Chairman is that if we do not sponsor this as a committee bill,
Mhm.
would you sponsor this as an individual bill?
Yeah, I think I would.
That's my only question.
In the half a loaf form. I mean, really, I don't want us to spend a lot of floor time during a budget session. You know how many hours we spend on all those special session bills, hours and hours and hours and hours to get nothing. So I want to do that. But maybe there's some small parts that we might be able to get through. That's, as I say, and if we don't want to mess with it, that's fine too. Representative Stivar.
Oh, yes, Madam Chairman. We passed this out of the House committee.
We did.
I say bring it back as committee bill.
Yep.
As we passed it out of the House committee and try it again
As amended.
as amended.
So is that a motion?
That's a motion.
Okay, is there a second? Seconded by Romero Martinez. Although I think we should hear maybe, well, it's moved and amended, but I guess. Senator Baldwin, do you have a thought from the Senate side? No, that's sorry, it's kind of late. That's perhaps not the best procedure, but we're flexible here.
So, and I guess my question would be to LSO, to John, about the proper procedure for bringing this back. And I keep thinking of that sentence that I heard as we were closing session. These bills that have been considered will be, I don't even know what the wording was, but Mr. Brody.
Mr. Brody, is there are we, what's the proper thing?
Well, actually, I was going to comment on a separate thing. Apologies, but I just wanted to make sure the committee didn't get too far ahead of itself before offering public comment on this topic or these bills.
Oh, well, we may as well know whether we're going to deal with it or not before we take public comment, but that's a good comment. Thank you, Mr. Brody. I'm ahead of myself on every direction. Left, right, up, down, all over the place. Representative Worf.
Madam Chair, yes, are we just talking about?
So my conversation was, and that's a good, perhaps I'll just say, and I might have to walk back my, my motion. I think that might be a thing. So you'll note on the agenda, we had the House Bill 1006. The other, when we were in Casper, there was a committee motion to have a bill drafted having to do with COVID and mRNA vaccines. That is the Senate File 1007 that you see before you. And so because it was a request of the committee to have the bill drafted, that is why that is in front of you. So that is certainly something that maybe we should back up and have some discussion about where we want to go with this. Remember that excuse me, the HB 1006 deals broadly with vaccination and passport type issues. It's not, as a matter of fact, that's why it didn't get introduced on the floor, was because it wasn't specific to COVID. You know, my preference is if you're gonna write a bill, write one that lasts, but that was just me. The other bill is very specific to a particular kind of vaccination. And so, yeah, they're both here. let's, maybe we can, now that I just sort of take a discussion, Senator or Representative Stivar, let's kind of, committee kind of talk it through what your desires would be.
Well, I put a motion on the floor just for
I know.
101-006.
I'm backing up on your motion there, just
Okay.
because I realize it probably is better to talk about them as a group. Let's hear what people would prefer to do rather than vote and, work one bill and then decide we like the other one better or what. Maybe we should just hear what people's opinions are. So that's what I'm asking.
I think they both need to be committee bills.
So your preference would be to have two committee bills.
Yeah,
Okay.
both of these. One,
Representative Flitner?
1007 and 110.
You're done. It's okay. Senator Hutchings.
For a few moments flapping my hands. I prefer both of them. I say we go for broke. We don't think about what happened in the past. We don't know what's gonna happen in the future. They looked good when I saw them the first time. I'm for them. Do it.
Representative Connolly.
Thank you, Madam Chairman. I favor 1006. I don't think we need to even debate that bill again. We've gone through that bill twice.
Yep.
I think we ought to just go ahead and send it just as is. On 1007, as you know, I would be in favor of this bill. However, I don't know that we have the support in this committee for it. I think we ought to vote it. I think we ought to vote on it without any debate. And because I think we know all the issues that are part of 1007. If it passes, then we ought to have it be a committee bill. If it doesn't, we drop it. Thank you, Madam Chairman.
Okay, Representative Connolly.
Are we sure?
Finally, Tim.
Madam Chairman, I'll be a no on both of these.
Okay. Senator Baldwin, what's your thinking?
My thinking is just this. So many people over here to comment on both of these bills are now gone because we passed their bedtime. And I'm not sure that we'll get a good representation from the public. And that would be my opposition to hearing bills. Although 1006, we've talked about it, we've debated it, et cetera. If we do one, that would be the one I would suggest. But I think that we've lost a lot of our public comment. My guts tell me they probably both will pass committee, but I don't know if this is a fair public opportunity. But that's
Fair
my
enough.
thoughts.
Fair enough. Representative Romero Martinez.
I think we've talked about it enough. I think I'm for both of them. I think there's some concerns that need to be brought. I think the public, for the most part, has some similar concerns. We all want to support the common good, but we also want to see ethical vaccines. And right now we need to take a look at the fact that breakthrough infections are taking place. Maybe that's because we didn't inoculate or vaccinate in time or whatever, but either way, I just think both of them, I think we've already looked at them enough to where I think we need to at least give them a shot. Thanks.
Let me just be clear, committee, that the House has not seen 1007 at all, ever, because that was drafted by LSO after the Casper meeting and taken to the Senate. So the House has not ever seen any of it, just so that we remember that, to be clear. Okay, Senator Furphy.
I'm a no on both. Which again, putting a mandate on businesses in our state. We already have the federal mandate that we're fighting. So put more mandates on business makes no sense.
Okay. Representative Worf.
Yeah, Madam Chair, I just would want to know whether we're doing them both at the same time or how we're doing it. I think we should probably do both of them.
Okay, Senator Bouchard.
Thank you, Madam Chair. I don't know if you've seen today the news, Supreme, or not the Supreme Court, but the appellate court has actually held that the mandate was unconstitutional. So that's already moving in that direction. But I mean, we've gotten to a point now where we haven't even solidified that, and we have so many companies just jumping on board before it was even ready to go. This is about sticking something in your arm against your will. And I thought America was about having choices. So I think we should, both bills, let's move them out there. And if we can get them out of, if the committee votes yes, and they can have a larger discussion on each house.
Okay, Representative Ottman, are you there?
Yes, thank you, Madam Chairman. Since it is November and we will not be going back till February, and we know things happen so fast, and the governor does have 3 lawsuits in, and I know there's a lot of personal suits that are going on. I would vote to carry both of them forward. They each have individual things that they're addressing. So I would be a yes.
Senator McCune, are you back? Doesn't look like it. Okay. Okay, well, committee, that's enough to consider it. I will say that just like all the floor votes, it's very divided, and it's, you know, I do think we need to really consider, and as Chairman Baldwin pointed out, we really have no input. I mean, that looks like we might have a few poor Mr. Hannes there in the back, and like, we have a couple of people here, but it's, I don't know how representative they are of the world, but that's all right. Let's, now, folks, let's just really not, what? Who? Well, are you here to testify on these bills? Well, good, I'll call on you eventually, but we're gonna start with, I gotta put one on the table. So, you know, no, that's good.
Madam
That's
Chairman,
good. Mr. Baldwin, or Mr.
it's late.
Whoever you are, John.
John Brody. I just wanted to note that we also have an additional individual online who's been with us since about 3 o'clock. So,
Well, we've been here since 8. Okay. Then Representative Stiver, I'll let you have your motion back. All right, committee, we know this bill extremely well. I am going to take the liberty of telling you what I have. As I say, I am a half a loaf kind of person. And so I have an amendment that people can either vote for or against, and I'm just going to tell you, actually, we can't work the bill yet. We should have our public testimony. Here you go. Someone got to keep me straight. Sir, come on up and talk. We are looking at House Bill 1006, vaccine requirements limitations. Is that the bill you're here for? Oh, you want to talk to the other one? Oh, you thought you were going to be able to get up, right? Is there anyone who would like to testify on House Bill 1006? Mr. Hanneswood. Oh, good. We have several people. Isn't that exciting?
I would like to testify.
Well,
Hello.
yeah. Ms. Higgins will call on you next. Go ahead, Mr. Hannes.
Okay.
Madam Chairman, members of the committee, once again, Josh Hannes with the Wyoming Hospital Association. My comments for both bills will be probably identical. In 1006, the employment piece is problematic for us. While there is a court that's stayed the OSHA rule, it does not apply to the CMS rule at this point, though there are lawsuits pending, Wyoming being one of the states that has joined that lawsuit. CMS regulates everything we do. We have to comply with those regulations. There's not a way around it for us. So we would be strongly opposed to 1006 in its current form that includes the employer pieces.
Okay, questions for Mr. Hannes? Representative Romero Martinez.
I don't know if I'm out of order again or if I'm half asleep, but what would be the best way to address that issue regarding CMS rule that you just mentioned?
Secede from the union?
Huh?
Mr. Hannes.
Yeah, probably did.
Madam Chairman, Representative Romero Martinez, the lawsuit that our state's engaged in is the remedy. We have to follow CMS regulations at this point. there's consequences and penalties tied to that.
Thank you. Any other questions for Mr. Hennis? Anybody? Yes, someone? Oh. In where? In Zoom? I didn't see him. Okay, bring him in. I'm getting giddy. It's like some low blood sugar or something. Mr. Johansson, hello.
Thank you, Madam Chairman and members of the committee. I am sorry. I was at the office across the street from where you are, and I had some computer issues, so I raced home to get on my home network and be available to you. Madam Chairman, I am just available here to answer questions for the committee that you might have about either one of these bills.
Okay. And I see you. We had Ms. Higgins online.
Hi.
Hello, Ms.
I don't know
Higgins.
if you can hear me. Hi, I'm so sorry. I know you guys are really hungry and ready for bed. Me too. It's way past my bedtime. My name is Christy Higgins. I'm a registered nurse. I worked at Cheyenne Regional Medical Center for 10 years. Unfortunately, I haven't been able to work since the end of May, and it was due to my vaccine, my Pfizer vaccine. I got COVID in January, and because of work, because we didn't limit, I worked at Davis Hospice, we did not limit visitors. And then between all the coworkers, we were just passing it around. So I ended up getting COVID, and my PCP told me to get the vaccine, wait 90 days and then get the vaccine. And I would honestly tell you that originally I was like so against the vaccine. I'm like, I don't want to be a guinea pig. I feel like this is being rushed out so fast. I feel like there could have been more trials done. But then I got COVID, and then I was so afraid for my family and my patients and their families that I went ahead and did what my doctor told me to do. The first day I got the vaccine, I felt okay, a little bit achy, no big deal. A few days later, started getting daily migraines, daily vertigo. After the second shot, I started getting to double vision, blurred vision. I couldn't walk right. I couldn't walk straight. The first time I fell was in May, and it was definitely, I had overexerted myself, but I have overexerted myself many years. I'm 43 years old. I've done gardening for so many years. So for me to overexert myself and to fall on my face was kind of odd. Then I started falling frequently for a few weeks. I saw an ear, nose, and throat doctor because I was trying to figure out if I had vertigo. He thought I might have had myasthenia gravis, so he tested for that. It was negative. I went to so many specialists and doctors and neurologists, or what do you call them? Anyway, different kinds of neurologists that deal with the eyes and the vision, and just so many different doctors. And basically, I even had a lumbar puncture. Everything came back normal. I thought I had MS. At one point, I thought I was getting Parkinson's. I couldn't walk. I couldn't walk without a walker. I was shaking and tremoring so bad. I had seizures in June. I had 2 seizures at Walmart. When I had my follow-up study with that, it didn't explain why I was having seizures. Nothing could explain what was going on with me. And so my final neurologist that I saw is the one that said he thinks it was related to the COVID-19 vaccine. Unfortunately, I found out in all of this mess that I had rheumatoid arthritis. So my whole thing is, if there's risks, especially if you have an underlying autoimmune disease, we should have a choice. Like I said, I was never really for it. I wanted there to be more studies, and there just wasn't enough time. It was just rushed out so fast. And I wish I could have gone back, because I literally just found out that I lost my job 3 days ago. And I've worked for the hospital for 10 years. 10 years I've worked at CRMC, and they can't hold my position any longer. And all I was doing was trying to protect my patients and their families and my coworkers and my family. and now I'm jobless. So please consider the fact that if there's risks, it should be everyone's choice. It should not be, it's so unconstitutional to mandate everybody gets vaccinated when this vaccine is so new. I have articles laying around me that I could read to you, but the person that invented the mRNA DNA vaccine, Steve Kirsch, read his article. He's not the one that invented the COVID vaccine, but he's the one that started the mRNA vaccine. And he has articles out there that say it's unsafe, especially in children. My children will not be getting vaccinated. Luckily, nobody in my family and none of my friends had reactions like I did. I was the lucky one, but I just think it should be a choice and not mandated. If you guys are worried about having enough staff to deal with this healthcare crisis, if the vaccine is mandated, you're going to have hundreds of nurses walking out, and then there's really going to be a staffing issue. You know what I mean? So I appreciate you listening. I've been waiting since 3 to talk because I can't see to drive half the time. I mean, my vision is the biggest problem I have. I still get the tremors. I haven't had any seizures, thank God. I still get muscle twitching tremors. My vision is still bad. Definitely not back to my baseline. But anyway, thank you for hearing me. And I hope you consider that there's a lot of other people that are going through this, that it's really difficult to report.
Ms. Higgins, thank you so much for coming and sticking with us all these hours and
yeah,
testifying. Really appreciate it. We certainly send you all the best and hope that you will be able to recover. Thank you for your past commitment to your patients.
Thank
Are there
you.
any questions for Ms. Higgins? Senator Bouchard.
I don't have a question, Madam Chair, but I just want to say thank you for your courage.
Thank you. I appreciate it. I'm a fighter. I've always been a fighter. And I hope that when I do get better, I can just go back to Davis Hospice and work there again. I mean, I just have a feeling everything happens for a reason. And that's why I felt like I should probably talk to you guys tonight just to help other people in the future. Because I mean, I've heard of so many stories just recently. 29-year-old athletic bicycler had cardiovascular issues because of the vaccine. I apparently have a heart murmur now. I haven't been able to follow up on it because you can't see a specialist for, months. I'm getting ready to lose my health insurance. And then there was the Denver police officer who couldn't feel his legs and was falling after his vaccine. And there's so many more on like TikTok and all the social media I don't know how to use, but there's so many more stories that are coming forward. But once they are found out about, they get deleted or censored. It's kind of a scary thing. It's just a really scary thing what's going on. I just feel like everyone should have a choice,
Thank you very much, Ms. Higgins.
Yes.
Okay, Tony Declever. Oops. Oh, I'm sorry. Did you have another question?
I wanted to make a comment, Madam Chair, if it's okay, I missed her name because I went out to the restroom.
Higgins.
Mrs.
Christy?
Higgins, Stacy, thank you so much. Christy, one of the things I think we keep hearing how valuable the vaccine or the COVID shot really is. And someone sent me to the openvaers.com, a doctor in one of the appropriations committee. And then I was told by a friend last night that may just be 1% of all the
Exactly.
cases and symptoms that people are having. You could take the shot and be totally healthy, be totally fine, and your spouse takes it or your sister takes it. And we've seen our Sergeant of Arms die with COVID complications after being fully vaccinated. We've seen one of our senators with Bell palsy, and there's people like you all over the country that we're really not hearing from. So thank you for taking the time to spend with us. Appreciate it.
Okay,
And I appreciate you guys listening. The VAERS reporting system is not ideal for the vision problems that I have. I tried twice to report my symptoms and it kept timing out on me because I couldn't see to type fast enough. And when you call the 800 number, you can't speak to anybody. So my symptoms were never reported until yesterday when I called another like pharmaceutical company. They are mandated reporters, so they reported it for me. But months and months ago, it should have been reported, and it was next to impossible for me to report. So yeah, there's a lot of stuff out there that's not getting reported. But thank
very
you for
much.
listening. I
You
appreciate
bet.
it.
Thanks for being with us. Okay, Tony,
Uh-huh.
Beckler,
Thank you, Madam Chairman. members of
introduce
the committee.
yourself for the committee, please.
Tony Decklever with Wyoming Nurses Association. Since the House Bill 1006 is as presented, the Wyoming Nurses Association would support the School Nurses Association in having you delete personal out of the vaccine mandates and or in that section under the school immunizations for children attending schools. The school nurses would just, they're very much opposed to anything that would take away the other vaccines that are currently being mandated for many, many reasons. And so the Wyoming Nurses Association supports the School Nurses Association in not taking away mandated vaccines right now. The other thing, and this is just a clerical thing, and Senator Baldwin probably does not remember this, but he called me several years ago and said, Tony, go through all of our statutes and find out wherever it says physician to change it or to see if we could change it to healthcare provider. And so and there was like 172 references to physician. So in this one, it says,
What page are you on?
and I am on page 6 and we are on line 4 where it says private licensed physician or his representative. And so if there was going to be an amendment to change that to healthcare provider, because that would incorporate PAs, MDs and nurse practitioners, all that give vaccines. And then it is also on, I'm sorry, page 5. So it's in two places. I'm sorry, it is on page 6, but it's also on page 5, lines 15 and 16, where it says private licensed physician or his representative. And so if we're cleaning up language, that would be
Okay. Although I will comment that if we strike the personal
Yes,
objection,
it would come out
then
anyway.
that entire section will be removed in any case, which is what we did in committee. Okay, any other testimony on this bill? Okay, then public testimony on 1006 is closed. In committee, I'll just take the liberty of telling you what I'm gonna make it in the form of an amendment, which you can divide if you want to. As I say, I think we should go for what we're more likely to know that we can and not worry about the things that died already. So I think we need to, and John, on line 5, it actually doesn't say limiting immunizations for children attending schools, which when we had that 5-year delay, I think that might need to be in there in the bill title. You know what I mean? I'll point that out when we get to that part. Okay, so committee, my motion would be on page 5, starting in line 6, strike that paragraph and all of page, I'm sorry, just page 5, line 6, strike all of that and then strike page 6. That was the part that went out in House Labor Committee. We had so much pushback over the personal objection that frankly, I think if that stayed in there, we probably would lose the whole bill. And so I think that's the first part of my motion would be the bottom of page 5 and all of page 6. So John, my comment was on the paragraph that would remain on the top of page 7. That's really not addressed in the bill title. Like on line 5, we could strike creating a personal exemption if this passes. But it seems to me that it should still say limiting immunizations for children attending schools, because otherwise the school component is not in the bill title. Wouldn't it be better to have it in there?
Madam Chairman, yes.
Okay, so that would be the second line of my mental amendment. And then on page 7, line 17, and again, this is my half loaf theory. My idea would be to, after the word unless, insert the requirement is strictly based on federal law or rule. And here's my thinking. Then it would say for it's unfair employment for an employer to require as a condition of employment that any employee be immunized for any preventable disease unless the requirement is strictly based on federal law or rule. Here's my thought. I don't feel like I want to spend a whole lot of airtime on the whole OSHA thing, on the CMS thing, as the hospital people have said, that went down. But we know that OSHA is they've not yet dealt with people 99 and under. There's half the employees across the state are still out there hanging unaddressed. I'm willing to say you need to provide reasonable accommodation. So those are, so that adds up to, and then actually on page 8, I think I would delete from line 6 down. So let me just go back and there's I think 4 things, and you can hold them in your head because we've got it. And I think the item on line 1 is really just a conforming amendment, so I won't address that. So my amendment would be on page 5, strike from line 6 to the bottom through the bottom of page 6, because then, so that's the first part. Then on page 7, insert that the requirement is strictly based on federal law or rule. That's the second part. And then the third part, because I would rather get something through than nothing. So those are the 3 parts. And do I have a second? Seconded by Flitner. Is there discussion? Representative Stiver.
I need a better explanation why you're wanting to get rid of line 6 on page 8 on down. I mean, that goes into, your religious exemptions, your personal exemptions. And why do you want to get rid of that? I need a better explanation.
Madam Chairman, no, sorry. Answering myself. The reason why is because after seeing 1001 croak, 1003 croak, I don't perceive the appetite in the House or the Senate to go there. And I would rather get the first part of the bill through than nothing. I mean, that's just my style. Because I think, I mean, that's just my read. I'm looking what happened in the Senate on 1003, and you senators can say, looks to me like people that don't like that employer part will probably kill the whole bill if it's in there. And I would like to maintain some component of, preventing them from putting COVID vaccine on the school list for 5 years, of enabling people to have, whoever thought a year ago that we'd be where we are now. Can we say that by July, there won't be vaccine passports all over to go in the grocery store or whatever, like there is in Europe? I don't know. And the healthcare visitation thing. I feel like those are important things, and I think maybe we can get that through. I don't think that we can get the business part through. That's not what I saw 2 weeks ago or whenever we were here. Yesterday, right? Seemed like yesterday. That's just, okay. Any other discussion? Discussion? Senator Bouchard.
I feel differently about that. I think that I think a lot of people made decisions and didn't really hear from their constituents. So I don't know whether it's going to be the same climate when we go back to session. So, I mean, look, you know what I do for a living. I'm out talking to people out there, and I just don't think. I
understand it's a gamble. I mean, right? We can go for a whole loaf and lose it. And if you're willing to lose it all, I don't know, that's not my approach. I'd rather help some people. Okay, question on the amendment. All in favor of the amendment, raise your hand. Let's see, on the it's 1, 2, 3, 4, 5, 6, 7. Okay, so the amendment passes. Are there any other amendments? Representative Flitner.
You didn't address that, did you? And that I missed that?
No, but I can, I'm sharing. That's existing statute. The only reason that's there is to change the B to a C because we inserted the reasonable accommodation stuff. So that's existing law.
Okay. Okay. Thank you.
Okay, any other amendments on the bill?
No, Madam Chair, if you don't mind. Question on, you mentioned somewhere that you added federal government's mandate. Was that on page 7?
It was
Once
on
you
page
said it,
7.
that-
So
Okay.
this paragraph says that it's an unfair employment practice. So in other words, we're asking employers to provide a reasonable accommodation for a person who won't show proof of immunization. That we don't address any kind of exemptions. We just say that you have to provide a reasonable accommodation, and that fits under existing, ADA, civil rights law and so on. But to address the OSHA CMS issue, look, I'm not trying to fight the feds. That's some people's battle. I'm trying to get this bill through and just, if that thing dies for them, great. What I'm trying to do is rope in the remaining half of the people in Wyoming for whom we did nothing. We're not even filing a law. I mean, their employer can put in amendments or requirements, whatever. So yes, I'm sorry, I'm rambling. I inserted afterwards unless the requirement is strictly based on federal law or rule. That leaves the CMS people and the OSHA people to do their thing, but we are addressing the other businesses where the owner wants to have a vaccine mandate. I'm trying, as I talked about in when I presented this bill in Riverton, I'm trying to walk the line between an employee's, a citizen's rights and an employer's property rights, which they do have, to make a mandate. This won't prevent the mandate, but it will say you have to, if you've got a mandate, small business owner, you have to provide a reasonable accommodation. And there's existing law, case law for decades. Some people still won't be helped by this because the employer may say, there is no reasonable accommodation in my bill, and that, then you fall under existing law. I used existing legal concepts in this to help as many people as I can get without overturning the legal system.
Well, Madam Chair, I do like that you put be immunized for any preventable disease.
Well, I don't think there's
Because-
immunizations for that's
'Cause-
existing.
Yeah, I like that part.
That is, I think that was in
Existing
existing.
law
This
already.
looks like a new paragraph, but
Is it new?
Mr. Brody, do you remember, why did we say preventable in that? I guess it's because you can't hardly immunize against automobile accident. You know what I'm saying? It's not preventable. I guess it's not preventable.
Madam Chair, I'm a bit confused. Didn't we just pass that amendment? And
We
so I'm
did.
not- so I'm
Senator
not
Hutchings
sure
was
what
just,
we're doing.
she asked me, wanted me to repeat, and I guess I've repeated enough, probably. Okay, were there any other amendments to the bill? Okay, then,
You brought it up.
question on the bill, whether to sponsor this as a committee bill. Please call the roll.
Madam Chair, this is a roll call vote on draft bill of House Bill 1006, vaccine requirements and limitations. Senator Bouchard. Aye. Senator Furphy.
No.
Senator Hutchings.
Aye.
Senator McEwen.
Excused.
Representative LeBeau, excused.
Excused.
Representative Connolly. No. Representative Flitner. No. Representative Hallinan.
Aye.
Representative Ottman.
Aye.
Representative Romero Martinez.
Aye.
Representative Stibar.
Aye.
Representative Worf. Co-Chairman Baldwin.
Aye.
Chairman Wilson.
Aye. Okay, the last thing for tonight, hopefully, is Senate File 1007, COVID and mRNA vaccines, limitations and prohibitions. And I do remember that you will want to testify, and I won't forget, but the House has not heard this bill. So Senator Bouchard, would you mind presenting the bill to us? I think with you being on the corner, we can see you, okay?
Thank you, Madam Chair.
Make sure you're close to your mic, though. You're a little distant.
So this bill is based on what we voted on. It has all the same issues that it was a different drafter, I think, than someone that works on the committee also, but handed them the same notes. And the key to this, and you can see it in the title, I didn't really want to cross over into any other vaccinations or anything else. I want to keep it specific to COVID and the mRNA technology. So as we go into page 2, they used a lot of wide-reaching definitions, some that aren't even needed in this bill. And I kind of think LSO even looked at the passport thing. I think it's in here as well, but I don't think the bill actually does anything in passport. So go on to page 4. You'll see public employee means any employee of or providing services. And then it also says as independent contractor for government entities. So these are anybody who takes money from the government. So it does reach far, not only government, but into government contractors. Remember there were segments of this that we did for the state employees, and there were another segment that would be for everyone. And that's why some of that language is written as such. Vaccination status means evidence of whether a person has received 1 or more doses of mRNA vaccination, including evidence of immunity passport. So what is there? It's broad, meaning that no matter what their immunity is, the reason we're defining that is because with the basis of this in this bill is that they can't ask. It's my personal business if I've been vaccinated. I don't think it's the whole world. I mean, that's kind of where we've been up until recently, I think. So it goes on to say no contractor shall coerce, require, mandate, otherwise make policy that forces, compels, or requires any person to receive mRNA vaccination. On 14, line 14 on page 4, no governmental entity or public employee shall force, require, or coerce a person to receive mRNA vaccination against the person's will. The state officer shall not include mRNA vaccination in any required immunization. So, I mean, again, we're trying to differentiate any other arguments about other vaccinations. No person shall refuse, withhold, or deny to a person any goods or services, facilities, advantage, or privileges that are public in nature or that invite the patronage of the public. As it goes on to line 6, you can just say no person shall ask a person or inquire into a person's vaccination status in order for the person to access any service goods. I mean, that would be, I could see they could actually put something on the storefront that says you can't come in. That's what they want to do, their business, but they can't ask you. So again, it's personal information. On line 13, page 5, each contractor, government entity, public employer, or an employer in Wyoming shall not accept a waiver or exemption for any mRNA vaccination requirement imposed. Subject to the provision of this section, waivers or exemptions shall be authorized and accepted by the contractor. So the whole idea is that they have to accept it. As we go on to page 6, more of the cannot ask language. No contractor, government entity, public employee, or employer shall ask any question
of any person submitting an exemption. So they really can't ask about my medical condition or other than what we put on the official form. And they can't ask about my religious beliefs either. I mean, all of this is personal. Page 6, line 9, there's penalties there. And we went kind of light there, I think. I mean, it's a felony and it's $5,000 and imprisonment of not more than 5 years. There has to be teeth. We have to say, you just can't do that in this state. There's also a provision there, starting on 15, line 15, page 6, that there can be civil cause. We can bring them to court. And we can ask for compensation and injunctive release. As we go on to page 7, the conforming language is here. We did some things when we've had our first COVID session. And so everything here is kind of jumping in here and saying, so for instance, there's liability claims. There's other parts of language in the state law already that we kind of have to come in there and basically says excludes a cause of action filed under. It's got the new statute there. As we go on to page 8, more of the same. I mean, right, you can see it right there on line 5 on page 8. We also did add, so this is existing law. So we're adding medical or religious grounds on line 3, page 8. Like I said, on 14, that's conforming language. On 21 as well, on line 21. As we go on to the next page, we have existing law. We're doing it again there on line 16. We're putting conforming language there. And on the last page, on page 10, the immunity from liability provided in subsections A and D of this section shall not apply to claims or causes of action filed under WS 34140. So we're kind of reversing what's happening, so we don't put people in jeopardy. So in a nutshell, that's the bill, and I think that the key part of this bill really is, or I should say a key part that nowhere else have we seen in any other bills is the shall not ask. So I mean, I think overall the bill has a lot of everything in it as far as saying they can't do it. I think it's certainly a bill that if it made it to the floor, even in its present form, they can choose to amend it on the floor. I mean, they could bring it down as small as they want, but this is the language that we talked when we had the people in committee that testified. So I think this addresses all of the causes that they brought forward. So I'll stand for any questions.
So we're not working the bill yet, but do have questions for Senator Bouchard? I think I had one. Well, I guess I had a couple. So on the bottom of page 4, picking up on line 20. So you're taking a tack there that is different from my approach, because you're basically addressing every business owner in the state.
Well, Madam Chair,
Says no person.
it's because like I had stated, if they want to put a no, if you're not vaccinated, sign up. They could do it at a store, but if you look at goods, facility advantages, and privileges that are public in nature, that invite the patronage of the public or any licensing employment opportunities, it does have that all on there. But I don't think you have a right to any services or goods. I mean, any store can say you can't come in. You don't have shoes, no service.
Right, but so, but if the person puts up a sign that says, let's just pick, I always pick the tattoo parlor because I don't have any tattoos. If the tattoo parlor puts up a sign and says, no vax, no tattoo. This says that that's prohibited because it says you can't refuse a service based on a person's vaccination status. I mean, I'm just bringing that out because that was, I took a different tack in my bill because I felt like, okay, things that aren't really essential, business owner can do what they want if they want to.
Madam Chair, I think LSO did make this broad, more broad than I
Because
was
if it's
looking to do
public,
in
that
one.
seems to
Yeah.
be, we're talking public accommodation. I mean, I take that as being anybody that's open for business where I can walk in. I want to go to the bookstore. I want to go to get a tattoo. The breadth of that is, something that I had tried to avoid in the other bill, but that was my first question. And then, so I guess my second question is just on page 6, line 10. I just really hate to see more criminalization of thing. I mean, I understand him wanting teeth, but it seems to make a person a felon is kind of severe.
Madam Chair, I've said that a lot, but we can't seem to slow down the felony bills on things that don't even matter. This is something that really does matter. I mean, either we say that no in this state, or we just don't punish people at all and they do
You
it
send
anyway.
that poor tattoo parlor owner out to Rollins? That seems pretty harsh. Okay, that's the only questions I have.
Well, Madam Chair, I think you could there's probably a way we could look at it, because one of the things that they kind of mixed in here is, for instance, look at educational opportunities. I've seen testimony from PhDs, which, by the way, PhDs are one of the biggest factions of people who are saying no. And what they used was basically, you're going to tell my kid that they can't go to school. And so that kind of fits in there, educational opportunities. Even on the healthcare part, I've seen the arguments that they use, but if their mask works and their vaccination works, why are they worried about someone else? I mean, and that's because that has been what we have accepted across America.
Okay, well, let's deal specifically with the bill just so we can get home sometime today. Otherwise, LSO will have to pay us for 2 days and we'll have to wait. No, we have a man who wants to testify. We're not gonna, poor man, he's been sitting here for hours. Sir, come on up. You've been waiting so patiently. Just introduce yourself for us, if you will, so we don't have to call you hey you when we call upon you. And there's a button, should be a button right in the middle, and then the
It's
light
green.
should turn green. Is it worked?
Yes.
Good job.
And if I get the titles wrong,
That's all right. Don't worry
things
about
like
it.
that, I apologize. I'm
This time that we're
tired,
all a little giddy.
as we all are. My blood sugar's low and I've had 9 concussions, so I lost the ability to get to the point at
You're a
number
bull
6,
rider?
but I will be as concise as I can be. So is it Madam Chair?
Madam Chairman, that's right.
Madam
Thank you.
Chairman and committee members, thank you for the opportunity to speak. I apologize for not shaving or dressing up. Kind of found out about this last minute and was able to get some time off work to come over and do this. So I appreciate the opportunity. I basically, I can't remember the lady's name that spoke about her.
Oh, the nurse.
The nurse that had the issues. I too would fall into that camp. I was a Moderna vaccine recipient. The reasons that went into taking the vaccine, highly personal. I didn't want to lose my job. I'm a federal employee, so I don't know that applies to Wyoming employees, but also with the change in administration, I'm a shareholder in airlines. My family lives halfway across the country. My intent was to move them out here and make Wyoming their final place to live as well, but COVID has kind of gotten in the way of that. But looking at the health problems that my elderly parents have, I knew that my only option to be as the sole living child to my parents, I knew that I was going to have to rely on airlines. And the prospectuses to shareholders basically said, look, it's likely going to have to be required to fly. So looking at all that, I made the personal decision to get the vaccine, knowing that eventually it was going to cost me my job if I didn't. And also being there for my parents and hopefully being able to get them out here and the ease with transporting myself halfway across the country. Long story short, I got the vaccine in January of 2021. Within 18 hours, the first dose of the Moderna vaccine, I woke up at about 2:00 in the morning after getting it at 8:00 the previous morning. And my joints were basically on fire. Every joint in my body was lit up. I've done stupid things in my life. So osteoarthritis is something that I've dealt with a good portion of my adult life. The military didn't help any of that. But this was something different. Every single joint, every digit on my hand, every toe, anything that moved was on fire. And that did not subside other than the swelling. There was no real reason for it. I thought maybe it was going to be temporary. Madam Chairman and committee, I speak to you today going. Sorry. Almost 10 months to the day, and I'm still dealing with those joint issues. They haven't been able to figure anything out. The VA locally is not equipped to handle the sort of rheumatic type arthritic condition that I was dealing with. So they sent me down to Denver. After about an hour-and-a-half long intake, where the resident that did my intake was basically saying, you're not the only person. You're not the only one that we've seen. We've actually seen quite a few, especially folks, service members that had the anthrax series when they were on active duty. But at least with the anthrax series, they told you were going to feel like, I'm going to filter. I lost my filter with concussion number 6, so I'll try. That you were going to feel like crap. Your joints were going to hurt for a couple months. You were going to not be able to sleep, have migraines, that sort of thing. This was something completely different. So after an hour-and-a-half with the resident, she left the room and was gone for over an hour, had the attending and the chief of the service come back in. And for the next 30 minutes, I was basically told there was no correlation between the vaccine that I had received and, the reaction I had, that I had probably had this condition. No one's refuting that. Maybe I did. Maybe I just, it was never an issue. Maybe something, woke the sleeping giant. So I got the second shot in February, and at the direction of the clinic in Denver, hoping that they could see if in fact the first shot caused this, maybe the second shot would, put all doubts to rest. So long story short, it was like the pain I had, but on steroids. And the condition again, the pain is one thing. Over the course of my life, I've gotten to the point to where I get used to pain. If you've been in the service, you've had your back broken, a variety of other things, you just get used to certain things. But this is something that kind of became overwhelming. I mean, my kids have seen me through injuries that have limited what I've been able to do, but nothing like this. Nothing like trying to pour a cup of coffee and not being able to hang on to the, just the sheer weight of an empty cup. Turning a doorknob, I refused to not shake hands with people. And there's nothing like meeting new people and being brought to your knees. I won't go into a lot of it, but it progressed from just the joint pain to in August of this year, numbness, just complete numbness. Like I could pinch to the point of bleeding and not feel it on my arms and my legs. And the neuropathy, which was under the surface, was so practically unbearable that aside from the fact that I've lost 3 veteran friends to suicide, convincing me that that's not the solution. It's the first time in a long time that I didn't have daily thoughts just because of the limitations and the pain. In September of this year, shortly after the numbness, the complete numbness on all my arms and legs, I started getting a left foot drop. My brain thought that my foot was working, but it would drag, it was falling. Wonderful care in the community. Dr. Armstrong here in town. I don't know if I can say names, can I? Wonderful and a great advocate, but wanted me to get, when I heard the other lady testifying, it's scary because I too was sitting in an MRI tube, getting multiple, lumbar puncture MRIs to try to figure out if I had MS. And if anybody's ever known anyone that's dealt with an MS diagnosis, it's scary as hell. Fortunately, that came back, okay. I've had nerve conduction tests. I do have my nerves are degenerating. They can't figure out why. I've been told everything from, well, you're getting older, these things happen, to, there may actually be some link between this vaccine and what you're experiencing. So ankylosing spondylitis, I'm not sure if anybody, that's the latest of what I'm hearing. It probably is. But the most disheartening thing, Madam Chairman and committee members, is that I'm basically being told this is probably not going to go away. This is probably not going to get better. This is probably not just an autoimmune response to the vaccine. It's triggered something, and like the lady that spoke before, I just wish that, there's it kind of angers me and frustrates me that as I'm approaching 50, that the limitations that I'm going to have, they could have been prevented. I made the choice to get the shot, but the choices were very limited. Be without a job, don't be able to take care of your elderly parents or get them out here so you can actually be a better son. So it was a personal choice to get the shot. No one forced me. No one had a gun to my head. But I just feel like, I don't know. It doesn't really matter what I feel. I see, I've had, neuro workups. I think one of the points that I really want to make, the registries and the frustration that the previous speaker saying that she wasn't able to successfully get things. I was dealing directly with specialists and medical care providers and folks that were working at our vaccine clinic at the VA. I was there when they were typing into, the VA ERS system, the national, I was there when a pharmacist that finally fought to get me on what was the 4th unsuccessful medication to try to treat some of this joint pain that I was experiencing while they were putting that in. As of this afternoon at 2:00, before I came over here for what I thought was the 3:00 hearing, was
welcome to our world.
It's on the CDC or the FDA MedWatch list. There's no male 48 years old in the months of January or February that have there's no listing on any of those federal registries for what it is I've experienced. And so, and it's not just, I'm the fine print guy as Dr. Armstrong has kind of said, you just kind of lucked out when you got this. But I've had discussions online, and that can be scary, but I've also talked to good friends of mine that are experiencing increased joint pains, just a variety of different things that make them, in retrospect, say they would not have gotten the vaccine. And I think what's frustrating to me is as I'm approaching 50, I look at all the different things, other options there are than getting the vaccine to protect against this. I managed to go through the period of time where we didn't have the vaccine without getting COVID, but just being careful, looking at my spacing, picking my circles of friends who also were making decent choices and stuff, at least from what our beliefs were, a variety of different things, working in a healthcare setting. COVID proved that 90% of what I do, I could do from home. But being pulled back into the facility, you know, when I hear about people talking about losing their jobs, you know, over a vaccine, when there's PPE, there's things that even if you've got the most benign job in the hospital, why in the hell would you fire somebody that's got 20 years of experience, you know, serving veterans when you've got equipment, you got PPE that you could wear? Even if I'm sitting at my desk, I don't have direct practice. I don't do direct care anymore. But even in my non-direct care position, rather than, I know that this is spinning off into something that's not pertaining to the actual vaccine, but I would agree with the lady that spoke before. Give folks a choice. I mean, give folks the opportunity to just build their bodies up, take care of themselves, their natural immunity. And I know that's a hot debate. I'm not here to take sides. I basically just know that making good choices, protecting myself with whatever I need to do. And I don't know, I regret the day that I got the shot. And that being said, you know, I picked my parents poorly genetically for a lot of things. My parents both got the Moderna vaccine, barely broke a sweat. And I'm thankful for that. I'm grateful for that. But it's not just me. I could name you 50 different people that I work with over the course of 1,000 population medical center that have had adverse reactions, and they too don't feel like that they've been heard or that it's been documented. And like I said, I sat right there. And if I've got just people in my small circle here in Cheyenne, Wyoming, and then I've communicated with folks in probably a 4-state area here in the Rocky Mountain region, 2,000 plus people that have had a similar reaction to the Moderna vaccine, we're not hearing anything about it. And I think that that's why I wanted to come today, is just because maybe somebody will listen. Maybe somebody will hear. You know I got it before the mandated date. I'm being told that I can't be covered if I miss time for doctor's appointments and things like that because I took it before it was required. So I guess I lucked out on a lot of fronts, but I don't know. I'm rambling now. So
You did great. Thank you very much. Questions for the gentleman, Representative Stivar?
I just want to thank him for coming in and testifying.
And for your service. We have a lot of veteran families here among us. More questions, sir? Yes.
yes, I skipped that part. Sean Butler.
Thank you, Sean. Representative Hallinan. Representative Hallinan, are you
Yeah,
there?
thank you, Madam Chairman. I have a question for Senator Bouchard. As I read this bill,
We're having on Representative Hallinan. We still have the witness at the table. Do you have a question for the witness?
no,
Okay, well, you don't have, wait, we might have anybody else? Oh, that's what that's called. Mr. Butler, thank you so much for coming. We surely hope that you get some relief from your pain. Okay, any more? Mr. Hannes, do you want to say something again? And
Madam Chairman, for the last time this evening, Josh Hannes with the Wyoming Hospital Association. And I want to honor our last speaker and in doing so, my comments will be limited to just the practicality of some of the language in this bill. I can go through the pages, but maybe I'll just pick out some of the highlights. So again, CMS has mandated that employees in healthcare facilities get vaccinated. We've been clear about that. There's a few other pieces in this particular bill, though, that also conflict with that rule that I want to point out to the committee. So on the exemptions, CMS has been very, very clear that the process for receiving and granting exceptions lives within existing federal law. So an EEOC law in the Americans with Disabilities Act, the way that you can grant exceptions lives in there, no more, no less. We can't do anything different in our facilities than what's pointed out there. And I guess I could just leave it at that. I mean, in terms of asking about religious exemptions, I mean, federal law allows for that, and it's part of the process that we have to follow. So Just one additional thing in this particular bill I wanted to point out for the committee. Happy to stand for questions.
Questions for Mr. Hennis? No. Well, I will just say, we know that you and the Hospital Association have been working very, very, very hard for the last year and a half, and we thank you for that. Ms. Declever and Ms. Hart, do you have anything to add?
Madam Chair Committee.
Ma'am.
Same issues that we had pointed out to Senator Baldwin on the last bill. The word of use of the word physician instead of provider twice in the bill.
Well, could you have a page number? Mark them on the other bill.
Excuse me?
That he asked me if I had marked them. I marked them on the previous bill, but so this bill evidently on 1007. But I don't, could you tell me what page number?
Yes, it is on page 6, line 6 and 7. And on, I believe, page 8. I'm remembering, yes, on page 8, line 8.
And page.
And I'm Lori Hart from the Board of Nursing.
Page 8, line 8. So just to clarify, and actually I might ask Senator Baldwin, just because he's seen a lot. So when we wrote the, whatever that licensing bill was called, generic licensing, whatever it's called. I think, did we not want to put healthcare provider? Because, I mean, we don't want it signed by, let's say, a speech therapist or something. What wording do we want?
Madam Chairman, in statute, healthcare provider is listed as advanced practice nurse, PA.
Oh, okay.
PO or
Okay.
MD, so it fits.
Okay. I just want to make sure. Okay, anything else?
No, ma'am.
Okay,
Thank you.
very good, thank you. We've lived so long, we've died and gone to heaven.
Yeah. It's too late for.
Ms. Declever.
Madam Chair, members of the committee, I just wanted to, on Senate File 1007, as I'm reading through this, there's a lot of reference to mRNA. The Johnson & Johnson vaccine is an attenuated vaccine. It is not an mRNA vaccine. So in all of these places where it just refers to the mRNA, that would leave out Johnson & Johnson. Even though on a previous statement, it says any vaccine, as you work through the bill, it just references mRNA. And I just wanted to make that point.
Well, that's good information. Questions for Ms. Declever? Evidently not.
Thank you.
Thank you. Okay. Any further witness? We seem to have run out of people. Oh, there's someone online. Representative Hallinan.
Thank you, Madam Chairman. I had a question for Senator Bouchard. The bill, as I see it, says that the restriction on the mRNA virus vaccine applies only to contractors, contractors and other agencies, but it leaves out employers who are not contractors. Is that by design, or is that something that you forgot to do, or something that we need to address?
Senator Bouchard.
Madam Chair, as we drafted the bill out of what was in committee, it had the stipulation that we're going to do state employees, government employees, and contractors, anybody who took government money. So that has a little bit different stipulation over there than when you flip the page and then you shall not ask. So there are two different concepts in the bill. So if you look on page 4, it talks about no contractor. And if, so it's at the top, it says public employee. And then it goes into contractors, goes into no government entity. Then it says down here, no person shall. So it does really cover everything. No person shall is on, and that's a different concept. Because if you look at the concept up here, we shall not force vaccination. Then when you come down 20, it's it's a discrimination clause. So you shall not discriminate. So that's kind of where this refusing to withhold or deny a person from any goods or services, that's a discriminatory part, which also connects with the part where you can't ask. So I mean, so there's multiple concepts in the bill.
Sorry, Representative Connolly.
And honestly, I see it too as including everyone like Senator Bouchard on page 5. It has each contractor, governmental entity, public employee and employer, and that language is again on page 6, where the definition of employer is on page 3, and that's different than public employee, which is on page 4. So it includes every employer.
Madam Chair, that's a whole different concept there, though. If you look what that says, that's about accepting waiver. So that's a different concept altogether.
Madam Chairman. But I
Representative
think that Representative Hallinan's question was about who does this bill cover? And he was thinking that it didn't include private employers. But I'm giving 2 examples on page 5 and 6 where it's clear that it does include private employers. And it isn't defined on page 3 specifically.
Madam Chair, so on that section on exemptions, it does, it covers contractor, government entity, public employee, employer. So that does put everything, everybody has to accept an exemption.
Representative Hallinan, did you have a follow-up?
Yes, Madam Chairman, thank you. Well, I don't believe that it does apply. It doesn't say that this vaccine is to be mandated or cannot be mandated for private employers. I don't see that in this bill. And I think that's an advantage in this bill because it does cover these government employees, people who get money from the government, contractors, but it doesn't cover employees, except in the exemptions. It does apply to them there. So I think that's a clear and important distinction in this bill. Thank you, Madam Chairman.
Thank you. So Senator, just to be clear then, so, and I think Representative Hallinan is correct that it doesn't prohibit mandates. An employer can mandate, however, they shall accept an exemption request on evidence of religious exception or medical contraindication. If a person doesn't, or prior infection. So if a person was not previously infected, doesn't have a real specifically religious exemption or medical contraindication, and they cannot ask the content of that condition or beliefs, people who fail to come up with some exemption could still be mandated. That's correct? I mean, if a
Madam Chair,
person
yeah.
couldn't come up with any reasoning.
Madam Chair, that my intent was not to get into that legal argument. My intent was to basically discrimination, and you can't ask me about my healthcare.
Okay.
So it was a different, conceptually different, because I think everybody else will go to a different part of the court. This one will go to one where we haven't gone before, and I think it's more of a privacy issue. And then I think what we did on this part over here with the services, even the services is similar to where Montana, where we're trying to be more of a discriminatory bill. And that was happening, by the way, in the hospitals, Madam Chair, where they were identifying people and making them sit in one place. And that's what we heard. We heard, when we visited those towns.
Okay, any more questions for Senator Bouchard? Senator Hutchings?
Yes, Madam Chair. One of the witnesses mentioned the constant input of messenger RNA vaccines throughout the bill. Is the good senator willing to change that to include Johnson and Johnson, or just leave it as that? Because I see you have COVID or the messenger RNA. That distinction, does that include the Johnson and Johnson? Is that the way you wanted to do it? Thank you.
Madam Chair, I think we could maybe change where we're using it in the bill and then redefine it somewhere. So it covers both those things. That the intention was to do what was on page 3 and at line 1. So that was the intention.
Because if they have this, what is it, next one, Novavax or something like that, that they're working on, that's, more of a traditional type of vaccine. I mean, would your intention be to have the bill apply to anything that comes out against COVID, regardless of what the chemical construction is?
Yes, Madam Chair. I really think that everything moves so fast that I think we could always come back and fix it if they, of course, I really truly do believe that as we go on, we're going to all learn to live with this thing. I don't think it's I've personally had COVID, and I've had a variant as well. So I don't think no.
I saw Representative Worf moved away from you there a little bit. We could find one of those plastic things that we had in here for a while. Okay, folks, let's move on here a little bit. Any final questions for Senator Bouchard? Is there anybody pending online, Katie? We're all half asleep, aren't we? Okay. Is there any motion on the bill? Moved by Stiver. Seconded by Worf. Are there any amendments? Senator Murphy.
Honestly, not going anywhere, but I'm going to tie the penalty to the same as one. So on page 6, line 11, change that to no less than $7,500 imprisonment for a period, a misdemeanor, not a felony, sorry, on page, line 10, from felony to misdemeanor. Penalty is $750 and change the imprisonment for a period of not more than 6 months. 5 years in jail just because you ask someone about their status on vaccine seems a little excessive. That's my.
Is there a second? Seconded? Okay, any discussion? Question? All in favor, say aye, or raise your hand. Let's just raise our hands. We can't talk anymore. 1, 2, 3, 4, 5. Okay, that passes. Okay, any other amendments? Did you get that, John or Katie? Okay, all right, good. There's some still awake anyway. Is there any more? Blah, blah, blah. We've been here more than 12 hours now. Okay, I guess there are no more amendments. Okay, Katie, would you take the roll on the bill, please? Yes.
intention was originally that's defined.
Well, and Senator Bouchard, as you generate the question for him, I'm just wondering, is there a reason why it really needs to say mRNA? Why don't we just have it say COVID vaccines, limitations and prohibitions, and delete messenger RNA and insert COVID-19 and just go with that? I mean, that's different than what you brought, but that seems like maybe that's a lot of amendments, but would that harm what you were trying to do?
If we do that and put it in the other places, it is all defined on page 3.
Right, and you could delete page 3, lines 18 through 21, because then it's irrelevant, and then we don't need to know anything about mRNA. I mean, if your objection is just COVID vaccination of every kind, who cares what the chemical structure of it? I mean, if that's what you're getting at, I don't know if it is.
Madam Chair, I think that my thought was, I mean, I would like to say that hasn't, something that hasn't been tested longer, but I don't know, we couldn't define that.
That would be awkward.
So that's kind of where I wanted to make sure that we did, that was my only worry, that if we didn't define what these were, that somebody could come and say, well, they could change it to a COVID-20 or so. I think that the way it looks is the mRNA is the way they're gonna keep going. That's all the testing that they're saying they're gonna do is stay on that technology unless this new one comes out like. So I would rather keep the definitions here, but then just simplify the rest of the bill where it points back where it says any vaccine that is marketed. So it could say, see, and that was the other thing, Madam Chair, when I talked to LSO about it, is what happens if they come back with COVID-20 or 21? I mean, you know what I'm saying? It's a different, they just go up on the numbers, 22, 23, 24.
I think they're going with Greek letters. Mu, lambda, mu,
Yeah.
mu, Omicron, pi, rho, sigma, tau,
But
epsilon.
But Madam Chair, that was the reason to keep the mRNA in there, is so that way in case they call it something else. I thought we had everything kind of covered in the definition. But I don't know whether it helps it when we go and flip through the bill.
Okay, and that question is evidently, all right, are we ready for the vote?
I have a question.
Oh,
Some
Senator
comments.
Baldwin has a.
I just have a quick comment on there. I have a lot of objections to the bill, but the one just comes to mind, we're talking about mRNA. It just says mRNA vaccination. mRNA is now in a field that they're using a lot. They're exploring a lot of things like vaccinations for kinds of cancers. I think it's a mistake in this bill to outlaw mRNA vaccinations across the board. I think that's a step too fast. But that's just an observation. We're talking about a whole technology that may involve a lot of things beyond COVID-19 or 20 or 30 or whatever you want to call it. I think that we've maybe stepped ourselves into something that certainly the legislature doesn't understand. I'm not an expert. I don't think anybody in the legislature is an expert. I think we've maybe stepped our foot in too far. We've gone one step too far in just saying the technology of mRNA across the board. If they come out with something that's very effective, a cancer vaccine would be a good example. Do we want to prohibit that in the bill? So I don't know. I'm just throwing that out there because I think it's a mistake.
Got it. Okay, any last discussion before we take the vote? Okay, Katie, would you do the roll, please?
Madam Chair, this is a roll call vote for committee sponsorship of the draft bill, Senate File 1007, COVID and mRNA vaccines, regulation and restriction. Senator Bouchard,
Aye.
Senator Furphy,
No.
Senator Hutchings, Senator McCune,
Excuse?
Representative LeBeau, excused,
Excused.
Representative Connolly. Representative Flitner. Representative Hallinan.
Aye.
Representative Ottman,
Aye.
Representative Romero Martinez,
Nope.
Representative Seibach,
Aye.
Representative Wharf,
Aye.
Chairman Baldwin,
No.
Chairman Wilson.
No. Okay, so that bill fills out a 6-6 tie, but I'm sure Senator Bouchard can bring it forward as an individual bill and maybe brush off the
Can we-
mRNA.
Can you leave it open until McEwen is found? I think he had technical difficulties with.
He's been gone for hours. I think you maybe work a little more on the mRNA, you know, how to parse that out and bring in Johnson. I mean, you know, it'd be sad if we just prohibit mRNA and then somebody gets the Johnson and Johnson jab. Like, how will that help? You know what I mean? Okay, committee, that is all we've got. And seeing as that's right. Committee, I want to just let you know, those of you who live in Cheyenne, I received an email last week from Bruce Spencer, that guy that testified from the Mountain Health Co-op. And he wants to know if anyone, he's going to be in town again next week. Do we want to have lunch with him when this coming Wednesday lunch? So it really only is a good invitation for people who either live in Cheyenne or over the hill. But if anyone wants to have lunch with him, please let me know and I will.
I am not coming back.
No, I didn't think you